Assume everyone is ready from our side of the table. So good morning, everyone. I want to ask all of us to please turn off our cell phones to silent and make sure they're off the table. Also, everyone, Blackberries, please make sure your Blackberries are also off the table so we can avoid any kind of feedback noise. And again, you might notice that board members are accessing laptops. That's to access the board materials, and which has been provided to them in electronic format. The board, of course, welcomes any public comment on items not on the agenda, and is the board's intent to ask for public comment prior to the board taking action on any agenda item. If for some reason I don't call on you to speak on agenda item and you wish to speak on that item, please raise your hand and you will be called on. And just I need you to always remember to fill out a public comments speaker sheet. I'd like to remind all speakers to complete this presenter's slip and give them to Mr. Einer. Mr. Einer, would you again raise your hand, please, and identify yourself for the audience? Give your slips, please, to him. I will do my best to call upon everyone who has supplied a slip for the agenda item. If somehow I miss you, please raise your hand and I'll recognize you. I want to remind all speakers to please stay on topic and keep your comments to 3 minutes or less. We plan to break around 11:30 for lunch and to set up for our noon speaker, which is agenda item number 17. So we may have to take some items out of order to accommodate presenters. I'd like to call the meeting to order and ask that Mr. Einer please call the roll.
Dr. Bishop?
Here.
Dr. Carrion?
Here.
Ms. Ching?
Here.
Dr. Diego?
Here.
Dr. DeRusso?
Here.
Dr. Gonadev?
Here.
Dr. Levine?
Here.
Dr. Lowe?
Here.
Dr. Salmonson?
Here.
Ms. Shipsky? Ms. Yaroslawski?
Here. Thank you. We have a quorum. So I'm going to, I have the following speakers' slips, but before we have public speaking, let's have an introduction of a special guest. I'd like to take this opportunity to introduce the new Deputy Director of the Department of Consumer Affairs, Rachel Everhart. She was appointed on January 11th as the Deputy Director for the Board and Bureau's Relations. Ms. Everhart has been a Senior Advisor to the Director of the Department of Consumer Affairs since 2011, and prior to her service at DCA, she was for 5 years Chief of Staff to Assemblymember Kathleen Galliani. She has served in a variety of other capacities within the Assembly as Legislative Director, Analyst, and Staff to various Assembly members since 2000, and before that as a field representative in the Central Valley from 95 to 99. I want to welcome you, Ms. Everhart, and ask you to please come forward and say a few words.
Good morning. Good morning, everybody.
Good morning.
As you heard, my name is Rochelle Everhart, and I'm newly appointed by the governor to be the Board and Bureau Relations Deputy Director, and I'm looking forward to it. And so what I'm trying to do is go to all the board meetings I can and meet all the board members, and if there's any concerns or questions you may have about any issue related to working with DCA, don't hesitate to contact me or let Linda know and she'll contact me, and I'd be happy to help. That's kind of what I'm trying to draw from your experiences to know what it is that we can do to help you and what works and what doesn't work. So I appreciate the time and thank you very much. And does anybody have any questions? Okay, thank you very much.
Thank you very much. Good. So we're going to go to public comment on items not on the agenda, and I have 2 speaker slips. And I'd like to call on Julie D'Angelo Feltmas to come forward, please. Remember the 3-minute rule.
Good morning. My name is Julie D'Angelo Felmuth, and I'm the Administrative Director of the Center for Public Interest Law. For the benefit of the new members, CPIL is an advocacy and academic organization based at the University of San Diego School of Law. And for 30 years, CPIL has been monitoring California state agencies that regulate business, professions, and trades, including the Medical Board. I also served as the Medical Board Enforcement Monitor from 2003 to 2005, so I know a good bit about the Medical Board's enforcement program. And I want to thank Dr. Lowe, who chairs your enforcement committee, for his good work in trying to get the Medical Board investigative staff and the Health Quality Enforcement section of the AG's office on the same page in compiling and reporting to you enforcement data. Thank you, Dr. Lowe. My comment today relates to a complaint that was made to the governor last fall by Public Citizen, a Washington, D.C.-based public interest organization. Last year, Public Citizen mined the data in the National Practitioner Data Bank, which is a national database created by the federal government to track licensing, discipline, malpractice payout, and hospital disciplinary actions against doctors. A number of entities, including state medical boards, insurance companies, hospitals, and HMOs, are required to report certain information to the National Practitioner Data Bank, and the goal is to prevent physicians from roaming from state to state, lying about their record, and getting licensure in a new state. So last fall, Public Citizen alleged that this board had failed over the last 20 years to take disciplinary action against a good number of California licensed doctors who had been disciplined by hospitals through the peer review process and had been reported to the National Practitioner Data Bank. You may have seen this. It was in a number of papers. This was of concern to me because we know that doctors who run hospitals do not lightly take disciplinary action against their colleague physicians. Public Citizen also reported that about 100 of these doctors were labeled imminent risks by the hospitals that reported them to the data bank, but they were not disciplined by this board. The governor's office was concerned, and your staff did an analysis of Public Citizen's allegations, and according to the minutes of the October 2011 board meeting that you approved yesterday, 2/3 of the cases reported by Public Citizen were past the statute of limitations and had been purged due to this board's retention requirements. Frankly, that doesn't make me feel any better. What I also learned is that your staff only queries the data bank at point of initial licensure. It does not query the data bank every 2 years upon renewal of a physician's license. If it did, it might have picked up some of these hospital disciplinary actions before the statute ran. It costs $4.75 to query the data bank. That's the cost of a cup of coffee in today's world. And I think that fee could be added to the physician's renewal fee, and you would have better access to that data bank. What also concerns me is that the decision not to query the data bank every 2 years upon renewal was apparently made by staff, and it was probably made many, many years ago. I've been attending this board's meetings for 25 years, long before the data bank was ever even created, and I have never heard this board discuss the National Practitioner Data Bank, much less make a decision not to use it. I encourage you to look into this issue as a board matter. Have staff do a cost-benefit analysis of what it would cost and what good you would get out of an every 2 years query. Hospitals are required to query the data bank every 2 years when they renew privileges, and I believe you should too. One last comment. I cannot query the data bank about my doctor. The data bank is not open to the public. I'm counting on you to do that for me as part of your public protection mandate. That's what the data bank is for, and I encourage you to look into this issue. Thank you.
Thank you very much. Tina Manassian and Jack French, would you please come forward?
Good morning, Madam Chair. Tina Manassian, representing Consumers Union Safe Patient Project.
Good morning, Jack French, Safe Patients Project.
Several of us met with Ms. Whitney and Ms. Kirkmeyer 2 weeks ago, and we want to let this committee know about concerns we have with the appropriate oversight and safety of outpatient surgery centers, which you were discussing today, and we have 3 areas of concerns. 1, opportunities for consumers to interact with NBC, and we asked the NBC to teleconference all NBC's public meetings, including committee meetings, meaning that the public can listen over the phone and provide public testimony over the phone during public comment periods. Numerous other agencies do this, including the California Healthcare Acquired Infections Committee and the California Health Benefit Exchange. They are both governed by the Bagley-Keene Act, and we ask that NBC request that DCA, Webcast, all of NBC's public meetings, make clear on its website the opportunities and rules for public participation in NBC meetings. And our second concern is the statute of limitations that governs patient complaints with the NBC. While we believe that the statute itself is flawed, the NBC's website adds insult to injury by offering confusing information to patients who are trying to understand and comply with deadlines for filing complaints. This has resulted in the NBC refusing to review complaints that patients believe were filed timely. We supplied NBC staff with some problematic examples of unclear and misleading communications on its website related to the statutes of limitations. We asked the NBC to clarify the information provided on the website in brochures and on the forms, and immediately notify the patient involved with the NBC, and immediately notify the patient involved when NBC learns of an alleged improper act or omission by a physician from a source other than the patient, which triggers the 3-year statutes of limitations. And when a patient makes a complaint to the NBC, explain the statute of limitations and inform the patient how much time is left before the statute of limitations will run out in their case. Further, the NBC should advise patients as their complaints are making the way through the process as to whether they are in danger of going over the statute of limitation time frame. And number 3, the implementation of SB 100, we asked NBC to include on its website historic information about outpatient settings violations that have been noted by accrediting agencies in the past, and work quickly to coordinate a clear process with the Department of Public Health regarding reporting of adverse events, including getting CDPH to notify the NBC when such events are reported or fines assessed, and make this important patient safety information available on its website. Where appropriate, NBC should investigate whether the adverse events involve physicians' misconduct. Communicate to California physicians that they must now report adverse events, and if they do not do so in a timely manner, they can be fined. We have provided detailed follow-up correspondence about all of this with Ms. Whitney for distribution to the board members. The Consumers Union California Safe Patient Network looks forward to working with staff and board to open up opportunities for consumers to participate in NBC meetings and to increase patient safety in California. Thank you for your consideration.
Thank you. Mr. French, did you want to speak as well?
No, thank you.
Thank you. So we're going to move on with the agenda items and move to, I'm going to take something out of order. Ms. Harold, who's here as the Executive Director of the State Board of Pharmacy, has requested that we take up her 2 agenda items early so that she may be able to get back to Sacramento in a timely fashion for a meeting she has there, midday. So I wanted to move the agenda, to agenda item number 26 and 27. And Ms. Harold, please introduce yourself and welcome.
I'm Virginia, or I go by Jenny Harold. I'm the Executive Officer of the Board of Pharmacy, and I'm very grateful for your accommodation to move me forward. Thank you very much. I appreciate it. Part of the reason that I'm here today is that the Board of Pharmacy is awash in regulating a profession that is suffering from severe drug diversion from pharmacies. We have had, regrettably, we're in trial right now on 2 pharmacies, for example, one of which lost 1.5 million pills, Vicodin, and another which lost 2 million. And lost means you had someone working inside that was diverting the drugs. The pills are worth anywhere between $1 and $10 a piece. We are very rigorous in watching our pharmacies to make sure that this doesn't occur. We have mandatory reporting requirements, as does the DEA for controlled substances. But last year, Assemblymember Hayashi had a bill in, which was AB 507, which was chaptered. That bill was sponsored by the American Cancer Society in the belief that patients are being denied adequate pain treatment, that when they go to your prescribers and when they come to our pharmacies, they're being overregulated and denied access to medication they need for pain relief. In some cases, that may be the case, but we are so awash in drug diversion at the Board of Pharmacy side, we think that it's appropriate to take a reflective look at what's going on out there, educate our practitioners better, work with your prescribers better to find a means by which there's better pain treatment for our patients. No one in this state should be deprived pain management because they can't see the right physician or they can't get the right quantity of drug. Incumbent in all this, and there's various pieces, in 1994 the Department of Consumer Affairs brought together principally the Medical Board and the Board of Pharmacy and convened a pain summit. That was 18 years ago, and despite the cover memo which I gave to my board which said at least 10 years ago, I think I'm trying to shave a few years off my tally here in my chronology, but nonetheless it's been 18 years. And you see a copy of the pain management monograph that we produced, written by experts in the field of pain management, that was 18 years ago. Over the last couple of years, I've been approached by various people suggesting that it's time to revisit the issue. And the Board of Pharmacy could do it on its own, but it doesn't have nearly the impact it would have for California patients, that if we joined with this board, working to help educate your prescribers and our dispensers so that they know how to work together and use the available resources that are out there, and that they know the state-of-art technology or medication therapy so that they can better care for patients, so that we don't have bills introduced aimed at assuring that patients have access to pain drugs, because that shouldn't be necessary. So with that said, that's kind of the proposal that I bring to you, that we would like to work with your staff in establishing a pain summit. We have various pieces that we think need to be part of it. The medical board may have various pieces that they think are integral to it. I think that there are other healthcare boards that may want to be part of this, but I think that it's principally the main prescribers in the medical board and the dispensers through our licensees that are the main point of contact that we need to resolve. So in that vein, I'm here to respectfully request that you authorize your staff to work with our staff in developing a concept for a pain summit perhaps later this year. I can tell you I've been approached by various entities already that are very interested in doing this, and I don't know what format it should take, other than I think we need to have a summit or a portion of it on the cures reporting system and the reports that are available to prescribers and pharmacies, so that you can see a profile of the patient in front of you at the time of dispensing. And that is not meant to deny pain treatment as much as it is to facilitate optimal pain treatment. And I'll talk about it in a minute, the cures program, because I tend to lay too many issues out on the table at once. So that's one issue. The second is that in our case, we strongly think that prescribers and pharmacies need to have a dialogue on how they can communicate better. When a pharmacist calls a prescriber to inquire about a patient's treatment, frequently it's not well received. Our dispensers are hesitant to make those calls, but yet we hold them responsible under corresponding responsibility, that if they dispense drugs that they shouldn't have because they didn't make the call, they didn't inquire, they didn't find out why this quantity of drug or why this unusual drug therapy was being prescribed, we will discipline them. And right now we are, as I say, part of those cases that I'm talking about, not so much the diversion cases, but we've got a couple of cases where in Los Angeles we have a pharmacy that filled prescriptions from several of your physicians that you've already disciplined, where we had at least 3 young people in their early 20s die of drug overdoses that had been prescribed and dispensed. And part of that may be inevitable because doctor shoppers will exist. But if you use the cures program, we think that that will help reduce that. So anyway, that's one outcome. The other is that we would like to do some educational pieces for long-term, what's state-of-the-art current thinking in pain management. And we have access to various experts throughout the country, and I suggest we use those to develop something that will lend to better patient care. So that's my pitch on the Pain Summit.
Thank you, Ms. Harold. Your board is very active, and we appreciate you coming to our meeting, and I would like to suggest that we can have some discussion first on the presentation, or we can have a motion to direct staff to work on a possible fall 2012 Pain Management Summit. with the State Board of Pharmacy. So whatever, Dr. Levine, you had your hand in the air first.
I was just going to ask you something, that is, can you also work with California Pharmacy Association, California Medical Association? These are the entities which handle doctors and pharmacists.
We strongly are going to need the support of our associations as well as a number of other practices. For example, the Board of Registered Nursing, or the nursing program right now, has nurse practitioners that also prescribe. And so there's other players out there that we need to bring into part of this. But right now, we're trying to just kind of get a general agenda that we can start working with and then ask for output, or input and output from various entities, how we're going to do it, where we're going to do it, how expensive is it. And we need the support of everyone to do this, because by being exclusionary, we're not going to get anywhere. It's a difficult topic, and there's a lot of pieces on it.
Dr. Levine?
Thank you very much. Do your comments mean that you're confident the Cures program is going to be funded?
I can't predict how this is going to go, but let me talk for a minute on Cures, and maybe this will help. Last week, Susan Cady joined me and two of my key Cures staff people. We met with the Department of Justice, and specifically the people that are currently trying to Band-Aid the Cures program to get it to operation. There is no direct funding for it per se. It's funded through grants that the former Bureau of Narcotic Enforcement would get, which was how they chose to pay for the program. They think that they can, short-term, continue to direct staff to run this program, and in fact, they think they can eliminate the outside vendor that's there, bring it in-house, and run it more efficiently without, for your prescribers that are dispensing full dosing regimens, you are able to fax in things. I've got bad news to tell you that those are going back in boxes. They're not being input into the system again, which was part of the reason we had a triplicate problem about 10 years ago. But the old program staff is no longer there. The people that now have the program, when they met with us last week, I will tell you, said the right thing. They understand data. They understand why you can't ignore inquiries that are coming in, why you have 200 boxes of forms sitting somewhere, which is what we were told. And they are trying to scrap together staff to keep the program running. Long term, I don't know what's going to happen. They say they have the strong support of their boss, the Attorney General, but where this ends up, we don't know. If they are unable to continue the support for the program, I would strongly encourage us to, again, work together, both the Medical Board and the Board of Pharmacy, to find a long-term solution to a prescription monitoring program like Cures. I will tell you the DEA is concerned because now they are setting up programs that run across state lines to help ensure doctors and pharmacies along border states don't have problems. And there's also internet pharmacies. There's prescribers in one state dispensing to patients in another state, and there's all kinds of ways around this. So we see great value. One of our priorities is to make sure the Cures program continues. We funded $1.5 million early on to do this because the Department of Justice was then a little recalcitrant in moving forward. They haven't operated the program, with all due respect to the Department of Justice, with the way that it should have been run in the past. And my assessment, and I don't know if Susan Cady wants to get up and discuss this, but my assessment is they've got the right people because they were saying the right thing. It's the first time I've ever said that about this program.
Thank you very much.
Okay, so how about if I have a motion to direct staff on working on a possible fall 2012 pain management summit with the State Board of Pharmacy? Do you have a motion?
So move.
Do you have a
Second.
Okay, now let's have some discussion on that motion. Okay. Do I have some public comment on that motion? I have Yvonne Chong. Would you like to speak to that motion?
Good morning. I'm Yvonne Chung with the California Medical Association. We would greatly appreciate being included in this effort as well. We also wanted to update the board that this is a high priority issue for us as well. We currently have a group within the California Medical Association of pain management specialists and other physicians that are working on developing, I guess you'd call it a physician advisory for your average physician, not your pain management specialist, as to how they can appropriately prescribe prescription opioids, trying to take all the information that's being put out by the FDA, the DEA, other states in terms of guidelines, and trying to develop some standard of best practice that physicians can follow. So as much as possible, we'd like to be included at the front end of this project. Thank you.
Good, thank you. Any other public comments on this? Do I have any, Dr. Lowe?
You know, I think this issue is relatively complex. It's not a simple issue. I don't think anybody is interested in denying patients medication for pain if we know that they have bona fide pain. The problem is that there is no pain meter. We don't have a meter that says this patient is having pain, so he gets medicine. The patient tells us he has pain. And, you know, I don't have a problem with cancer patients getting pain medications, but, you know, it's much more complex when it comes to chronic pain from, you know, fibromyalgia, from back disorders, where you can't identify any objective finding to account for their pain. And so it's a very complex issue, and I think that the most important thing in my mind about the management of pain patients is trying to find the source of their pain and seeing whether or not the source can be addressed rather than just to treat the symptom, which I find far too often is done because that's the easy way out. So it's not a simple problem. It's very complex. And in terms of funding for the Cures program, can we not have something like a cigarette tax, a tax on pain medications? What's the difference? I mean, if you get the medicine and it has to be regulated, you have to pay for it. So we put a surtax on pain medication. It won't be a large amount, but it'll be enough to fund the program, which is essential for us to be able to practice, you know, good medicine.
California, I will tell you, is one of the few states that does not have a separate registration for those that prescribe and dispense controlled substances. So there, as you say, is a potential area for possible funding for the Cures program right there. But that would require legislation, and it may not be warmly received because that will be creating a fee in this economic climate. But a lot of other states do require their prescribers and their dispensers to obtain a separate state registration specifically for controlled substances.
California requires that to renew your medical license that you're current in CME for pain.
You may have already addressed a portion of it, and maybe
Is not addressed by many of these other states.
that's true.
Okay, Dr. Diego?
So it's a little concerning to me to hear that in this time and era of electronics, we're relying on data input and that some of that information is stuck in boxes. I certainly hope that with this summit, we're moving towards electronic. I know that there are a lot of concerns that there's danger there in electronic, but it seems that it's still better than somebody doing data input and then boxes staying in the back of somewhere, because then communication between the prescriber and the pharmacy would be more accessible. I know that the federal government is trying to move in towards having controlled substances being able to be prescribed electronic. I certainly hope California can move in that direction for sure.
Okay, I want to remind the board that we were active participants, not with the pharmacy board, but while I was on this board, on an intractable pain task force by which we had all of the interested parties come together for several meetings where we tried to develop a protocol and appropriate information to be put out there into the community as to what was appropriate method of prescribing. It wasn't so much the quantity, but the method. I think that what happens and what we see in our cases as well is that the people that are falling between the cracks, that are getting medicine in great quantities, as well as those that are prescribing in great quantities, might have forgotten what the tools of the trade are as far as what they're supposed to do and what their responsibilities are as far as prescribing in general, starting with a good faith exam. So I would look forward to, Dr. Simmons, I would look forward to the opportunity with this summit going forward to really try and crack this nut once and for all participants. So I want to thank you for your efforts on that. So I apologize. I thought, Dr. Simonson, go ahead.
Well, when you said good faith exam, I just have to echo what Dr. Lowe had said, where pain is like an additional quote vital sign, but it's certainly not as objective as a blood pressure or temperature, because if
Right.
a patient's saying I have a 9 or a 10 and can sit here calmly and somebody else is writhing and says they've got a 4. So it is extremely complex, and I do welcome the summit to try to sort this out, but it's...
Ms. Chang?
Well, I'm very happy that you're doing this, because I think the new trend is pain management is coming up. I believe the federal government is asking to educate either the public and the doctors, and they are giving out grants. For the grant is actually require the pharmaceutical companies to fund it, the educational piece. I sit on the Federation foundation, and then we have a combined project with the Federation itself on the opium books and an overall problem. And I would like to be having our staff member talk to you about part of your portion, your educational portion about your summit, because they know we have lobbyists in Washington. They know all the current laws, and they follow up, and we're actively doing a educational piece. So I'll get your card.
I'll give you my card, yeah. Okay. Thank you.
Dr. Ganadev?
I just want to make sure I emphasize again that in my previous life with CMA, I've seen experts. These are very good people. They're pretty passionate about pain management. I'm sure same thing with the Pharmacy Association. So use their skills to get where we want doctors to go rather than not use them.
Okay, do I have any other comments either from the board or from the public? Dr. Lowe?
One question. We have Dr. Bishop, who's an anesthesiologist, and pain management is now a part of, in many places, of anesthesia. It seems to me that the people involved in pain management are most interested in interventional pain management with injections and things like that, rather than the prescribing of chronic pain medications, which they would like to send back to the primary care physician.
Right.
So that makes it, even more complex, because these pain specialists, who are probably the best ones to assess these people, aren't the ones doing the prescribing.
They're also not the ones getting in trouble, probably.
Well, I can comment.
Oh, about getting in trouble, Dr. Bishop?
I agree that the interventionalists are very much involved in intervention. But part of the intervention is that we know that, except in the case of severe cancer pain, escalating doses of narcotics are absolutely contraindicated in the care of these patients. It's a never-ending battle, and it doesn't help. So part of their intervention is to attempt to detox these patients from these high doses of narcotics, which really are not doing much anymore except just feeding a habit. So I think that what you say is true. However, that is a part of the intervention. So I think that perhaps I have some ideas that I don't think we should talk about today, but about ways we can use these people to perhaps help with this problem. And I did have a question. You alluded to the fact that we had 2 pharmacies that were together 2.5 million doses of narcotics. Now that sounds like a lot, but we have a lot of prescription, we have a lot of providers prescribing. Would you suggest that 2.5 million pills is a large or a small percentage of the drug dosing that is being diverted and or inappropriately used in this state?
I hate to think we have very many pharmacies in this state sending out the back door that quantity of drugs.
I mean the physicians, like physicians over-prescribing. Would you say, since there's 25,000 physicians perhaps that prescribe, would the cumulative effect of those people over-prescribing exceed 2.5 million pills? I'm trying to
I have no way of knowing.
the problem.
I can't estimate that. That I would defer to your judgment. I don't have the expertise there. But what happens is then you get the DEA, the FBI, the Board of Pharmacy, local law enforcement coming into these areas and clamping down controls. Other pharmacies in the area see that, and they start getting anxious, and they refuse to fill controlled substances prescriptions, which then impacts patients. And that's what we need to take care of the diverters, because that's why we're in business. But then to assure that those that are practicing good pharmacy and those that are prescribing appropriately for care of patients can continue to have access to these drugs, so that they're not so overregulated that you cannot get them out of a pharmacy.
Absolutely. I'm happy to discuss my thoughts offline as well. So
I'd love to. I'll give you a card. Thank you.
Thank you.
Ms. Whitney?
I just wanted to let you all know that Ms. Harold did approach me with this idea because her board president was very interested in this issue, and we together talked about it and thought it would be great effort for our two boards jointly working together and then reaching out to the stakeholders. We have not had a strong partnership in the past few years, and we are working together to develop that strong partnership. I will be attending the pharmacy board meetings as appropriate to let them know that we have that partnership should you move forward with this recommendation on the pain management. But we want to form a strong alliance with the pharmacy board because there's so many things that interact between the two boards that we need to be on the same page. So I hope that you know that the staff does look forward to working on this effort should you approve this motion.
Okay, so we have a motion on the floor as well as second. May I have all those in favor please say aye?
Aye.
Any opposed? Okay, so that is done. Thank you very much.
Thank you very
Anything
much.
else that you'd like to present to us?
No, I just want to share the importance that we feel for the Cures program, which I also heard out of you. And we've also heard from the new, at least temporary, people that are running the program, that they are no longer going to accept those paper transmissions, but I don't know how they're going to deal with it. Our pharmacies are not getting confirmation back. One of the most basic things they do is they peel off the data every week off a computer. They're not getting verification back that that data's been received. And with 6,500 pharmacies in the state, that's a lot of data that's not being recorded appropriately. So in the case of a prescriber, I don't know what verification you get back when you send in that information, even on a piece of paper. So I think we're going to continue to work with the Department of Justice to make sure the Cures program operates functionally, at least during the M until there's a long-term solution. So.
Thank you.
Thank you so
very
much, and
for
thank you
coming,
for
Ms.
the
Harrell, and
accommodation.
Thank you. My pleasure. Have a safe drive back to Sacramento.
Thank you.
We're going to return now to agenda item number 8. Dr. Lowe, would you please present on actually 8 and 9, the physician assistant and enforcement committee updates?
Okay, the Physician Assistant Committee update is that a new chair and vice chair have been elected. The chair is Bob Sachs, who's well known to the committee and is a PA at USC. Steve Klompus was the former chair and is now the vice chair. The PAC is working on a regulation pursuant to AB 2699, which allows out-of-state licensees to offer their professional services at sponsored free health care events. The PAC will discuss the regulation and language at the February 6th meeting. The committee is also considering amending the regulations regarding the interpretation of the, quote, personal presence of the physician as well as the scope of practice of a PA. Since this regulation involves the scope of practice, it will need to be promulgated by the Medical Board of California on behalf of the PAC. At the next meeting on February 6th, the committee will review the final draft language, and if approved, then bring it back to the next medical board for consideration. The committee is also working on amending the disciplinary guidelines in order to incorporate SB 1441. And finally, the committee approved the final 2012 Sunset Report, and it will be submitted to the legislature by the requested date. The Sunset hearing is scheduled for March 19th, and our chair and executive officer will be attending. Ms. Whitney will be discussing the medical board sunset review process during her report, so if you have any questions, you can ask her at that time. And finally, the executive officer has been very effective at coordinating her staff to deal with the licensing backlog that occurred because one of their staff members I believe, retired. In any event, now that they're able to fill that position, a new employee has been hired and will begin on February 6th. That concludes the report from the PA committee.
Thank you very much. Would you like any questions on Dr. Lowe's report? So would you like to continue on to your enforcement committee update?
Okay, the Enforcement Committee update. The Enforcement Committee had a meeting yesterday during which I provided an update of the subcommittee's activities. As you recall, at the last board meeting, we learned that the Medical Board and the Attorney General's Office maintain data, but they do it independently, and the data doesn't match completely. and it's because they calculate it differently and manage it differently. So one of our primary purposes is to resolve that problem. So to that end, we had several meetings, one of which occurred on January 3rd with the medical board staff, and the second meeting occurred on January 9th with the medical board staff, myself, and importantly, we had Mr. Carlos Ramirez and Ms. Gloria Castro from the Attorney General's office, and they came up from Los Angeles, and it was an extremely productive meeting. So it was decided at that meeting that the Health Quality Enforcement section of the AG's office, that their supervisory staff and the supervisory staff of the Medical Board of California would meet to reconcile the previous month's statistics. So every month we'll meet and reconcile those data. So the AG's office agreed to provide monthly reports from their case management system, and Ms. Sweet from our enforcement section said that the Medical Board of California staff would provide specific case activity reporting forms to the Health Quality Enforcement section of the AG's office. After each district office and the AG's office reconcile the data, one single report will be provided to our board. So we will no longer have two separate reports. So that's, I think, tremendous progress. So on January 18th, there was another meeting between the AG's HQES section and our medical board staff to facilitate the implementation of this new procedure, which I understand is now happening. Mr. Ramirez explained that he previously provided data to the medical board, but it was difficult for Ms. Whitney to use this data because it was in a format that was inconsistent with how we keep track of things. So in the end, it turns out that we will be getting reports from the CMS section of the AG's office that will meet the needs of the medical board. So the CMS is the entity within the Department of Justice that's responsible for the preparation of the reports reflecting the statistical data. Currently, they're trying to program a report that will attach also the attorney billing on a particular case that we're very interested in. So as an aside, on January 23rd, the medical board staff met with the Department of Justice CMS staff as well as with Mr. Ramirez and Ms. Castro, and made requests for these specific reports. Also at the January 9th meeting, we discussed the need to incorporate the median as well as the mean times for this data that we collect so that we can better understand the outliers. I suggested that the outlying cases receive independent review so we can understand the causes for inaction and remedy the situation as soon as possible. We discussed other miscellaneous items relating to case aging, such as the Department of Justice wanting to acquire the ability to hold cases in abeyance during the pendency of criminal prosecution, something that the medical board already does. And this way, the cases won't age further while that process is going on. And so while the data may not look as good as it really is, these changes would better reflect what's actually going on. So Ms. Castro also reported that the Los Angeles office of the HQAS are under orders to not slow down the investigative process, particularly when scheduling of interviews and the review of expert packages is in conflict. So both agencies agreed to provide reports that may be of value to assist reconciling data and sharing information. All in all, I think the subcommittee has been amazingly productive, and I think that we're well on our way to resolving the problem. When we receive an update on the expert training, we received an update on the expert training project from Ms. Sweet, who's put in a tremendous amount of energy in organizing something that I think will be very important. I think standardization amongst experts will reduce variation, improve quality and efficiency, so this is a very high priority project. The first expert training meeting should occur in April. We'll have them in the North State, the South State, and in the very South State. Most of the training is finished except for the last-minute modifications. It's just a matter of coordinating the schedules of the different presenters. And I believe the first one will occur in Sacramento at the UC Davis School of Medicine. So this is an exciting time for us. That concludes my report.
Dr. Lowe, I can't thank you enough. I hope all the members around this table, as well as the members of the public, and especially from the Department of Consumer Affairs, realize what a milestone we have finally gotten to. Unfortunately, the press has an opportunity to write whatever they want without any kind of background material and just put stuff out there that freaks everybody out, and everyone's convinced nobody's doing anything but eating bonbons all day, which is what happened a few months ago. I want to thank Dr. Lowe for his leadership and Ms. Whitney for her participation and active engagement with staff, as well as Mr. Ramirez for finally coming to the table and realizing that this is not an unfixable problem. This is not an issue that we can't deal with, but we need to know what's going on. So, Dr. Lowe, I really can't commend you and your energy enough, as well as Ms. Whitney.
Well, the credit really has to go to the medical board staff and to the Attorney General's office, and the fact that we all feel this urgency to do the right thing and to make enforcement better and more efficient.
So thank you for stepping up to the plate and making sure that that happens. And thank you to the staff as well, and Mr. Ramirez, to your staff as well. Thank you. We're going to move on to item number 10 and ask Dr. Salmonson to please present on the licensing committee update.
Mr. Warden provided an update on...
Excuse me, could you use your microphone?
Sorry. Mr. Warden provided an update on staffing in the licensing program, and deficiencies are being filled, fortunately. Still some openings, but there's a strong plan in place. Then Mr. Warden and Mr. Salgado provided updates on following the business process reengineering recommendations. Some of the highlights there would be revision and streamlining of the physician and surgeon application process, improvements on the website relative to the application process. There's still some decision-making regarding the postgraduate training authorization letter process, whether it will be a separate process, and also revisions of the policy and procedure manual. Another big project that has come, at least a portion under licensing, is implementation of SB 100, which is the outpatient surgery center requirements. And one of the features will be that the status of the outpatient centers will be on the board's website. At this point, the way, again, the data has been provided is you can't, at this point, look up a list of certified centers, but the public ultimately will be able to look it up themselves. But in the short run, if they have a planned procedure, should call the board. I'm sure they're not going to love that, but the information is available. So we're eager to proceed quickly with this for patient safety. And that concludes the licensing report.
Thank you very much. Any questions on the licensing report? Okay, we will move on to the Federation of State Medical Boards update. Ms. Chang, please present, and then Ms. Whitney, if you have anything to add.
Okay, I actually never talked much about the foundation of the Federation State Medical Board. It was an endowment set aside by the Federation and set up a 501(c), and there were a set of money, and then we do projects. I'll talk two of the projects that they're really working on right now. Give me 2 minutes, okay?
Take your time. I'm here all day.
Well, one of them, we just funded a small project with Washington State. Washington State Board, they becoming a autonomous board by themselves. They report directly to the governor. They are no longer with the Department of Health and Human Services, and they need to justify their existence or whether they're doing a good job or not. From their own records, they look fine. We have the assessment data and showing that they can do the cases in such time, they finish the investigation in such time. So all the parameters are put in there. And right now, we're in the final stage. We're just funding it for them to finish the study. So that is one project that the foundation is doing. And the other one is, I know Barbara always talk about scope of practice and all that, or best practice. And this one it's in the discussing stage, and in concept is being accepted that we're going to do it. It's a best practice for the investigators. It's not the best practice for the physicians, but for the investigators. And this will be a 4 joint project with the state of Alabama, state of North Carolina, and 2 other states. Arizona was the other one. And they wanted to put out their best practice and for us to evaluate. And it's an educational piece. Foundation is an educational instrument for the Federation. So that's the 2 main projects that's happening right at this moment. Now, I should talk about the Federation's coming 100-year celebration annual conferences in April. And the chairman of our board always showed up every year with some staff members, if it's possible, to go to the annual meeting conferences. And I believe Barbara is going this year, and I'm on the board, so I will be there. It's usually a 3 to 4 days conferences with various education topic. And I would encourage all of you to come. You can room with me. Some of you can, not all of you. It's a great opportunity, but this year is the biggest one of them all because it's a 100-year celebration. So it will be fun. It'll be in Dallas. It's the end of April. So I'll send out the date for all of you. Thank you. Linda.
Ms. Whitney, do you have anything to add?
I'd like to update the board on a number of things that we're doing at the office and working with the Federation. I participated on the work group to define minimal data sets. Our final meeting was Tuesday, January 31st, to discuss comments provided from the other boards on the document developed by the committee. This report will now go to the Federation board, then the reference committee, and it will be presented at the full membership meeting in April. Over the past 2 months, we've held a couple of teleconference meetings with the Federation staff regarding the new USMLE validation process that may hold up the release of some scores for physicians. The Step 3 scores could be held up for a couple months. We have notified our program directors and are working very closely with the Federation staff to monitor this, so all who need licensure by July 1st will have their scores in plenty of time. On January 25th, staff at the board participated in a webinar presented by the main board regarding a proposal similar to national licensure. We will continue to track this issue and continue to report back to this board. We have assigned a manager to track the Federation pilot project on maintenance of licensure and will provide updates at future licensing committee meetings. This will include tracking what ABMS is doing regarding maintenance of their certificate too. The Federation Foundation is surveying boards regarding members and staff being targets of violence. Results will be shared with you in the future. Other reports being completed by the Federation staff for presentation at the annual meeting are a report on physician re-entry into the practice of medicine, guidelines to physicians and state boards on the use of social media, and a report on the composite action index and summary of state board actions. And this is the summary that's put out each year on statistics from all the various boards. So that's what's coming up with the Federation. Thank you.
Thank you. Are there any questions about this report? I'm going to move, Dr. Levine.
Yeah, just a question, Linda. In terms of the issue of physician re-entry into practice, does the medical board or the Federation have any sense of the size or scope of what that population is? How often does this come up?
Obviously, it's coming up more frequently than it has in the past. We don't know the size of the issue, and different states are reacting differently. As an example, in your disciplinary guidelines, you basically say if someone has been out of practice for 18 months, then they have to take some remediation courses in order to re-enter the practice of medicine. If someone has not renewed his or her license for up to 5 years, then there isn't any examination whether that person has been practicing or not. But after 5 years, we do look at that, and on case by case may require different types of remediation. Some states say if you've been out of practice for 2 years, you have to take certain remediation. All the states are a little bit different, and no one has put together the actual number of individuals we're talking about, but the Federation is trying to bring all of this material together so the states aren't acting totally independently, and that we all have a sense of what the other states are doing and how they're addressing the reentry issue, so we're common. And we're also in this process looking at how ABMS is dealing with recertification, because that has to be factored into the whole of the problem.
Right. Thanks. I believe there will be a visitor from Arizona board, our liaison from the Federation, coming in our next board meeting. You know, I would think maybe we could suggest to them, Linda could suggest to them, maybe re-entry will be a interest for them to make some presentation, or some, you know, we
So
can.
if they're going to make a presentation, maybe we should also have an idea of how many doctors we're talking about here in California.
What do we want to know?
Right.
From what they're doing. Reentry could be a issue. Some board actually actively using the 2-year as the as the definition of reentry. It does do that. So we could ask them for a presentation. I think they're mainly wanting to talk about MOL because I think we requested that. But we could also tag reentry into it just to show what they have.
Thank you. I think it'd be very interesting. Any other comments from any of the board members on the Federation information? Thank you. We're going to move on to Health Professions Educational Foundation. Dr. Dussault, do you have anything to report?
Yeah, just a comment.
Please.
We sort of talked about this yesterday a little bit, but let me just share with the board, as your representative along with Chair, at least from my perspective, how impressed I have been with the testimonies given by the participants who are receiving this loan repayment program. And by the way, supported by this board, including financial. The work that these individuals are doing and the work that they're performing in these underserved communities, in my view, is very impactful. It's just not enough of it, as I can see it. So I thought maybe it might be useful for this board at least once to hear some of these compelling, compassionate testimonies given by these individuals and the work that they're doing, and how their work is actually related to access to care. And so
I think it's an excellent idea. I have to I echo Dr. Dussault's comments that thanks to the work of this board, the Medical Board of California, as well as the California Medical Association, in establishing the Stephen Thompson Award in the first place, and with Dr. Gitnick's leadership and financial involvement and engagement as well, What we're seeing now, we had just a second cycle. I think I reported at the last meeting. We had an opportunity of some federal dollars, some unspent money that we didn't want to leave at the table, and we were able to put through another series of doctors out there in the community. Had we had more money, we would have had more doctors out there. So I think we have another 30 doctors out there in the community. We've also now just gone through a intense regulation meeting, a review for regulations for state law, and I want to thank Mr. Shumke for his engagement and participation as well as I participated. This organization, unfortunately, in my opinion, has become a stepchild as far as staffing, but that seems every organization in the state now has become a stepchild. There just isn't enough staff. And that impacts the programs and the ability to put these programs out. But our staff at the HPF has really stepped up to the plate with new staff constantly changing and constantly not being there, and executive directors changing. And it's just a very interesting who you're going to talk to tomorrow opportunity. But regardless, they have put out applications on the web. They've gotten information out. They've put people back out into the workplace who are working in underserved communities, as Dr. Dussault said. And it's a shining example of what really can happen when people partner. And it's not just one organization. It's the federal government, it's the state government, and it's our medical professionals. And I just want to thank everyone for my time that I'm able to serve there. Dr. Ganadev, you want to?
Thank you. One of the common wisdom in these issues is that if a physician stays in a community for about 3 to 4 years, they stay. I would really like to see the statistics. This is a wonderful program, but I do want to make sure that these physicians are staying after the loan repayment program is gone, or what percentage of them are staying in the underserved community, and whatever else we can do to really increase the scope of the program. This is one of the programs with the access to care. We talked about that yesterday. So I like the staff to bring it to next meeting or so, if you can get the numbers. We have it going for several years now, and see what percentage of them are
We'll be
staying
happy to
in
bring
the
that, sure.
community.
Very much so.
I can just give you, I know that I went to Altamed Clinic, which is in East Los Angeles. Altamed has, I don't know, a dozen clinics plus more or less around the eastern and southern part of Los Angeles County. Met a previous recipient who happened to be Indian, actually, at Altamed, who had, she was staying in that community because she remembered when she came to Boyle Heights how they treated her, and her family was there with her. And I have to tell you, the previous recipient was there as well, and she's moved on and stayed like 10 minutes away in another clinic. And what I've seen, but I'd be happy to get you the numbers, and if we can find that information out. I don't know that they track it, but it'd be interesting to track for sure. But you're absolutely right. The amount of time that the intention of the program is to bring doctors into the community and to have them stay, live there, and become genuinely part of the community in the medical profession as well as in every other aspect. Dr. Dussault, anything else?
No.
Any questions? So thank you very much. I'm going to suggest that I would be happy to entertain any comments on communications with interested parties. To start off the boat, I don't know who's interested or not, but I meet with a whole lot of people all the time. They're all very interesting, at least in their own minds. But there's no conflict of interest that I need to report and divulge, so I apologize for the humor, but I always find it interesting. Be assured, if there was a conflict of interest, I would be reporting it up front and out there. Anyone have any reports to make? Okay. During this quarter, I participated in 3 DCA board presidents' calls. We have a monthly call with the presidents and the executive officers through DCA, discussing issues of common concern, board membership, whatever it is, or lack thereof. And they're always very interesting. The lack of transportation or be able to travel is always come up. Whatever the issues are, it seems to not only affect our board, it affects every single board under DCA's sponsorship. And I think that the questions asked or raised are interesting, and I think it's a benefit. I enjoy the conversation. I'm sure they enjoy my comments as well, or not really, but anyway, they get them. And it's a learning experience. It's an opportunity to have a voice at the table, and I think that's what our object is to be in partnership with GCA under the leadership of this governor and his staff. And I appreciate the opportunity to participate, though I make light of it. It is always informative and asks some interesting questions. I also have a weekly call with our executive staff and review information that is, I think, utmost important that we stay on top of. All aspects that affect this board, from licensing and statistics and numbers. Enforcement is always at the table. Legislation is always at the table. Our public information, welcome Mr. Dan Wood, Dan. See, I have a favorite author, Dan, I have to remember Dan Wood, Dan Brown, and Stuart Little, it's okay. So I apologize. I'll call you. As long as they call you, it doesn't matter, right? As long as they remember your name. Yes, to call you. So I want to welcome you as well. But we do have this weekly meeting on the phone, and I think it's an opportunity for our executive director to hear from me and vice versa, and I hear from the staff as well, and I appreciate that time. I also attended the December 14th Medical Board staff holiday party, and I have to tell you, everyone seemed to have a wonderful time. The organizational skills of our staff is totally amazing, and we all have to be proud. I mean, coming to work every day, you become part of a family, and I have to tell you that I think that the support and the engagement of our staff with each other, and this is a real team-building experience, planning a party for 200-plus people, and they pulled it through, and everyone had, I'm sure, hopefully a very good time. I also participated in January 20th with the new board members here in Sacramento, an orientation, and found the orientation, I have to tell you, it's almost, I wouldn't have to want to put any more work on Ms. Whitney and her staff, but it was excellent. It was really excellent to the point that I'm not so sure that we as board members shouldn't have the opportunity to go through an orientation such as they did on a regular basis. You forget certain things, or you're not quite sure of certain things, or you need to be reminded of certain things. I have to tell you, the staff put in, I don't know how much time. I want to give them credit for putting in many hours of time they really don't have, but the professionalism and the information, the layout, the scope of the work that they did to make sure that these two new board members who have just walked into this board, I mean, I'm not so sure that we shouldn't have the experience as well. So I want to thank you and your staff as well. So moving along, Ms. Whitney, would you like to present the executive director's report? We're on agenda item C.
Okay. Thank you. I'm pleased to announce the appointment of Tim Einer, our new administrative assistant. Tim, there you are. And with this is Cheryl's last meeting. Cheryl Thompson, could you stand, please? I would like all of us to thank Cheryl for a job very well done. In December, we finally were able to hire, after a vacancy for over a year, our new public information officer. Dan Wood, please stand, Dan, has 30 years experience in journalism and television broadcasting. He has already made an impact on our newsletter. I hope you've all seen that. And has a number of goals in addition to implementing those from your strategic plan. I mean, he's hit the ground running. Thank you, Dan. We've hired a research program specialist to replace Janie Cordray, but we have kept Ms. Cordray on for special projects and for historical reference. The new specialist, Letitia Robinson, is a former manager in licensing, so we have robbed Peter to pay Paul in this case. We're very excited about her taking over this job. She will focus her efforts on the VEP evaluation, various statistical analyses, and on preparing our sunset review report that will be due in the fall of 2012. So we're excited that she's switched over, but of course she's going to be doing two jobs until we're able to fill that manager position. As you heard in the presentation by Ms. Harold of the Pharmacy Board, in early December, Ms. Simoes and I attended the California Endowment Shareholder Group on improving prescription medication labeling. Ms. Harold made sure that we were invited She wanted to ensure that we were at the table in discussing this because this item needs to be fleshed out a little bit more, and we need to share this information with our physicians in our newsletter and on our website. So Ms. Harold has done a great service to this board by ensuring that we are participating in the information regarding improving prescription medication labeling. On January 12th, the National Practitioner Data Bank staff provided an excellent all-day training session to the board and DCA staff. A couple of staff from the Attorney General's office attended, and a few other people from around town who are actual reporters, including Kaiser attended. There were over 60 in attendance. Ms. Kirkmeyer took the lead in setting up this training, and we co-sponsored it with the National Practitioners Data Bank. Thank you, Ms. Kirkmeyer, for all of your work in putting that together. On January 18th, Ms. Kirkmeyer and I met with representatives of Consumer Union. I think you've heard about that. And they requested broader webcasting of our meetings to include committees, which we had already planned for this meeting, and that was done yesterday. They requested that our board meetings be available via teleconferencing. This is a legal matter and has been referred to DCA Legal Office. They made a number of suggestions for improving our website and brochures regarding clarity on the statute of limitations, and they asked questions about our implementation of SB 100, information that would be posted on our website. We told them that we would provide a written response to these items after the board meeting because we were in preparation for this board meeting, and that we are looking at our brochures and our website to ensure that we get the best information to consumers, and that information has been handed over to Dan to incorporate into new information for consumers. In addition, we told them that SB 100 was on the board's agenda for yesterday in our licensing committee, and that we would be providing future updates as it related to enforcement and just things on our website that would be more informative to consumers. We'll also be providing information on outcomes as we move forward with the implementation of this law. You will receive copies of information as we have that available. On January 20th, as you have heard, our 2 new members came to our headquarters office to receive the medical board orientation from executive staff and various managers in our licensing and enforcement section. They still have to go through DCA orientation, so they have a long training schedule in their future. On January 23rd, staff met with the Attorney General's office, as you've heard from Dr. Lowe, regarding information systems, referred to as CMS, and worked on additional details to get the data needs to the medical board for our VEP evaluation. We hope to have the data in the very near future so we can compare it with some of the analyses that was done in the Ben Frank report and the recommendations that were there. I met with our new Deputy Director, Ms. Everhart, on January 24th, and hope to have a meeting with the new Director and Chief Deputy Director by the end of February. Ms. Kirkmeyer, could you come forward? I think there are more administrative updates, and then you can provide the rest. Thank you.
Thank you very much, and good morning. I'd like to first add a few administrative updates. Most of the members have been receiving their board information via a thumb drive or a USB drive rather than a hard copy of the board documents. It's been saving mailing time, staff time, etc. The members then load the documents onto their computer for use at the board meetings. We're beginning to consider if emailing the board members the materials so you would have it in your MBC email account for you to download onto your computers would be easier than using the jump drive. And again, it would be saving staff time and shipping costs and everything. And so we're looking at that as a venue right now. We just implemented our new Outlook system. And so one of those things are being able to add more information. So that's an item that we're looking for. It was actually recommended by one of the new members, and it would greatly assist staff who have to maintain and collect the thumb drives back after the meetings. So we'd like to implement this for the May meeting. We'd be sending out instructions to each of the members, and right now I'm just kind of putting it out there to see if this would be something that the board members would be interested in doing.
I would love it.
Second that motion.
You want a motion? Yeah.
No.
No.
No, you don't need a motion. I do not need a motion.
That was a joke.
I would love it because those of us who use an iPad right now cannot use the thumb drive. So we have to load it on in a Dropbox or some kind of an iBook and then put it back and do it. So the process is doing it, make them into an email and then make them into the system, do it properly. So you will be so ahead of cutting edge, ahead of everybody.
Perfect.
Okay, using the iPad. So a lot of people who has iPad can do that.
Would be perfect.
Dr. Gonadab?
Yeah, it's a great idea, actually. I was there. You have to remember that when you email these large files, it gets rejected. So you have to break them down into multiple files and email them. And the better option actually will be if we are in a Wi-Fi, you can actually dump on all computers, especially iPads, directly without even going through email. But I think that's a long way to go. But right now, I think you're better off just breaking them into appropriate size files and send them. Otherwise, they will not go through.
Right. Actually, I'm brag a little bit about our ISB, our Information Systems branch. I believe this is probably closer in the future than we think. I'm not the techie in the office. Miss Whitney and I, we stray away from that from time to time. But we actually are getting SharePoint as part of our package with the Outlook, and that would be able to give us a system out there that was secure that you could go out and pull the documents from there. I'm not going to tell you how to do it, but our IT system will definitely look at that as well for the future. So I think that's kind of similar to what you're talking about. So it's definitely something we're moving to be definitely more paperless just to save money and staff time.
And the trees.
And the trees, yes.
I'm sure it's good for your back as well. Not mine, but yours.
Soon, you're almost there. I also wanted to let the members know that the board has been working with both the Department of Healthcare Services and the Centers for Medicare and Medicaid Services to notify physicians of 2 opportunities to receive funding for electronic health records. The Department of Healthcare Services has a program called Medi-Cal Electronic Health Record, or EHR, incentive program, which provides eligible Medi-Cal providers with $21,000 during the first year of the program for adopting, implementing, or upgrading a certified electronic health record in their practice. In subsequent years, providers who demonstrate meaningful use of their EHRs by reporting on a set of objectives and clinical quality measures will receive $8,500 yearly up to 5 years. Over the life of the program, providers can receive a total of $63,750 in incentive payments from Medi-Cal. An email blast was sent to physicians notifying them of this program and its deadlines for application. The board also partnered with the University of California at San Francisco to assist the Department of Healthcare Services in being able to baseline or provide a starting point for the use of EHRs statewide. The UCSF drafted a survey that was sent out to physicians along with their renewal notice from the medical board. This survey was separate from the board's physician survey and asked questions regarding EHRs. The information gathered from this survey by UCSF is being used to draft a report for the department. This report will provide the department with the data they can use to see how this program impacts the use of EHR in the future. The Department of Healthcare Services and UCSF may wish to present the board to the board at a future meeting on this report. The board is also working with the Centers for Medicare and Medicaid Services for their Medicare EHR incentive program. We will be sending out an email blast to all physicians in the future on this program and its application deadlines too. Under this program, Medicare physicians can actually receive up to $44,000 for over 5 years for the meaningful use of EHRs. Both of these programs are important to physicians and the public, and we are happy to partner with these sister agencies. As information is received on these programs, we will provide information to the board. We will also be providing links on our websites for these programs and putting articles in the newsletter on the programs and the deadlines. Okay, moving on to staffing, and this is a much better report than, oh, yes, Dr.
Can I comment on that, on the electronic health initiative monies? There are entities which are established in California, like CalHIPSO, like Los Angeles Care, and CalOptima. So they got grants from the federal government to provide this service or help doctors to get there, especially primary care doctors. I think we should include that information to docs. And this money came through the stimulus package before, not from the health reform bill, from stimulus bill, to help physicians to get to electronic health records. And we need to make sure that they utilize this, all the resources available.
Okay, we can get that information from you.
Thank you. Continue, please.
Since the last board meeting, we have had the hiring freeze lifted and have been able to advertise, interview, and hire individuals for our positions. At the last meeting, you may remember that I reported the board had 71 vacancies, and that included our CPEI positions. At the end of January, the board will have 51 vacancies, including the CPEI positions. And of those 51 vacancies, we have approximately 14 individuals either awaiting a background investigation or confirmation of eligibility at DCA so we can hire. However, we also have 3 future vacancies occurring due to staff transferring to other agencies. 51 vacancies equates to an 18% vacancy rate at the board compared to 25% from the last board meeting. If we remove the CPEI positions from those figures, we actually have about a 13% vacancy rate, and that even includes the positions that are in background, so it's even lower than that once we pulled those numbers out. So we're doing very well with filling our positions. It takes a lot of staff time, but it's obviously very worth it, and we're really glad that we were able to hire in this time frame. Moving on to the budget overview, unless there's any questions on staffing. Okay, I'd like to turn your attention under tab 15, and you will find the budget reports on pages 51 through 58 of your packet. And please note there is a revised page 51. It's entitled 51.1, which replaced page 51, and that's the board's most recent fund condition. The document has been updated since the last meeting based on the governor's budget that was released. The governor's budget included the position authority for the reestablishment of 6 positions for Operation Safe Medicine. However, as you can see in looking at that document, we were not approved for the funding for these positions and will therefore have to absorb the costs of the unit within its existing budget. The BREEZE project was also included in the governor's budget for a one-time augmentation of $1.278 million in fiscal year 12-13. As you can see also on that document right below that the board is also anticipating future BREEZE costs for the project as well. Ms. Whitney and I will be reviewing the board's budget to ensure the board can absorb the costs for the Operation Safe Medicine in the future, and if necessary, may again put forward a request for the funding for these positions. Additionally, based upon future workload for this unit, we may be requesting position authority and funding for positions in for a Northern California unit as well. As most of you know, we only have a Southern California Operation Safe Medicine unit right now. As you can see from this fund condition, if the board spends as planned, the board will be within its statutory mandate at the end of fiscal year 2011-2012 and in the middle of the mandate in fiscal year 12-13. This is important to note because, as was reported at the last meeting, the Bureau of State Audits is monitoring the board's fund condition to see if it is within the statutory mandate of 2 to 4 months as follow-up to their audit in 2007. Also, as reported at the last meeting, the board did respond to the Bureau of State Audits regarding its recommendation that the board consider reducing licensing fees in order not to exceed its mandate. The Bureau has released its report on recommendations not fully implemented for all state agencies and included the board's response in this report. As you may remember, the board's response indicated that at this time, the board is projected to be at a mandated level at the end of this fiscal year and projected to be even lower in the following fiscal years. The response stated that it would not be prudent for the board to consider a reduction at this time. Based upon the board's response and the Bureau's review, the Bureau stated in their report that their assessment was that the board will not implement this recommendation. Again, the board staff continues to review its fund condition to determine if the fees need to be reduced, but if the board continues as planned, we will be within our mandate by fiscal year 12-13. We will revisit this discussion at the end of this fiscal year when we have a better idea of this year's spending and any other items that may impact the board's fund condition. Are there any questions? Yes, Dr. Simonson.
Yeah, if I understood this, by 13-14, our months in reserve would only be 1.6?
Yes.
And then dropping down to 0.2. So there is the mismatch there. With that in mind, any possibility of recouping our loan?
What will happen is based upon our fund conditions, as we get to the point to where we are without funding to implement our program, the department would then request from the Department of Finance the refund or the loan repayment for the money that they have actually taken from us. The statute actually says that you can't seek, which when we get to this level, if we didn't have that loan outstanding, we'd be going back to ask for increase in licensing fees.
I have to say,
and
as
so
a
that
licensee, I would, as well as the board
Right.
member wearing both hats, I would prefer that we recoup our loan prior to
Yes.
requesting that I get to pay more as a
Yes,
licensee.
and absolutely, that's exactly what it is. We cannot go through the process of increasing our licensing fees until that money is recouped into our fund.
Maybe just the interest on the loan would be okay, too.
Yeah, that might work as well. That's a good chunk of change. Okay. All right. Some of the members may remember that the legislation which changed the board's reserve mandate from 2 months to between 2 and 4 months also included a requirement that the Department of Finance Office of State Audits and Evaluations perform a preliminary review of the board's financial status, including but not limited to its projection related to expenses, revenues, and reserves, and the impact of the loan from the contingent fund of the Medical Board of California to the general fund made pursuant to the Budget Act of 2008. This review is to be completed by June 1st of 2012. Beginning on January 17th, the auditors from the Department of Finance started reviewing the budget documents from the board. Their first week, they were there and they actually met with the Department of Consumer Affairs and reviewed all of their documents. They came to the board on January 20th and began reviewing board-specific documents and interviewing our staff. They have met with Ms. Whitney, our budget analysts Debbie Titus and Tamiko Heim, and myself. They are looking at how the board reviews the budget documents and makes projections on revenue and expenditures. We will continue to update the board as we have more information from these auditors, and will also provide the board with a copy of the final report. Okay, moving on in the board packet. You will see in pages 51.2 and 51.3, the board section of the budget bill that is going through the legislature. Because the board has a budget change proposal for Operation Safe Medicine, we will be following this bill and may be required to testify at budget hearings regarding this unit. Our hope is that this bill goes through as planned and we will receive final approval for Operation Safe Medicine for fiscal year 12-13 and ongoing. Page 52, unless there's any questions. Page 52 shows the entire board's actual expenditures as of November 30th. We have stayed on target for this time of year and there is nothing that raises concerns. Please be aware that we are going to be requesting video conferencing equipment for 3 of our field offices as well as for our headquarters office. We believe that this will allow us to provide better training and more meetings for the field as well as opportunities for meetings with other departments located around the state. We are preparing the documentation to be reviewed by the Department of Consumer Affairs for approval. And we thank Dr. Lowe for his suggestion on this and support on that item as well. The next 3 pages show the budget report specifically for licensing and enforcement and the AG expenditure for enforcement, and page 56 shows the enforcement receipts received in the last 3 fiscal years as of November 30th. Are there any questions before I move on? Okay. In addition, the last page is in regards to board member spending, and I've asked Mr. Einer to hand out, we actually have a new document that replaces page 57. And these are expenditures for the board members through December 31st, based upon travel claims we've received and hours reported from the members. We would like to remind members how important it is to submit your travel claims and hours in a timely manner. This will assist us in monitoring our spending as well as ensuring we have accurate reports for the meetings. And then the last page, page 58, is just the synopsis of the board's budget and expenditures by each program. Unless there's any questions, I'm going to be moving on to the Breeze update. Okay. As was reported at the last meeting, the Breeze vendor began on the project in late September and is in full swing at this time. Board staff have been very involved in this project. So far, we have had meetings to review the licensing and enforcement requirements for our processes. Additionally, we have had staff involved in the configuration of the system and the development of correspondence that will be in the system and able to use. Our information systems branch has approximately 6 staff involved in different aspects of this project. Additionally, we have identified 7 staff that will be trained on the system and will be able to provide training for all board staff as well as training for other boards and bureaus for the department. The Department of Consumer Affairs has hired a new Chief Information Officer. Her name is Amy Cox O'Farrell, and she came from the Contractor State Licensing Board, where she was the head of their IT unit. She has been very involved in the Breeze project and has extensive knowledge of the department and its functions. This is a great choice for the department, and we believe she will continue pursuing improvement in customer service that was started by Debbie Balaam, the former CIO. And I just wanted to take a moment really for Dr. Bishop and Dr. Ganadeb for the numbers to just give them a little bit more on this project. The board has a very archaic system for licensing and enforcement processes. We have COBOL, and nobody really knows the system, natural databases. So it's really old. I can see Dr. Bishop passing out over there. In addition, we found, based upon the needs of the boards, we have built custom systems, workaround databases outside of the CAS and ATS systems that we use. The Breeze project is going to replace all of these systems with one system that will include information for all technology requirements. Some enhancements will be the ability for a physician to pay all fees online and also to allow third-party payers to pay for physician application or renewal fees. It will also allow individuals to track items online, such as their application or their complaint. It will also let physicians check their license information online, including obtaining a special ID with security, which would then allow them to make changes online, such as a change of address. So it would be very electronic. The system will also allow applicants to complete and submit their applications online. Of course, some documents will still need to be mailed in to the board. So that's kind of a brief synopsis of the report. The system is scheduled to be implemented in the fall of 2012, and we will be working on communication plans for our licensees, interested parties, and the public on this new system. We are planning on providing a complete presentation at the July board meeting. Are there any questions on Breeze? Okay. Finally, the FSMA update. At the last meeting, we notified you of a request from the Department of Consumer Affairs to identify and report on the most significant risks to the board. The request was based upon the Financial Integrity and State Managers Accountability Act, known as FSMA. As you may remember, the definition of a risk was defined as those objects or impediments that stand in the way of achieving your goals and objectives. Beginning on page 59, you will see the department's response based upon the input provided by all of the boards and bureaus of the department. They identified the top 4 risks as staff resources, enforcement, Breeze implementation, and appropriate budget funding. The department pointed out how the lack of staffing impacts both licensing functions and enforcement processing. For enforcement, the department discussed the hiring freeze and how it resulted in the CPEI positions not being able to be filled. They also indicated that a lack of staffing resources increases the enforcement timeframes, which we're all well aware of. The Breeze implementation was twofold according to the report. One concern was the system meeting the board's needs, and the second concern was challenges during development. The last item was appropriate budget funding. The report stated that with budget cuts, some boards are unable to absorb costs associated with increased program costs. And so that report was submitted to the Department of Finance from the department. So with that, are there any questions on any of my report?
Do you have any questions, Dr. Ganadeb?
Yeah, just a comment that actually this time, first time I was able to do online renewal and my license came back in 2 weeks. It's amazing, so it did work.
Great, that's good to hear.
Thank you. Do I have any public comment on this report? Thank you. We're going to continue with our agenda. I'm going to pull item number 16 off of the agenda as we had no special faculty permits to be reviewed. I'm going to move on the agenda to the licensing chief report. Mr. Warden, would you please come forward and present on number 18 on the agenda item?
The Special Faculty Permit Committee Review Committee meeting was held on January 23rd. One applicant was presented, but the committee decided to request additional information, which we are in the process of requesting, and the applicant will be re-reviewed at one of the next Special Faculty Committee meetings, which is either scheduled for March 12th, June 14th, or September 6th. We have one current application for a specialty board application, and we're awaiting response from the board to our request. The polysomnographic program regs become effective on February 18th, and we are currently working on implementing the new program with website information, notifications to interested parties, and procedures for processing the applications. For the implementation of AB 1424, which is the tax delinquency denial of application for licensure and to suspend a license or certification and registration, has been updated onto our website on the home page, the licensees page, and the applicants page. And that's for people who have over $100,000 in delinquent taxes. I'll be going on to staffing at this time if there's no questions.
I'm just curious, how are they going to pay if they don't have license?
It works very similar to the child support law. So.
I have another question, is how many of these physicians are there? What kind of an impact is there?
For us, I'm not sure. We don't have that information yet, but according to the Franchise Tax Board, there's probably between 250 and 500 licensees statewide for different licenses. So,
Anita?
If I may, only because I've been involved from the departmental side in the implementation of this bill. It's targeted at those on the top 500 list of both the Franchise Tax Board and the Board of Equalization. And I believe the impact to the board would probably be minimal. I think that they were anticipating under 24 physicians, but there are some physicians who are currently on the list.
So if there's any other questions?
Continue, please.
I'll go on to staffing. First off, I'd like to thank all of our licensing staff because they're continuing to do an excellent job. They've maintained our processing within our goals for almost every week, with a few exceptions, depending on the influx of applications and our vacancy rate and or people being absent for medical reasons or other reasons. For the first time, well, to start off with, our licensing staff includes all the people who perform our duties in our call center, our cashiering, our allied health programs, our fictitious name permits, the outpatient surgery center information, the license verification, our specialty boards, the polysomnography, the special programs, the CME audits, and licensing applications for physicians, surgeons, and renewals. Licensing currently has 5 vacancies. One of them is a manager position, which was Ms. Robinson's. Fortunately, she's still helping us out on several things, one of those being the outpatient surgery center. But for that position, to give you an idea of what Ms. Robinson was doing, she was doing midwifery, the RDO program, outpatient surgery, cashiering, research cycle analyst, and the CME for the physicians and surgeons. We currently have that position has been advertised. We have received the applications, and we're awaiting approval from ECA and Department of Personnel to be able to hire that position. Interviews will be probably scheduled in the near future for that position, and that's where we're at with that. We have one physician and surgeon international application review position that's been vacant. It's been advertised. We've received applications, and interviews are scheduled for that one next week. We have a management service technician vacancy, which is for our RDO position, and we are waiting for the duty statement to be approved for that one before we can hire or advertise that one. We also have an OT position in cashiering that's been advertised, and we received vacancies for that. And for a polysomnographic analyst, the duty statement is currently being developed and will need approval. For basically the first time in a year, we are fully staffed in the call center, which is huge because at one time we had 2 people in there, so which makes it very difficult to handle all those calls. And as you may have heard, Ms. Thompson is no longer the midwifery analyst. I've hired her to do my international medical schools. This position has been vacant for a year also. We have hired a new analyst to replace Ms. Thompson for midwifery. She started this week. We're having her review our last MAC meeting minutes and becoming familiar with midwifery this week, and we'll start training her fully next week with Ms. Thompson's help. And then we have 2 of our other vacancies for analysts that we've recently hired, which is for the senior application review analyst, and that will be Ms. Christina Thomas, and also for our policy and procedures manager, Mr. Mendenhall. Those are 2 people we promoted from within licensing for those positions. Approximately 25% of licensing staff are in various stages of training for their positions. So even though we have significantly reduced our vacancies, we still have a lot of training going on, which means that staff is not working at their full capability at this time. And that concludes the staffing update.
Dr. Solomonson?
And I'm sure you covered it, but you covered a lot. Just for clarification, with your increased responsibilities for the outpatient surgery centers, are we budgeted for a new position that you're working on filling? We're just having to absorb that? How are we handling that?
That particular position is part of the midwifery position, and so we do not have a new position for that. Once it's sort of up and running, I'm thinking we'll be okay, but right now there's a lot of work that Mr. Sagato, Ms. Robinson, and myself, and we're all pitching in on, especially the ISB staff. They're the ones that are trying to develop a system that will actually be able to work on the web with all the information we get and start requiring the outpatient surgeries to submit it in a specific format so that we're not manually inputting it, so that it will actually be electronically provided and dumped into our system. So we're still a little ways from all that being done, but it's coming along.
So basically, it's an unfunded mandate, that it was placed in like the outpatient surgery centers aren't paying us a fee to get listed?
Well, actually, the outpatient surgery centers do pay us a fee per se. To become an accreditation agency, you have to apply to the...
Right, they pay the agency, but are they paying the board for the...
Well, the agencies, we require a $5,000 application fee to get accredited.
Right.
The agencies pay us $100 for each outpatient surgeries on their renewals, which is, they renew every 3 years. An outpatient surgery center has a 3-year renewal process. So every 3 years, we're getting a renewal fee of $100 per outpatient surgery center.
Dr. Ganadev?
I think I had the same concern. That is that one of the pleasant surprises when I got on the board was that actually we made a tremendous strides in licensing compared to a few years back, how long it was taking. I just don't want us to go back because SB 100 requirements are serious. If you take that on without any additional staff, my concern is, are we going to get backward into delay in getting doctors to California, which is, in my mind, one of the most important access issues?
Well, I don't plan on getting in delays on physician and surgeon application.
I think it's being carefully watched. I think that we need to see what kind of time constraints are going to take these new programs, and we're going to have to, we have to depend on staff to reevaluate and get back to us as to expectations and appropriate pushing.
One quick question also. With the freeze lift, does that mean that Kevin is freed up to do the licensing fairs without special permission on every
Beautiful.
That's coming, that's not
All
yet.
right, thank you.
Okay, so any other questions? Then I'll go ahead and move on to the program statistics, which are on pages 65 through 71 of your board packet. Basically, the statistics speak for themselves, but I'd like to cover a few of the things for fiscal quarter, second quarter for the fiscal year. The board received 1,666 physician and surgeon applications, and 1,689 physician and surgeon applications for initial reviews were completed. That included for PTAL also. There are a total of 4,225 total pending physician and surgeon applications. Of those, 3,530 have been reviewed, 795 are pending review, and we've issued at the quarter 1,203 physician and surgeon licenses. On page 69 is a 5-year history of the physician and surgeon licenses issued, and on page 70 is a 5-year history of the applications. On page, there were 121 pending applications for senior review, and as per the request of the chair, on page 66 is a breakdown of the senior review categories. 8 of those pending had not been categorized at the time of this report. As in on, let's see, what page was that? For the physician and surgeon application data for January 7th, the initial review date for U.S. files was actually 50 days. Last year at that time it was 30. For the IMG files it was 33. The pending mail was 7 for U.S. and pending mail for 7. Just before coming to this meeting, I received this week's current status of that, same data, and the U.S. files are at 42 days for initial review. IMG files are at 29. Pending mail is at 7 and 7. So if there are any questions, I'll go ahead and move on.
I want to thank you for the statistics. I hope the board is well aware of these pages 65 through 70, whatever it was you said, 69. It's a new format that we're receiving with our materials, and I would hope that you would all take the time to review it. It's taken a lot of work to put together, but I think it does give a very good oversight and understanding of what the workload is currently, and I want to thank you very much for bringing it to our attention.
You're welcome. Okay, so I'll go ahead and move on to agenda item 18C, which is the status of international medical school reviews. Basically, this is from pages 67 and then 73 to 85. So I've revised the chart to include schools that have requested recognition and the schools where we have received a physician and surgeon application or PTA applications where the medical schools is not on the board's recognized list, and the applicants have requested the board to evaluate their school for evaluation for recognition. This list includes international medical schools applying for recognition pursuant to either California Code of Regulations 1314.A1A or 1314.1A2. At the time of these stats, there were 75 international medical schools on this list. We have not had anybody working on international medical schools basically for a year except for myself and legal staff, which is where we just have not had any staff. We are going to be able to start doing more. We have made some progress, but the progress has been very slow. And with the analysts finally assigned to that, we'll be able to move some of this along at a little bit quicker pace. We do have several schools that have applied that are in the process of the review process that have been on hold for over a year. 2 of those are schools that are applying for their A2 recognition, and we've not been able to go on to working on those. We do have preliminary reviews of those schools, but we needed additional information. We have not been able to get review on that. That will be one of our priorities, is to get those schools, because both of those schools have been in the process for over 3 years. So we also have some new applications regarding that status. in summary, the initial reviews is, as I said, have been moving slowly, and we need now to train Ms. Thompson on how to do a lot of this work, and Ms. Oseto and I will be providing the training for this position, and that concludes my report.
Thank you. Any questions in general? Or Mr. Warden, I want to thank you and thank your staff. It's never easy to work when you don't have people to do the work. It seems that your office is able to put on hold a bunch of different hats and get the work done, and I want to tell you that I expect it to be that way. I don't want you to think that this is a break in the process, but I want you to know that I recognize, and I want this entire board to recognize the efforts that go on with you and your department. And if I have any public comment before I let you go, let's hear if there's any other. We've heard from the board. Any public comment? No. Okay. Thank you very much, Mr. Warden. Excuse me. Don't get up yet, Dr. Levine.
Yeah, I just wanted to say how much I appreciate the emails that you send, keeping the board members updated on that frequent and periodic reminder or ability to view. That is terrific.
Yeah. I personally believe it's important for you to see when we're not meeting our self-imposed goal of 45 days for initial reviews, and overall we're meeting that with most weeks. So there are exceptions to that, and it generally has to do with a staffing shortage or a high influx of when Mr. Chunky has done a licensing fair. So so it's generally one of those two things that causes the influx. And you know, as I said, all of the staff is doing an excellent job, and the managers, I don't let them go home at night. So
That's good. We should be charging bed tax. Maybe then that's one way to raise money in the state of California. Bed tax employees, the Medical Board of California. Thank you, Mr. Warden. Let's move on the agenda to Mr. Shunke. Would you like to come forward and report on your licensing outreach and education report?
Good morning, Ms. Yaroslavsky and members. As a reminder for some of you in education, for Dr. Ganadev and Dr. Bishop, Dr. Salmonson just asked about the lifting of the hiring freeze and how it impacted my ability to travel. Those are actually two separate issues. It is correct that the hiring freeze has been lifted. However, all state agencies are still subject to the governor's executive order regarding restrictions on travel. However, with a major shout out to Ms. Kirkmeyer, she has been able to finagle and maneuver her connections at the Department of Consumer Affairs, and so far all of my travel for 2012, all of my outreach throughout California has been approved. So starting in February, I will be beginning my travel to outreach to the teaching hospitals in California. Right now I have about 14 trips which have been approved that cover about 20 primary teaching hospitals and the affiliated hospitals which are together, you know, which I can visit at the same time. In recognizing and in trying to adhere to the spirit of the travel restrictions, I am trying to condense and combine as many visits to teaching hospitals in one area as I can. Some of the new hospitals, in December, we sent out about 1,000 letters to all the program directors and to the GME offices and to the designated institutional officers in California, and offering our services, offering a repeat of the matrix that we have created over the last several years. The matrix is for those of you who are in a teaching hospital and work with GME, you're aware that the residents are coming up to a licensing deadline at the end of their training year when they must be licensed. And several years ago, at the encouragement of Ms. Whitney, we asked the teaching hospitals to provide us with the names of those people who needed to be licensed at the end of the year, because it helped us not only identify those files, but also to manage our anticipated workload as we were moving towards July 1. And so the letter not only encouraged them to get in contact with us to provide us with the names, but to use us as a resource in moving forward. Several hospitals have contacted us for the first time. Coincidentally, made a first initial contact with Arrowhead, almost coinciding with Dr. Ganadev's appointment to the board. So I'm very happy to have that connection. I've been in frequent contact with City of Hope down in the Los Angeles area, but have never had the opportunity to go visit them. So while I'm at the UCLA Olive View Center up in the San Gabriel Valley, I'll be going to City of Hope. Cedars-Sinai Hospital, although a major hospital and I've been in frequent contact with them, we've never had a license fair there, so I'll be doing that for the first time. And when I'm traveling down to UCSF San Francisco, I'll be making several stops at some of the other locations in the Central Valley. So saving money, but still using the opportunity to expand the outreach. Also with the encouragement of individual members on the board, but also Ms. Whitney, I am starting to, or increasing my outreach to the hospital recruiters as they hire new staff members at the hospital to try and discourage them from hiring new staff to start in the summer when we're really focused on the residents and trying to get the residents licensed in a timely manner. Of course, we're not going to discourage them from hiring anyone in particular during a certain time frame, but just to make them aware that that's the busiest time frame for us, where we're dealing with thousands of people who literally are coming up to a licensing deadline and will not be able to continue in their residency training if they're not licensed. It's an inopportune period for us to try and meet those the same sense of urgency that a hospital has in hiring new staff. And then, as I briefly mentioned, we are starting to create the matrix for 2012. Last year, we had almost 2,000 names on of people who needed to be licensed. I anticipate the matrix to be smaller this year because Mr. Warden and his staff have been so efficient. In fact, one of the teaching hospitals, when I solicited input from them regarding the matrix, I was surprised one of the hospitals said we're not going to be submitting any names this year. At first, I really took it as a surprise and an offense, and when I read on the email, she was happy to report that all of their residents already were licensed by December. So it's a combination of Mr. Warden working more and his staff working more efficiently, but it's also our opportunity to educate them and to make them aware of how urgent it is that they start. Yet nevertheless, there are always stragglers. And as for the two new board members, and as those of you, the rest of you have heard, last year, the last application we received for those who needed licensure on July 1, the application was submitted the third week of July. So 3 weeks after he was fired from his job for not having a license, he finally got around to submitting his application for licensure. So there are some people who will never learn. Do you have any questions?
Any questions? Dr.
Just have to
Solomonson?
compliment Kevin and recall that when the freeze was on, that I remember a number of program directors saying, can we pay Kevin's way to come? Because they found it that valuable. Unfortunately, there was no way for us to take their money, but they get Kevin, so it just proves how valuable you are.
Dr. Solomonson, board members, there still is a restriction on travel. And so it was never frozen, but it's a restriction. So we have to get permission for Kevin to go out on the outreach efforts, and we still don't have full permission to go to the orientation of the new students who are getting to the medical school or the new postgraduates, and we hope to have that in the near future so Mr. Shunke can go out and do his full outreach and let the students know as they come to California what's going to be required in terms of licensure, so they're well prepared for that when time comes up for them to make application.
Well, thank you for correcting me.
I think we all need to be aware and cognizant of the fact that the travel restrictions imposed has been at issue with the mission of this medical board, be it for the ability for staff to travel to do interviews. It's always, everything is very carefully weighed. They're allowed to go, they get permission to go, but it's not like within the course of the day you make your schedule for next week, next month, and next few months. Everything is always under this umbrella of checking and rechecking and permission granted, permission denied. So I want to thank Ms. Whitney as well as Mr. Shunke for, and the staff for,
Ms.
Ms. Kirkmeyer for sure. But we all need to understand that the blanket has not really been lifted totally at all yet, so don't assume that it has. Dr. Ganadev.
Yeah, I do want to thank Mr. Shunke for really reaching out. You have to remember, March through June is like Christmas time for retailers. That's when most of the license, the residents really apply for, so that's a very tough time. One other thing I would suggest for you to do is also train people in the GME offices, in the DIO offices. They might be able to, they will be your surrogates when it comes to that. They can assist the residents in, it's tough, we're all residents, we know how it is, so they need some help. I think that's another way to do.
Anything else? Any public comment? Okay, thank you, Mr. Shunke, very much. We're going to move on the agenda to the midwifery update and ask Ms. Ehrlich to come forward. Ms. Barvo, are you joining? Thank you.
Good morning. I thought it was going to be afternoon.
It is somewhere.
It's true. I would like to, first of all, introduce Carrie Sparavon to you all. This is my last report as chair of the Midwifery Advisory Council for the time being. I am going to be moving to the vice chair position for the next term. Carrie has been elected chairwoman of the Advisory Council, and she will be taking on that responsibility starting at currently, but for the March 29th meeting. So I'm going to be giving the report to wrap up for my term of having been the chairwoman. At the last meeting on December 13th, we discussed ACOG's new position statement on collaboration between OBGYNs and CNMs and CMs. We are hopeful that this might help to change the climate for the licensed midwives in California, and are very happy to see that collaborative care statement coming forward. We had a discussion about modifying the Midwifery Advisory Council membership. There is an area in your packet from page 92 to 94 discussing some of the issues around possibly changing some of the, fine-tuning, I should say, some of the definitions of those members who will be on the Midwifery Advisory Council. I would like the board to know clearly that we want and need physician input on the council. We want and need one of the slots on the council to remain as a licensed obstetrician, licensed by the board of the Medical Board of California. We also do feel that there is room for some other input from interested parties. My personal preference, because I do believe that we are a partnership with the women in our care, is that the second public member slot that is open potentially be filled by a consumer of midwifery services. But it does remain to be seen. I recognize that we might not have that, and I do know that interested parties might not meet that definition. There will also be some regulations that are going to be proposed to you folks. You can see them outlined from page 86 to 91 in your packets. These have to do with not redefining, because we never could define in the first place appropriate levels of supervision for licensed midwives. But this has to do with the fourth attempt that we are going to try to have a definition for appropriate supervision that does essentially move the supervision of midwives into a realm that more resembles collaboration. We believe that if this does indeed pass, that we will have a much better climate in the state of California for protecting consumers. Another of the other regulation that you will see there is to finally authorize us to use the tools of our trade that our enabling legislation dictates that we be trained in. So in other words, those tools of our trades like ordering a lab work, ordering ultrasounds, being able to purchase and use the medications that are necessary for the well-being and safekeeping of mothers and babies, like Rogam, oxygen, extremely important that we be able to have these, Pitocin, anti-hemorrhagics, that we would actually have the authority behind us of regulation that we can purchase and utilize these tools of our trade. We are all pleased and gratified that legal staff and that the staff of the medical board has moved forward with trying to help us to gain these tools. And we do hope that these proposals do move forward. We have been talking for quite a while about the fact that the statistical reporting that we have been doing now for 4 years, we are about to move into our 5th year of reporting, has difficulties associated with it that we are trying to fix by moving our reporting to be initiated through the Division of Research of the Midwives Alliance of North America. This program is prospective, and all data is reviewed by the staff of the Division of Research and validated if there are any discrepancies. We believe that by having this prospective data, we would be in a much better position to clearly understand the work of the midwives in the state of California. And I would like to repeat, as I stated at the meeting in the fall, I don't remember the date, that the 4 years that we have already had this reporting shows us to be doing good work, and that is without physician supervision. So I would hope that we will move forward in being able to get this better information so that the statistics can be clear about the good work that licensed midwives are doing in California. I have noticed today that a couple of items in the minutes, there are just a couple of omissions in things that I would have said, that I did say in my last report. And I know the minutes have already been accepted because I didn't notice them until today. So I would like to request that when the minutes are published, when they go up on the website, that our new chairwoman have the benefit of perhaps just an extra little note from staff that it's there, and to review the minutes so that she is sure that what goes into the memorialization of our reports is accurate. Do you have anything you'd like to say today?
Carrie, why don't you give us a little 2-minute background on who you are?
2-minute background. I don't know if I can do it in 2 minutes.
Well, then take 90 seconds.
I'll try. I am a California licensed midwife. I've been licensed since the first group of midwives that were licensed in 1996, 97. And I have a different position in my community than a lot of licensed midwives. I work in a private physician office, so I do have supervision, but I'm not attending any births. So I bring a different bent, as it were, to the chairship of the Midwifery Advisory Council. I am pleased as punch to see the definition of physician supervision getting some attention finally, as well as moving forward with ensuring the ability of licensed midwives that are practicing in a home setting to secure the medications and devices that they need to ensure safety for birthing women. What I would ask, At the last Midwifery Advisory Council meeting, we were going to ask the board to allow us to fill those 2 vacant positions at our March meeting, if that was possible, and ahead of board confirmation, full board confirmation. And so I would ask that, if that's possible to do at this board meeting, that it happen.
I don't see it on the agenda is the problem.
If you look at the,
It's under C?
Under 20.
Then I apologize. Then when we get to C, then I will ask for a motion, but we're not there yet. Got it. So it's on there. I apologize. I'm only still at A. Do you have anything else to?
No, I think that's good. I'm really looking forward to chairing this committee.
Thank you very much. I also want to recognize Faith Gibson, who is in our audience, who's been a longtime member of our council and has been around this issue, I think, since the 70s, as I remember reading. It's also her birthday, as I remember, so I would wish you happy birthday on behalf of the board. So moving on thank you. Moving on the discussion, I'm going to first bring forward, unless Mr. Spencer, you wanted to speak on this agenda item. Do you want to wait and speak on it now, or do you want to wait till Mr. Warden is presented and speak on everything on item number 20?
Stay here or not?
You wait, that's what I thought. Okay, Mr. Warden, would you please come forward and present on the items you need to present on? Thank you very much. I think that you can be excused from the table. Yeah, sure.
I think this is 2 Kurtz for the price of 1, right?
Yes, it is.
That's cute.
So to start out with is for the physician surgeon supervision for the licensed midwives. As you just previously heard, that they basically are not able to comply with that law with the way things have been working out. But they're required to have it in order to practice, and we have come up with what we think might be a solution to that problem, which is physician collaboration. And so we have drafted some draft language that would allow that to happen, but at the last MAC meeting, we did not have any physicians attending, so we do not have any physician input on what we have drafted. And so what we're asking is for the board to consider the draft language that we've looked at, but also to authorize us to do a interested parties meeting so that we get the physicians' input on it to see what we need to do to maybe modify it or make it acceptable. For sure that we would have that ability to make it go forward and actually be useful for the midwives. If we start the regulation process without collaboration of the physicians for what their input is, we would get that during the regulatory hearing process and have to usually start over, which is a much more lengthy process, which we're trying to avoid.
Questions?
Well, I thank God not an OBGYN to be caught in this moral dilemma, but it would seem to me that at the table needs to be an attorney, a lot of attorneys, but certainly for the malpractice carriers to see how they would interpret collaboration, to see.
That's what interested parties this meeting is about.
Let's not be vague, let's be specific. Attorneys to make sure, because a physician can feel this is a good thing, want to do the right thing, but they can't lose their malpractice coverage. They just dare not.
This is an issue that has been on the table for a long time, and we doctors feel that the malpractice issue is a serious issue. And
Dr. Salmonson. Continue, Dr. Carry on, please.
And at this moment, really, many doctors will want to cooperate with the midwives, especially in areas, for example, in the area that I work. But it's extremely difficult. The insurance carrier doesn't give you the green light to do that. And that's something very serious.
Dr. Levine?
Yeah.
I really appreciate the spirit of this effort to find a way through the dilemma that exists. And my only question about the language is that there is a big difference between agreeing to provide guidance and instructions regarding the care of women and/or newborns, and agreeing to provide emergency advice should complications develop. And that, to me, isn't an informal collaborative relationship. So it seems to me that binds the physician to being available should emergency complications develop, particularly if there is only one such collaborative agreement. And I'm wondering what the intent of that is, because that language suggests something other than informal collaborative relationship.
So let's make sure we're all on the same page, that we're reading all the same language, okay? So we're on page 88. Okay, so just make sure that we're all on the same page and we know where we are. So Dr. Levine, continue. Did you have a...
That was it.
You were just, thank you very much,
That's
Dr. Ganadev.
I have the same concern. I'm not an OBGYN, I'm a surgeon, but the professional liability issue for the birth or a bad baby syndrome is a serious issue. I want to emphasize that. That's where I am the medical director of a public hospital, and the highest settlements are on that note compared to anything else. So I think we got to be very careful here. Protection of the consumers, and that's the reason why physicians often don't, and there might be some other reasons in their mind, business related, but in my mind I think that's a big reason what OBGYN people I met with told me, as it wasn't a personal experience because I'm not one.
Dr. Diego?
You know, I do have a comment type of question. I don't know that we have the answer to it. And there is the malpractice and all that and the high liability, and that's where everyone gets stuck, right? But if that were taken away, I wonder if the OBGYNs would still be interested. I mean, I don't know that if you guys have gone off and explored that, because right now they can say very nice things and say, oh, I'd love to, but you know, malpractice, blah, blah, blah. But deep inside, would they? I mean, are we then going to come back and have a different set of problem?
I think the issue has been currently is that there are certain legal issues that do not allow this group of individuals to do what they have been trained to do, and one of them is even in the situation of having to have a woman go to the hospital because an emergency has arisen. The hospital may not take the patient in, that there's a liability issue, and that there's. I think that what we have to recognize is that this committee has been meeting. There's been a lot of frustration. It's been fraught with arguments and discussion. What we have are identified 2 or 3 specific issues that if those issues were dealt with in an official, appropriate manner, that maybe this would be an issue that we could then figure out what is going on. And to that extent, an interested parties meeting, which is what you're suggesting you have, would be the opportunity you would hear from this board as well, but you would hear from those people that are engaged and involved in that. And that's what your staff recommendation is on this, is to have an interested parties meeting to go forward and to move it forward. So I can appreciate that everyone is worried and concerned and very concerned, and rightfully so, but this is not where we're going, this is not the forum by which we're going to deal with this issue. The issue has to be dealt in an appropriate manner, just as any other issue that is raised that needs to be dealt with. So to that, I know I have public comments. I'm more than willing to hear everybody's comments about everything they want to talk about. But I want to ask you, do you have anything else that you want to explain specifically on this regulation 137, okay? Because if not, if you are finished explaining, I'm going to ask for a motion to approve this and the staff recommendation, and then we'll have public comment on that. Is that okay? Mr. Hepler, you advise me, please tell me.
Thank you, Madam President. From this side, you get to see everybody's full face, not just their profile from when I sit up there. So, candidly, although I'm sitting here, this effort is really the fine work of Ms. Scurry. And what collectively we tried to do was form this in a more collaborative relationship taking kind of a different spin on it than the traditional supervision requirement. And so that's what you see before you. I just want to comment that you will take public comment, but as an administrative board, I just want to remind everybody that civil liability is not really our forte. We leave that to the judicial system. Administrative discipline and that sort of thing is our forte, and we take our actions based upon the imprimatur of public protection. So, thank you.
Ms. Gray, I see you would like to add.
Yes, briefly. Given ACOG's changed position paper, which supports a collaborative relationship, it seemed like the time was right to try to bring this issue forth again. Although we haven't been successful, the board hasn't been successful in the past. And the board does, as a regulatory body, have a certain responsibility, not for the civil liability aspect of it, but to try to make sure that the law works and can be followed by the people who are licensed and are required to comply with it. It's very difficult if there is a catch-22 to make sure that the public is protected and that the license functions can be performed as the legislature contemplated. So that was really the reason for the language that you see in front of you. It is derived in part from the ACOG position statement and from other states' laws as well.
Thank you for that clarification. So may I ask for a motion? We'll continue the discussion, but
Yeah.
So move.
So I move
Second.
staff recommendation.
Second.
Thank you very much. So we're on page, we're on number B, so I've had enough comment, or I haven't maybe had enough, but I've had comments from the board. So I'd like to ask and entertain, does the public want to speak on this issue, B? Those that would like to come forward, I have Shannon Smith Crawley. Would you like to come speak forward on B?
Thank you. Good morning still.
Good morning.
Shannon Smith Crowley, representing the American Congress of OBGYNs in California. And we've actually worked a lot on this behind the scenes. And I think that there is some progress that's being made. To your point about physicians being willing to work with the midwives, they already are at their peril. If they get busted, if this gets found that they're collaborating, they have no insurance coverage. Whether the relationship is collaboration, consultation, supervision, it's basically the carriers have said, if you have anything to do with home birth, you will not be covered. Yet, there still are working relationships. You can see in the outcomes reporting that there are a number of working relationships already in place. So one of the things that you've done over the last few years that's really going to make a difference in removing some barriers to the physicians working with the midwives is the outcomes reporting. Because the liability carriers, I've had some initial discussions, and they're saying, well, if there's a book of business and we can underwrite the risk, we know what the risks are, and they, believe me, they had all kinds of stereotypes. It's like, no, it's, it's really, there is some good data out there. There are physicians working with these, with the midwives. Now that there is some outcomes data, they can look at underwriting the physicians. So regardless of how ultimately the relationship is defined in terms of the specifics of the supervision, we believe that the best outcomes for California mothers and the babies is for there to be a working relationship and to make sure that physicians are in the mix, that there's the consultation right now. Say, for instance, if you were a midwife and you had a patient and you had a question about whether she was still eligible for a home birth, or you just needed to send some, make sure everything was okay, it would be very scary to send her to a physician with whom you didn't have a relationship in terms of once she got to the doctor, what's the doctor going to say, and they're going to try and persuade them to have a hospital birth and not use the midwife anymore. So there could be some reluctance to really refer out to physicians when there should be. And then also the physicians that are working with the midwives now, they're kind of having to do a kind of, I know you're not having a home birth, but I'm not really knowing you're doing a home birth, and that's not really the best quality of care. So we think that the idea of having, we're at the point in time where I think we've got enough people that can really bring something to the table in terms of having an interested party meeting. We can have some liability carriers, and we also have a real asset that we haven't tapped yet, which is the state in the University of California self-funded or self-insured entity And there are programs such as at UCSF that are specifically looking at workforce and the roles of different types of providers, that there are, I think, a lot of opportunities out there, and I'd be very happy to work with the medical board in identifying some of these interested parties, because we really think that not that it would solve everything, but the single biggest, hugest barrier is the liability coverage, and so we support the interested party.
So thank you very much for your presentation. I also have Julie Feldsmith D'Angelo speaking on this specific 21B1.
Julie D'Angelo Felmuth from the Center for Public Interest Law. I have a suggestion for a different approach. And I made this suggestion about 10 years ago, but it was probably before the Midwifery Advisory Committee existed. Your paper here says, although required by law, physician supervision is essentially unavailable to licensed midwives, as California physicians are generally prohibited in their insurance agreements from providing supervision of midwives who perform home births, lest they lose their hospital privilege and insurance coverage. If the insurance industry is refusing to cover an activity of physicians which is mandated by law, we have an insurance commissioner here in California, and I suggest that you approach the insurance commissioner, Dave Jones, and his staff. I suggest that you bring representatives of the Department of Insurance to your interested parties meeting. The insurance commissioner has the authority to hold hearings on this issue, the extent to which the insurance industry is refusing to cover this activity or refusing to cut off physicians who provide supervision. The hold hearings, make findings, and actually force the industry to cover this activity. If it's required by law, and I know it is, and it's been there on the books for 10, 15, 20 years, and we've never been able to crack this nut, bring the insurance commissioner into this conversation.
It's a very good idea. Thank you very much.
Very good.
Ryan, so Mr. Spencer, you want now or you want later? Okay. Please identify yourself.
Sure. Ryan Spencer with the California Medical Association, and Shannon actually mentioned most of the comments, and we just want to officially support what she said. I mean, physician supervision is very important in terms of patient safety, particularly when there are medical complications. So if the board does decide to move forward with this action, the California Medical Association would like to be a part of the group. Thank you.
Thank you very much. Faith Gibson, would you like to come forward, please?
Faith Gibson, California, the Midwifery Advisory Council. I just want to provide a little background, which is that in the years before the passage of the LMPA, physicians were independently willing to provide backup arrangements for that every mother who was planning to have a home birth had some identified physician or an institution, such as a teaching hospital, that would provide care in the case of any kind of a labor that didn't progress appropriately, a medical problem, whatever the issue was. Once the LNPA was passed, which created, and there are documents that exist from ACOG and other places, that the creation of vicarious liability was actually the purpose of them having asked for that to be part of the law. The result of that, it did indeed create vicarious liability, or at least the assumption of it. The result is that the same doctors who would provide backup services or be willing to consult with us said they couldn't do that anymore now because their malpractice carriers wouldn't allow them to take on that relationship of vicarious liability. One of the questions that, one of the comments that frequently came up was that, well, if we as midwives had malpractice insurance, then that would make it different, that the reason that the malpractice carriers weren't willing to permit their I guess you call them customers, to do this was because they were the deep pocket. So I organized and administered for 3 years a malpractice consortium which covered not only licensed midwives in California but also nurse midwives and midwives in both New Mexico and Florida, all of whom provided community-based care. I did that for 3 years, and basically what we were told was, we kind of patted on the head and said, well, that's nice, but you know, any lawyer will tell you the only thing better than one deep pocket is two deep pockets. So it made no difference relative to the availability. That one of the changes that was made to the LMPA, an amendment to it in, I believe it was SB 1479 in the year 2000, was to remove some of the language in the original physician supervision provision and to replace it with a requirement that every midwife and every client that she provides care to have a document in the client's chart that identifies exactly where that client would get obstetrical care during the course of pregnancy if there was any question, problem, issue, the desire to have any kind of evaluation, a test or whatever, or to be evaluated for a complication, or if she needed, who would she transfer to if suddenly she developed high blood pressure or whatever. And then the same thing for during the labor and the birth and emergency arrangements for if there was, in other words, an elective transfer during the labor or after the birth, either for mother or baby, and then what was our emergency arrangements. So that's already been going on. So I appreciate the concept, the conversation about the safety of the patient, but I do want you to hear that for 19 years, we have been doing exactly what I had described to you. We have not had supervision available. I live in Palo Alto, which is where Stanford Hospital is. You would think that would be the hotbed of access to avant-garde, care of whatever kind, including cooperative obstetricians. I have 0 people who are willing to be on the books. That what we actually do is a process often, I probably more than 50% of the people that I provide care to actually have concurrent care. And part of that is because they may have Kaiser, which is a little different kind of a situation. But they often, particularly for first-time mothers who have a fairly high transfer rate, not based on complications, but simply that the labor doesn't progress, that they decide that they want to have a pain medication, epidural, whatever, is that they are receiving concurrent care from an obstetrician. But even for that to occur, we have to do the don't ask, don't tell, which is that they don't tell their obstetrician that they're seeing a midwife. I just hate this. I used to be a labor and delivery room nurse. I remember the good old days when we were when obstetricians and me in my position as an L&D nurse were on the same side. We were a team. And now we're, I don't know what to say, but, couldn't be worse.
Thank you, Faith. I have one more. Karen, did you want to, Karen, speak on this? You need to really wrap it up quickly because we need to move the agenda and vote on this. There'll be plenty of time at the interested parties meeting if that passes to talk.
I would like to address what Dr. Levine said. The way the regulation is proposed, that it says to provide emergency advice should complications develop. If a complication develops, we're transferring. I would like to personally see this say, and to provide emergency advice, or take out emergency. We're not talking about emergencies. To provide advice should risk factors develop.
Might I suggest that that's appropriate for the interested parties and not now?
I'm trying to address what the issues.
They're not going to vote on they're not going to be, if they want to come to the interested parties, they'll come to interested parties, otherwise you'll be at the table.
Can the regulation be changed via the interested parties meeting?
Yes, absolutely.
Okay, then just to also, to Dr. Diego, that there are significant numbers of OBs in the state of California who would like to help us. That is absolutely true. I also know there are others who don't want to help us, but that is another story.
Thank you. Ms. Fairbairn, did you? I'm going to pass. Thank you. Appreciate that. So moving, any other public comment from people I haven't heard from? Thank you. Do I have I do have a motion to,
Is it
yes.
too late for me to make a comment here?
Oh, no, please make a comment.
This comment is colored greatly by personal experience with a total disaster with a midwife who had an informal relationship with a physician in my small town. And they were caring for a patient in a large town. However, when complications did arise, they transported the patient 60 miles
Your microphone is not in front of you. They
large
can't.
town to the small town, the baby did badly, and everyone was sued except for the nurse, for not even nurse, but the midwife. It's really colored my opinion, so I have to tell you that up front. But I'm extremely concerned because of the informal relationship. I believe there's a matter in front of the board currently as well regarding the supervision of people in plastic surgery centers who are doing Botox and things like that. And that's of great concern to the board, and I think this should be as well. I think
It is. You should know for years it has been very important to this board for many years.
The informal aspect is very troubling to me.
I'll be happy to have you read all of the previous, okay?
I don't know all that, but
I will make sure you have the minutes, and you will see how important it has been and engaging it's been. Okay, so on the question of the motion, I have a motion to set a regulatory, where am I? For the workshop. So that's, I apologize. So I have the motion, it's been made and second. All those in favor of the motion, please say aye.
Aye.
Any opposed? Any abstentions? Okay, so it's done. Thank you, Mr. Warden. So now I have the question. It is, my executive director here is very nervous that you won't eat on time. It's now 11:45, so the suggestion is that we take this and break this agenda item up into the parts that it exists as, and to take a break now. So we're going to take a break now for 15 minutes, and we'll convene back here at 12 o'clock. We have a speaker, and lunch will be taken in this room by board members.
Back at 12.
If you need to check out, check out. Bring your stuff down here to be down here. Do whatever you need to do for 15 minutes.
Yeah, can we bring our lunches back?
Looks funny. Okay, we're going to rearrange the agenda a bit. We're going to move to item number 17 for a noon presentation with Ms. Dower on California's healthcare workforce. If you'd come forward, I'll be happy to introduce you. Catherine Dower is the Associate Director for Research at the UCSF Center for Health Professions, where over 15 years she has led health professions research and policy efforts. She directs a national innovative workforce model in healthcare projects and co-directs the Health Workforce Tracking Collaborative and co-directed the Pew Health Professions Commission National Task Force on Healthcare Workforce Regulation. She received her undergraduate and law degrees from the University of California, Berkeley. Go Bears.
Thank you.
And is licensed to practice in the state of California. Just a UC family, what can I tell you? So welcome and thank you, and look forward to your presentation.
Thank you very much. It is good to be here, and I'm pleased that some folks are still talking with UCSF this week. Many people, including my children and their friends, are shunning us because we're the folks that recommended that sugar be regulated this week, the way alcohol and tobacco are. So we're not so popular in some circles. But today I'm not talking about sugar. I'm going to be talking about the healthcare workforce and California's readiness in terms of workforce for implementing the ACA. I don't have control over the slides, so I'm going to ask somebody. Oh, there you are. Thank you. So next slide. This is a project that we conducted at the Center for the Health Professions with a team of people. I work with a great group of colleagues that put this together. The funder was the California Wellness Foundation. They came to us and asked us to look at the California workforce, health workforce, in light of the Affordable Care Act, since California is moving forward with implementing. And we had a specific impetus and encouragement from the governor's task force that was put together in the prior administration because of the concern that California might not be ready should we move forward with implementing the recommendations or the full act in the state. Next slide. We put out two reports, two publications out of this project. One is a big chart book. It is heavy and super fun to read. And then we have a smaller issue brief that captures the essence of it, we hope. The report is also online, of course, and we encourage folks to take a look at that if they can. Next slide. Our methodology was a series of key informant interviews with key leaders in the state around this topic, and then we purchased the full master file from the California Department of Consumer Affairs on all the licensed professionals, healthcare professionals in the state, and we also did a full literature review. So the fuller chart book here includes charts and tables and graphs, as well as a bibliography, an annotated bibliography of all of the research that we could find on California's health workforce. So it's a good resource for anyone who's into the geeky numbers as well as the literature review. And then we did an overall environmental scan of the topic. Next slide. As I said, it is available online. If you hit the slide twice, you'll see a couple of circles that can help you find it. Our website is futurehealth.ucsf.edu. Just tap the forward button and you'll see some, next slide. There you go. See, it's a build slide. One more time. There you go. Ways to find the report on our webpage, either through the publications section or from the home page there. Next slide. And this is the summary on the website of the two reports. Next slide. Tap, tap. Sorry, I'm not used to having somebody else do this. Next one. Thank you. And we'll go forward. I'm trying to go through quickly these first few introductory slides. And this is, if you get to the main report, it is fully bookmarked, so you can use it. We hope it's user-friendly, so you can flip back and forth between the various charts and the literature articles and the graphs that we have in the book. Next slide. And what we have in here, from audiologists to physicians, we have all of the professions for which DCA has licensure information. We've put together first a chart that shows the number of new licenses per year from all of the decades that we have information for that profession, usually from 1980 or so, or sometimes earlier, to current. So number of new licenses per year is graphed out. And on the next slide, we also have a map showing the distribution of licensee per population. So it's a ratio map by county. And so we have those for each of the professions throughout California. We have the graph and the map. And the next slide. The key findings, so if there's anything to take away from my few minutes here, health workforce is a major part of the labor sector. It was one of the very few, I think it was the only labor sector that grew during the economic recession in the past couple of years. We expect continued growth. Today's numbers were very impressive. Everyone's listening to and talking about the job report this morning. Estimated 5 million jobs in healthcare. It will be the driving component of the job creation in the next decade. 5 million jobs added to the roles in the next decade, and California is expected to see about 10% of that, so probably 500,000 more people employed in healthcare over the next next 8 years or so before 2020. The big problem in California, though, is not the numbers. We have a lot of practitioners, and I'll go through some of those details in a few minutes, but we are maldistributed. They're not practicing evenly across the state. So some counties are very well supplied, and some areas within those counties are extremely well supplied, and other areas very undersupplied. It's not surprising the urban and suburban areas, particularly those along the coast, are very well supplied. The upper northern counties and the inland areas are not so well supplied. And this holds true for virtually all the professions. You can go through each one by one. There's some variation. There's a few professions where, and I'll point those out later, where they tend to practice in the underserved areas a little bit more than other professions. But overall, we've got a major problem, and that's the big takeaway message. It's kind of sobering. I've been doing this work for a long time now, looking at workforce issues, and I'm still sober when I flip through the book and map after map after map shows those northern counties undersupplied and the Bay Area oversupplied. So that's the big problem. Aside from the ACA, we have a growing population, we have a more diverse population, we have an aging population, which is really nice for those of us who are getting older and living longer, but it's putting a strain on the workforce and the healthcare delivery system. And we have a changing disease burden overall. And all of that's happening parallel to and quite aside from ACA. But we do expect that if ACA is fully implemented, which California is definitely on track to do so, it's going to strain the primary care providers first in this state. That will be the major burden. Then that will roll over to some of the other associated professions, including imaging and lab, clinical lab, pharmacy, and some of the health education and counseling professions as well as mental health. Next slide, please. Just so everybody knows that what we're talking about in terms of the workforce in California, as of February of last year, so data is almost a year old now, but it's as good as we could get, we had 840,000 licensed or registered professionals in the state. Nursing is by far the largest category. And this number, or this pie chart here, does not include a number of professions that are not licensed or regulated in the state. So this doesn't include the medical assistants, the home health workers, and community health workers and others, many of whom make up very large numbers, so that we easily go over the 1 million mark of healthcare workers in California. So just we keep that in mind as we're going through our work. Next slide. We organized the analysis of our report into some questions, 6 major questions. What are the drivers that affect workforce quality and quantity? Can the current health workforce meet the changes in demand? Are there other sources of healthcare workers? Do we educate enough providers to meet the state's growing needs? Are our healthcare professionals reflective of the state's racial and ethnic diversity? And what policy solutions can help California meet the changing demands? So our analysis, again, the analysis you can find in the issue brief or in the first couple pages of the executive summary, so you don't have to wade through the whole document to find the analysis. On the next slide, I'll start going through that first question. So the drivers, as I've already mentioned, we've got some major demographic shifts in this state as nationally. We have an aging population. California has a growing population. We continue to attract people, and people continue to increase the population here. It's increasingly diverse, as we all know. We have a large and growing English as a second language population. So those are some of the demographic shifts that are really putting some pressure on the health workforce to meet changing demands. We have growth in health information technology, everything from electronic health records to telehealth modalities, which putting a strain on the way care is being delivered and practiced in the state. We have new models of care, and again, this includes not just things like telehealth and technology, but financing and delivery models such as ACOs, patient-centered medical homes, retail clinics. There's a lot of new models being tested and demonstrated right now, and those are changing the way care is being delivered and the way the workers are being used in those sites. And then, of course, we have the Patient Protection and Affordable Care Act. The best estimates in California right now are that we anticipate 3 to 4 million newly insured Californians starting in 2014. Those numbers vary a little bit. We have about 8 million people who are uninsured right now. So these are fairly conservative numbers. It might be as many as 6 million. In any event, it's going to be a lot of people knocking on the doors starting in 2014 looking for care. Next slide, please. That second question that we had to outline our work, can the current healthcare workforce meet the changes in demand? Again, maldistribution is the biggest challenge. We have people working and practicing in areas that are very well supplied, and it tends to be in some of the professions, in particular medicine is one example, the more we produce, the more they go to those already oversupplied areas. So for every, Dr. Kevin Grumbach did some research a couple of years ago, for every one physician who goes to an underserved area, 4 more go into the already well-supplied areas. So the gap keeps getting worse. So the maldistribution is the biggest challenge. And we were very careful about, we don't say shortage in this report. And I know, and we're taking a lot of heat for that. I have to put on my armor to go into some circles when I say we couldn't find acute shortages. However, there are shortages, we can't find acute shortages overall in the state. There are shortages, of course, in some of these rural and underserved areas and in some inner city communities as well. But overall, we've got the numbers. It's just where people are practicing. We have a lack of cultural and linguistic concordance that may be limiting access. So for many of the professions just don't reflect the California's general population. And so that's problematic in terms of culturally competent care and in terms of language. We have incomplete or insufficient data that limits workforce planning, and this is where we get really geeky about our numbers, but it's problematic. We can't compare right now. I can't do a map that shows you how many primary care providers are practicing in which county. I can tell you how many physicians, because the medical board collects those great data. We're very pleased with that. It's terrific. But the nurses don't collect the same, they don't use the same standards. They use a sample survey, and they don't ask people, particularly the nurse practitioners, where they're practicing. So we can't do a geographic distribution for primary care providers. We know where their mailing address is. which is a proxy, and we use that proxy for our maps, but we don't know exactly where they're practicing. So we've got some problems with the data. And as I said, we do expect that primary care is likely to be the most impacted in this state and across the country by the increase in demand. When Massachusetts expanded its coverage a few years back, the primary care providers it was an extreme burden, and it took 3 years for that to level out. It took a long time. So people who were new to insurance had a hard time getting appointments, and people who are already in the system, of course, were competing now with a lot more people. So we do anticipate, and that's the only example that we have, and it's hard to extrapolate to the rest of the country, but that's all we have right now. So we expect that there will be a big burden on primary care. And within primary care, it's probably going to be on the safety net institutions first. So it will be on the community clinics, it'll be on the community health centers, the rural health centers, and some of the safety net hospitals, the public hospitals and such. They're going to be the ones who are hearing from the newly insured under the Medicaid and exchange programs most likely. Next slide, please. This is a snapshot of one of the pages in the report about this is the one group that has probably seen these data before. I'm giving a lot of talks, and these are new licenses issued per year between 1980 and 2010 for medicine in California. And you can see a pretty steady increase starting around 1995 or so. And most of this growth, as you probably know, is from out of state. People moving in. The medical schools haven't expanded that much, and where they have, it's been in very recent years, so we wouldn't have seen that growth. So most of the new licenses are coming from out-of-state people moving into California, as California is still an attractor state. We still bring more people in. Next slide, please. Sorry, you can't see the slide on the screen, but those of you who have the handouts, we have a snapshot here comparing the DCA, so the Department of Consumer Affairs master file data on physicians to the medical board data. And again, we highlight this in our report because you have done a terrific job collecting much better data on where physicians are practicing, what they're doing, whether they're practicing at all versus the DCA file. You really can't tell for most of the professions if people are practicing. It will list if they're active, but active is a very loose definition. So in the overall takeaway from this page is that the medical board data are usually much lower, much more accurate, much more nuanced, but the numbers are much lower than the DCA numbers. So there are examples here. San Francisco, for example, there's over 700 physicians listed per 100,000 population in the DCA master file, and much fewer, I can't even see the number now, but 200 or so. Thank you. 370. I should get my glasses out. 370, yeah, on the medical board. So it's a significant difference. So it's important, and we're using this to highlight what other professions might be able to do to get better data, more accurate data, because we do think that the medical board data is more reflective of reality and is more meaningful. Next slide, please. This just magnifies it a little bit for you. Highlighting, again, I just pointed out the San Francisco example, but another example to take note of are some of these very small counties where statistics can play games, it appears. Alpine County, for example, DCA file listed 85 physicians per 100,000 population. We think that meant that there was one physician in Alpine County, and then that person left. In between, the DCA master file was on a different date than the medical board data on this one particular slide here. So with one physician leaving, that dropped it down to 0. So just being aware of the differences in statistics and the meanings that can bring to you. Next slide, please. And this is the distribution of physicians by county in California. For this one, we use the medical board data. Again, it's more accurate, but it does highlight the congregation of physicians in the Bay Area and Sacramento areas, and a little bit down in the LA, San Diego area. But we have many counties where we have very low ratios of physicians to population, and that's been an ongoing problem for many years, and as I said, it seems to be getting worse rather than getting better. Next slide, please. This slide is a comparison between the primary care physicians and physician assistants. And we put this up here just to show you that the physician assistants do tend to, the ratios are a little bit higher in those areas where the physicians are not practicing as regularly. So and then in contrast, in the Bay Area, which is highlighted there, we have fewer ratios of PAs to general population and higher ratios of physicians to population. So we are seeing some spreads that are interesting when we do our analysis. Next slide, please. And it's not peculiar to doctors. We see a similar distribution when we compare dentists and dental assistants. So a little bit higher ratios of the dental assistants in the areas where dentists are not practicing. Next slide, please. Some of the solutions and recommendations that we, in collaboration with the experts that worked on this report, the key informants, include increasing training and residency opportunities in the underserved areas. We know that people tend to stay in the areas where they do their residencies. Although that data has been based on experiences where the residency programs were in the nicer areas, so we haven't tested that out to compare the more challenging areas yet, but we do see overall across the country that people tend to stay in the areas where they do their residencies, so we're recommending that we do increase those opportunities. The loan repayment programs work at the state and the national level, and we could expand those. Many of them, the slots are not getting filled, and we could put more money into those. There's good data on those, and the people do stay. We can enhance telehealth, and that's being done. And some of you have been working on the legislation and other efforts, and it does range from the new legislation passed here in California, AB 415 last year, to all of the pilots that are being done and the demonstration projects that UC Davis and others are part of. So those will really help the distribution problem. There is a recommendation to expand the legal scope of practice for NPs and PAs, consistent with the IOM recommendation that came out last year to go along with the consensus model, that the APRN consensus model. The California could move to that to make sure that nurse practitioners in particular and PAs are practicing to the top of their competence. We do need to improve workforce data collection, as I said, and the medical board could be a leader in California in sharing what you've done with the other professions and working with OSHPD, which is working on the clearinghouse. And then, as I said, the safety net providers are going to be feel the biggest strain as we implement the ACA. So that capacity needs to be built up, and we are recommending a lot of attention being placed on and investment being put in the safety net providers because they're going to feel the strain at first. Next slide, please. In terms of other sources of health professionals, California does rely on foreign trained professionals, particularly in primary care. 31% of the primary care physicians were trained out of this country, and a quarter of the nurses. We don't have real good data on people who are trained in California, where and when they move from California and where they go. So that's one of the data points that we don't know much about. Next slide, please. Do we educate enough providers to meet the state's growing needs? Over the past 10 years, we've seen a decrease in family medicine residency slots, not what we need in the state when we're trying to enhance primary care. We have oversubscribed training programs in many of the professions. So as I'm sure most of you have heard, nursing is impacted. Many of the programs are impacted. You can't get into them. At the same time, we have very high attrition rates in many of the community college allied health training programs. So the programs are full and people are not completing them, so they're not able to actually start practicing the profession. We have low graduation rates among traditionally underrepresented minorities, making it very difficult to diversify some of the health professions. And we need more health information technology professionals, not only the individuals who are going to use the information technology, but the people who are working with the people who are going to be using it directly. So the full range of healthcare professionals need to understand and be trained in health information technology. Next slide, please. The recommendations in this area include encouraging medical students to practice in primary care. That's a small statement that we could spend days on, I know, but there are some examples out there of programs that are working. There are some good models. We need to evaluate those and expand and replicate those where we can. We are recommending to the expert group recommends refocusing some of the education resources in California on nurse practitioner and PA training, just because it's a much quicker return on investment. We can't possibly train enough primary care physicians in the next couple of years to meet the demand, but we might be able to train a few more nurse practitioners. Excuse me one sec. We also have some models out there that do work for retaining people in the community college health careers programs, wraparound services that really work for folks. So again, we need to evaluate and replicate those where we can. That's a shame in this state where we have so many people that are not finishing those programs. And of course, we need to invest more in primary and secondary education programs. We don't often have the people that are prepared to go into the health profession programs the way they should be. Next slide, please. This is just an example where nursing, back in the late 1990s, we were saying, gosh, there looks like it's going to be a shortage here in nursing, and there was a lot of money and investment made at the state and the national level. It worked. It's amazing. There's a number of new licenses issued by the nursing board each year over the past several decades, and the increase in the past couple years has been significant, to the point where, and this is the word of caution, that we've gone a little too far. We have a lot of nurses coming out of programs who cannot get jobs. So we need to be smart about this. We can't have the knee-jerk reactions, which is one of the reasons that we're real careful about using that word shortage. We can't use it too broadly, because the reaction is often an overreaction, and we end up with people who are trained and competent and cannot get employment. Next slide, please. This is about the diversity. The California Wellness Foundation is extremely interested in and committed to increasing the diversity, ethnic and racial diversity of our health professionals. 5% of the state's physicians are Latino, 7% of the dentists are Latino. We're doing a little bit better with physician assistants, it's over 20%, but 37% of the state's residents are Latino. So there's a big disconnect there, and it's not getting better very quickly. The estimates for newly eligible people under the Medi-Cal program starting in 2014 are that more than half of them will be people of color, and that about a third of them or more will speak English less than well. It's one of the official census groups, and that's problematic. Many of the physicians and other health professionals in California do not speak a second language, and there's a disconnect. We have language access problems in this state that continue. Next slide, please. Solutions on this. We need to invest in interpretation. California still doesn't have a recognized standard interpretation training program or certification or regulation for interpreters. We need to train more community health workers and promoters and health educators. They serve as an excellent link between the health care services and the communities in the state, but we don't have enough of them working throughout the state. We can build better career ladders for the more diverse allied health professions. The allied professions are more diverse than the medicine, nursing, pharmacy, and dentistry, top of the list there. But it's real hard for many people in the allied professions to move from allied into those other professions. We can replicate models that do work, such as the PRIME model at UCSF, to retain underrepresented minorities in the training programs. And we can include communities of color in the planning processes for ACA implementation in the state. So there's a lot of planning going on, and we want to make sure that communities of color are included in those conversations. Next slide, thank you. So this is a summary slide. Moving forward, just a couple of comments. The challenges are going to be this growing pressure on the safety net providers. That will be a big problem starting in just a few years. They're already strained. The community clinics, the rural health centers, and the safety net hospitals, public hospitals are already strained, and we're going to see an increasing impact on them as we go forward. The biggest issue with distribution and supply and demand is this maldistribution again, and then we have diversity challenges, the racial and ethnic diversity challenges. There are promises, though, with the workforce. We do expect to see continued job growth despite the recession and now coming out of the recession. We do expect that the workforce will be a significant factor in a big sector of the labor market. We're putting a lot of attention on the new finance and delivery models, which may decrease costs and also improve access and quality of care at the same time. So we're looking closely at everything from the little teamlet models in primary care that Dr. Bodenheimer is working on, to the retail clinics, to the ACOs and the patient-centered medical homes. All of these new models really will change the workforce, the needs, the way the ratios are set up between the who's working where and who's working in what teams. And that shift is what we're tracking right now, because it's not going to be done the same way it was done in the past 10 or 20 years. These new models really are going to change the way care is being delivered, and we're tracking that in terms of the impact on workforce. And then, of course, as I've mentioned several times, information technology is going to effect. It's part of the problem and part of the solution. At first, it really does increase the amount of time and money that's spent on patients, but it has long-term promise for improving access, improving quality of care, improving safety, and hopefully reducing costs long-term. Next slide, and next slide. That's it. I was talking fast. I'm open for questions. Anyone can contact me as you, if I can't answer questions here as well.
Okay, I see you're going to have lots of questions, but I want to thank you first very much for your informative presentation, and really thank you for being here today with us.
You're welcome.
I'm going to start at one end, and we'll just come around the table. Dr. Lowe, do you have any questions for our guest? Dr. Bishop? Dr. Diego?
Yes, I was wondering, does the study show where these newly eligible patients are going to be? Is there a distribution? Are they going to be mostly where there is that maldistribution of providers as well?
That's a good question. You know, UCLA is doing some more nuanced analyses, and I haven't seen the latest data. They're trying to figure out geographic distribution. We do know that nationally the studies have indicated that the distribution will be, they're going to be in the places where the providers who offer Medicaid services don't tend to be located. So there's a disconnect between, nationally we are seeing that where the patients are going to, where the new patients are going to be insured are going to be places where we don't have enough providers who take Medicaid. So nationally we do know that that's a problem. California, I can't tell you by county because I haven't seen the latest data out of UCLA, but I would expect that would hold true in California as well.
Dr. Giusso?
Okay. Do you have any further thoughts on how one might increase training and residency opportunities in the unserved areas, particularly with the limitations that we're familiar with these residency caps and reductions and so forth?
Yeah, again, that's one of those questions that we could spend a couple days on. I think that there are a lot of right now, some of the clinics and some of the providers are looking at ways to set up training programs and residency programs in areas where they haven't been doing it before. So that's going to take some creative new ways to approach it, new partnerships, but people are trying to figure out ways to do that. And I think that, but that's going to be a lot of work. We don't have an easy answer right now. The goal, though, is to improve those or increase those training opportunities in the underserved areas, but it's going to take some creative approaches to figure out how to do that given the limitations. I agree. Mm-hmm. But it's definitely worth some increased attention and people talking about it and meeting about it.
Thank you.
Thank you.
Ms. Chan?
In your workforce numbers, do they include the DOs?
Yes.
Okay.
No, I mean, we do include DOs in the report, of course. Some of those charts that I showed you were only talking about medical doctors, so depending on which chart you're looking at, but we definitely included DOs in our analysis. And when we're talking about primary care, they are included in the numbers.
Yeah, because I had dinner one time with Mike Honda and Regina Benjamin. Both of them are in the top of the health thing. Regina's Surgeon General.
Yes.
And she was saying one of the focus should be, now I know I'm talking about this in medical board, but it's actually increasing DO population because they make the best primary care doctors because of the way they're trained. Now, I know some of you probably totally disagree with that, but I'm just saying that.
Thank you. It's a good point. I would just, you know, in our analysis, we didn't make a judgment call on who's better or worse, but we did, you know, when we looked at national numbers, the DOs are the ones who made up. So in the headlines over the past couple of years, everyone's seen the headlines saying that we have fewer people going into primary care. And the numbers show that fewer U.S. medical school graduates go into primary care. That number is going down. However, the DOs are increasing, and the number of DOs and the number of foreign-trained medical students outbalanced the decrease in people from medical schools, U.S. medical schools, going into primary care. So the absolute number has increased in primary care because of the DOs and the foreign-trained medical students going into primary care at greater rates than the number of U.S. medical school students who are not going into primary care. So it's a real interesting phenomenon. So I don't know in terms of quality, again, I won't make a judgment call on that, but in terms of numbers and ratios, DOs tend to go into primary care at much higher rates than allopathic doctors.
Okay.
Thank you. Dr. Salmonson?
Well, just, you know, it is a kind of a confusing calculation because, and somebody else made the comment, there's a difference between, you know, the number of insured people and the demand. I mean, if the demand is there, it's now that they will have presumably the coverage. So I mean, the demand is probably already there. And I thought the theory was it's being played out in like emergency rooms or urgent care. So hopefully when primary care is in effect, that people are getting their primary care, and hopefully it will improve the pressures on ERs. Do you have a way to analyze that, to say what percentage of ER visits really would have been primary care visits, and that, you know what I'm saying, there'll be a little shifting of where the care is delivered?
Yeah, it's a good point. All I can say is I can point to the most recent data indicate that most ER visits are actually by insured people. So, yeah. And then the other thing is that the analyses show that people who don't have insurance now tend to not have a primary care doctor. I mean, when there is a problem, they might go to an ER, but they don't have primary care, and they don't have, many of them are, well, some of them have chronic conditions that haven't been treated. So again, the Massachusetts example is the only one that we can point to right now in the United States where they did the same thing and there was pent-up demand. And no one knew how to predict it prior to that, but there was pent-up demand. Most of the people who are not insured right now tend to be healthier than currently insured Medicaid patients, so the population's a little bit healthier. However, they don't have primary care, and there probably is some pent-up demand. So it'll be interesting to see how it plays out. Again, nobody has a real good crystal ball, but there are some, you made some very good points, but there are also some,
Had heard that a lot of ER visits were in lieu of primary care.
That is absolutely true. That's where the expensive medicine is coming from, especially in your big counties, your larger counties. Dr. Ganadev?
Yeah, I think when you talked about the residencies, you're absolutely correct. When the people go into practice where they do residency rather than where they go to medical school, that's a misnomer for a lot of people. But the ACA does allow the outpatient family medicine training programs where the clinics, not just the hospitals alone anymore, who can train, and the cap doesn't apply when you first start the residency. The cap is the 3 years, you have 3-year time period where CMS gives you time. You can have as many as you want once they approve, but beyond that you can't raise the cap. So that's why if you work with clinics, it's important to let clinics know that they have to start with as many as they could support rather than try with a small number and try to go to bigger number. It doesn't work, then cap comes into place. One question for you is that have you looked into, as health reform 2014 comes and many of the uninsured get into health exchanges? Already there is a significant lack of physicians taking care of Medi-Cal patients. So when ACA comes, and ACA actually health exchanges reimburse much better than Medi-Cal. The reimbursement rates for exchanges is Medicare rates. So have you looked into see the access to the Medi-Cal patients? Is it going to further deteriorate as that comes on and physicians move away because Medi-Cal is the worst, 50th in the entire country to pay doctors and still cutting down 10% at a time? So have you done the study on that?
We don't have an analysis in here, but yes, and that's to your point as well, that the places where the providers are available to serve Medicaid patients, Medi-Cal patients in California, we're going to have other areas where we're having higher rates of people who are getting Medi-Cal insurance, and we do expect that we won't have enough Medi-Cal providers, or we don't know if they'll leave California. That's always that. There's always that cloud or that concern, and in fact, as you all know, California still is an attractive state for many practitioners for other reasons. But I don't know if they'll come in for the Medi-Cal. I mean, they'll come in to practice medicine, but not necessarily to provide Medi-Cal services. And that's why I did emphasize that we think that the safety net providers are going to take the biggest burden. I don't think there's going to be a huge number of professionals, particularly physicians, who said, "Oh, look at the ACA is in place now. Now I'm going to take more Medicaid patients." I think that it's still going to be. Some people will take a little bit more, maybe, but it's not going to be a huge shift. But we're going to see more people going to the clinics and the public hospitals for care. So I do think it will be a problem. I don't have numbers to give you, but I do think it will be a problem.
Mine actually was the reverse of that. My concern is that I'm not worried about physicians leaving California. I'm worried about physicians leaving Medi-Cal program and not seeing Medi-Cal patients, instead actually treat patients in the health exchanges, because it is a better reimbursement model compared to Medi-Cal. So that's where I was wondering if you did any studies.
Thank you for clarifying. No, I don't have a study on that. I would expect it to be the same analysis, essentially, because I think some people will leave for that reason. There's a financial incentive to leave, yes.
Just a couple of things. In terms of the DOs,
Yes.
most of the DOs do allopathic residencies, and so when they complete their training, they are equivalent in terms of quality, competency. A relatively small percentage of DOs do osteopathic residencies. So, from my perspective, they're equivalent to MDs in terms of their capacity to practice. One of the issues that you didn't mention, and you may have done this, is looking at the gender distribution among the specialties. Primary care is increasingly a woman's specialty, and the percentage of primary care physicians working full-time is substantially decreased over the last decade, partly because of these are young women who are in their childbearing years, and partly because the burden of primary care practice is substantially increased. And so the numbers, I don't think, actually fully represent the gap between the need and the available supply. And I honestly think that the word encourage is a pretty weak word in terms of what we need to do to begin to close that gap. And when a trainee with $250,000 in debt finishes their medical school training and is making a choice about a specialty, looking at a starting salary of $130,000 or $140,000 as a pediatrician versus $350,000 as a cardiologist, that has a huge influence on the choices they make. And it isn't just about increasing primary care pay, it's also about narrowing the gap so that so there isn't this enormous magnet for specialty and subspecialty care, which is perfectly understandable. These are rational economic actors. So encourage, I think, ought to be, find a way to create incentives to make the practice more attractive and to make it more, relatively comparably financially rewarding.
Yes. Thank you. Those are terrific points, and I couldn't agree with you more. And I would just add to your point about the productivity, the physicians working full-time versus part-time, et cetera. Dartmouth, they're doing some great studies now looking at calculating the FTE physicians in primary care, because when we look at numbers of physicians in primary care, we still don't see a real strong correlation between numbers and health outcomes, which is like, it doesn't intuitively make sense, because we would think that if you had more primary care providers, you'd have better health outcomes, or at least better access to health care, which we don't when we look nationally. But when they look at FTE physicians who are actually practicing and providing a select set of services that are, when they look at the claims data, then they can do a better calculation, then they do see that correlation, which is really exciting. So I would just say that there's some research going in that direction to get a little bit more of the nuances there, but thank you.
There's also a strong link between the degree of linkage between primary care and specialty care in a community.
Yes.
The degree to which they talk with each other and they coordinate care and health outcomes, which isn't often mentioned.
Thank you.
Thank you, Dr. Levine. Dr. Simonson?
Well, I just reminded, when I was on a humanitarian trip to Cuba, I met with some physicians, and one happened to be a pediatrician, and all the doctors make $30 a month. But so did the daycare provider. So when she had a child, she said, why should I pay $30 a month to someone else when I can stay home and take care of my own child for $30 a month? So on every scale, it's driven by, cost incentive, even in that system.
I have a couple of questions. Is the information that you garner in reports like this shared with OSHPD?
Yes.
So that through, you have two members here that sit on the Health Professions Educational Foundation, where we're looking for programs to fund. We're looking for funders to fund the programs. So if there are creative models out there that are doing something to promote something that is dealing with the delivery of healthcare services, I would urge you to make sure that either Dr. Dussault or myself, but better yet, Health Professions Educational Foundation be well aware of the work.
Thank you. That's a good point. We work closely with OSHPD in their Health Workforce Department with Angela Minifield and such, mostly on the data side. So that's a good connection.
Well, that's
Thank
nice. You guys that are doing all your reports and all your statistics, I'm glad you like numbers. But you know what? Us people that are on the program side are trying to hear what we should be doing, and the numbers, there's a divide there, okay? There's information to divide. So if there are programs out there that you know about, or that may or may not, we want to look at them, but at least give us the chance to try and create it and replicate, because we are trying to reinvent the wheel, and I get tired of that. It's much easier to copy someone else, okay? That's number one. Number two is my understanding is with the nursing workforce is that because of the economic situation in the state of California being so poor, nurses are staying longer in their field, and therefore the issue of new nurses coming in are not getting hired. So that's one issue. The issue is also with the primary care physician. Everything is about reimbursement, and as Dr. Levine suggested, the idea of an incentive program might be something that someone else has tried, and if you're aware of that, that might be something that we should be talking to insurance companies. Someone mentioned Dave Jones before, Julie did, as we all have high expectations for him. But it seems to me that insurance companies should be paying a higher reimbursement rate to those doctors that are providing the services that need to be done. So if there's somewhere where the data that you're collecting can be delivered to the people doing the work,
right,
so that we don't just look, you know what I'm saying? There's got to be some connection, so.
Yes. Thank you. I will follow up on your invitations.
Thank you, please. Dr. Levine.
Yeah, just one other comment. One of the, and I'm sure, Catherine, you're aware of this, one of the bottlenecks, if you will, is that the residency review committees who accredit residency programs have a 1965 model of what a residency is. And so there's a lot of pressure on them to begin to look at more innovative models that are not hospital-based, but it has been a long, hard slog for innovative residency training programs. And I do think there's a lot of signal in the ACA to say, get off the dime and let's look at meeting.
Especially if the data is going to drive the discussion that gives them the impetus to be able to, for one institution alone, if UC would identify one campus, or Kaiser would identify a campus and take a look at doing some kind of a joint project funded by,
Yeah, the problem is you can't get a resident to come to a program if it's not an accredited program.
Right.
In order to accredit the program, there are the accreditation czars. And, I think there is beginning to be movement.
Yeah.
But it is one of the things that has slowed the rate of innovative programs from developing. And the other issue is insurance companies are actually beginning to pay more money for primary care physicians. It's too late. The issue is, what is the signal to the medical student about what their earnings are going to be long-term, and how does it compare to the dermatologist, to the radiologist, and to the orthopedic surgeon, which are also their options. So it's about the absolute dollars, but it's also about the gap between the subspecialties and primary care.
And that actually is where I was going and thinking is, I actually have personal friends, kids, and who originally set to become a primary care, get accepted and figured out the income level is so different, waited a year, went into radiology. So what I'm saying is, now this may not be proper, but if the DO is equally as good as the MD, now I'm saying this, I know that most of you probably kick me out later, but if that is a proper route for a good primary care physician, maybe, just maybe, the focus should be stimulate the growth of DIGO schools, the growth of the residency program, and because their training is a little different. I believe they only have 5 specialties or something like that. So they're more limited not quite. But I thought it's something worth looking into.
Yeah, thank you.
Can I add a comment to that? Sorry.
You've opened a whole bag of worms.
We're trying.
I just want to keep in mind, wait one second, I just want to keep in mind that we have a guest here that is in charge of a certain purview of what she's doing, and,
I know.
but please, feel free.
I was going to say, no, but I was going to say it's not as easy as you think because DO residencies, where I'm at in the Central Valley, we have a high need for primary care physicians, and they're trying to open a DO residency. In order to establish a DO residency, we need DOs. They're not DOs there, they're MDs. The residents tend to stay where they practice. You can't establish because you don't have DOs. The DO schools are somewhere else. They're not opening residencies there. They're not, in the places where the medical schools, DO medical schools are, they probably don't need, they're probably like, they don't need that, so it's a huge, complex problem, not easily solved.
So
the DOs have a harder time getting into MD. The MDs cannot get into DO residencies either, so.
So what I would suggest is to you, as a challenge, is where there are issues of licensing that we can do and be helpful, or where there's an issue of opportunities of programming, or where there's the opportunity of using some muscle and some clout, we're here and available.
Thank you.
So know that you've got a partner, whatever you're doing,
Thank
and
you.
I
And we're
appreciate
available
it.
too, so please let us know if you have any questions, but I will follow up directly with you on that.
Thank you
very much.
Thank you. So we're going to continue on our agenda and go back to item number 18, or 20, I'm sorry, we're on 20. 20B. And we have a discussion on the regulatory proposal for section 1379.23, which is physician supervision and collaboration. Are we finished? Oh, sorry, B. We're on 1379.24, midwifery practice, test drugs and devices. What I'm going to ask for is a motion, and then we'll have discussion on that motion, okay? Of authorizing midwives to obtain drugs, devices, and tests consistent with their educational requirements. There are some edits that have been included in your packet by staff for regulatory hearing. So I'm going to ask for a motion to do that.
So move.
And do I have a second?
Second.
Okay, so now can I have discussion on, Mr. Warden, did you want to present on this, Mr. Hepler? Or should we just move it along?
Well, never missing an opportunity to say something. Just want to point out that this is, again, Ms. Curry's fine work, and what it is an attempt to address a dichotomy in the regulations that talk about the educational requirements for a licensed midwife with no corresponding reference to what the scope of what the tools and implements that may be used in that practice. So this attempts to rectify that inconsistency by reconciling those things which the educational program for licensed midwife trains them to do by including that within their scope of practice.
Mr. Hepler, you have
Yes.
any, that's it for the comments on that?
Well, that's
Mr.
all I
Warden,
wanted
do
to
you
say,
have
Mr.
any
Warden.
comments?
I just agree with Mr. Hepler.
That's so good. So now, Anita, could you give us,
This is just an attempt to help remove some of the other barriers to practice that occur if they cannot get the supplies because the law doesn't, or the regulations don't specifically say that they may utilize these materials.
okay, do I have any comments?
Do
Dr.
we
Diego?
know why they were having a hard time getting the supplies? To begin with, is not in their scope, or?
Ms. Sparavan, would you like to come, or Ms. Ehrlich, would you like to come forward? And both of you, but I just want I don't want to, I would like to just have answer to the question.
We often do have difficulty obtaining these supplies. Midwives throughout the state have not been able to get oxygen, and that is an essential piece of safeguarding mothers and newborn fetuses and newborns. There are supply houses for medical drugs and devices. Many of them will not allow us to order from them because we are not authorized in our law to be able to have them on our own authority. And these are life-saving, they are life-protecting.
That's not the question. The
Oh.
answer is that you're not allowed to get
We
the
have not
medical
been,
house.
yes,
Thank
there have
you.
been midwives throughout the state who have not been able
Thank
to
you.
get these.
Ms.
I think the real answer to this question really is that there's no provision to date that allows a licensed midwife to obtain things that are normally obtained by a written prescription from a physician. And that includes oxygen and Pitocin and other.
Right, so the vendors don't recognize your license to be
Excuse-
able to.
wait, so-
Okay,
Correct.
that was my question.
Yeah.
Okay, what I'm going to ask for is people to present, and if you have questions, it's not to the presenters, it's to the, we can ask the questions, but they're not, they're not answering. So the public comment, I appreciate the answer, and I also have a public comment on that question as well from Faith Gibson. So if you'd like to come up and explain the same thing, I'd appreciate it.
You know, I don't really have much to add, except that we're doing what you would describe as a workaround, is that we try a variety. Some midwives will, for example, order Pitocin from someplace in Washington State or something like that. It's just this patchwork quilt, which the original idea was that if you had a supervising physician, all of these things would be handled through the aperture of your supervising physician. Since we don't, we have all of these, what I described before as workarounds.
Thank you. Okay, so questions can be addressed to Mr. Hepler or to Mr. Warden as they are in charge of this motion, okay?
Are any of the other allied health professionals in California legally able to obtain prescription drugs? Nurse practitioners, PAs?
Yes.
Yes, both, I'm counsel to the Physician Assistant Committee. They don't call them prescriptions. They do call them drug orders. And with the proper delegation of services agreement between the supervising physician and the PA, the PA.
Supervising physician.
And the
These
PA.
individuals do not have supervising physicians, correct?
Not in the same sense that a PA
Correct,
does,
they do not.
correct.
Okay. Would nurse midwife training include the same pharmacologic training and skills as a nurse practitioner and/or a PA?
So let's understand the
They're not nurse
question. The
midwives,
question
they're
you're asking, Dr. Bishop, are there other allied professionals who are trained, allowed to receive materials that allow them to do their job appropriately?
No, I'm asking prescription medications in the absence of a physician's prescription.
Are you asking prescriptions? I don't think that,
That's the crux of the matter.
but that's not what's being asked for here.
Well, it is. Because you can, if all of a sudden you say it's within their scope of practice to do anything, then they obviate all the rules that we have in place for prescription drug administration. See, I'm telling you, this nebulous discussion is opening a door to unintended consequences.
Anita?
They should not be utilizing prescription medications in the absence of correct pharmacologic training that's commensurate with other professionals.
Anita?
Is my opinion.
Well, you're not, it's your opinion. But we're trying to get questions
There-
answered
the-
about this.
Physicians' assistants and nurse practitioners, when they are utilizing drug orders or whatever you like to call them, your prescriptive power, do have a supervising physician, but then they are performing medical tasks. Midwifery is a separate type of practice that is not a part of medicine. I mean, it's hard to comprehend that, that's the way it's set up in the law as a separate type. This proposal does not allow unfettered access. It is the authority limited to the practice of midwifery to obtain and administer these particular drugs, immunizing agents, diagnostic tests, and services for which they are, in fact, trained in their 3-year program.
Okay, so Dr. Simonson and then Dr. Gunadev.
Maybe it's irrelevant, but in the other states that don't require a license or a oversight or whatever the proper term would be, how is availability of these supplies? Do you know?
I don't know.
If I can be so bold, I think some of this was taken, some of the initial research was done from other states such as Washington. Washington has much broader, licensed midwives have much broader authority to get things like that. They have a better comprehensive regulatory scheme than we do. They have more access to this type of material than California does.
Is there a medical board involved in any way with the midwives?
That I don't know the answer to, I'm sorry.
Okay, Dr. Ganadev?
Yeah, this is for Mr. Kepler. Does the law allow or authorize midwives to do this? My concern is statutory. What is the statute in California? Are we trying to make a law by regulation, or is there a law which allows this to be done?
Yeah, no, there is a law, it's called the Licensed Midwifery Practice Act, which upon these regulations are based. So we are not essentially venturing out, in my mind, somewhere that we're exceeding the scope of the existing statute. What we're trying to do is reconcile a dichotomy where we talk about the educational requirements in existing regulation, talk about that the midwifery education program, essentially the educational program, shall prepare the midwife to practice as follows. And that's, administration of local anesthesia and a bunch of stuff that I don't understand, in IV fluids, analgesics, postpartum, oxytocics, and ROGAM. So what we're trying to reconcile is the educational program, they get trained to do this stuff, but there's a block because we don't have essentially enabling regulations that says we allow you to do this. And for that reason, the pharmaceutical houses or the medical supply industry does not recognize the license of a midwife as the ability to essentially get these sort of products.
Just follow up on that. My understanding is that physician assistants and nurse practitioners are allowed by law to do what they're doing. So that's why, is there a law that these prescriptions, like oxytocin, I understand why they want these supplies. I truly, because they are delivering babies. But what I want to make sure is that does the law, when it comes to allied health, we need to see what the law allows. Okay. Is it similar to physician assistants law and similar to nurse practitioners law where they're allowed to prescribe?
To be candid with you, I do not have a lot of experience with the nurse practitioners. I can't speak to physician assistants because I'm their counsel. It's not exactly the same. Clearly, a physician assistant, in my words and my words only, are tethered to a supervising physician and surgeon. There is a delegated service agreement where essentially the supervising physician and surgeon says to the licensed PA, I know you have a license, but this is the sort of thing. Here's a little document that says what you can and can't do. That model is not necessarily incorporated within this licensing act. However, what's different, as my counsel has pointed out, is we've identified the scope and practice of midwifery as not something essentially that's the same thing as the practice of medicine. They're different. And so that's why this licensing act is a little bit different than at least the PA model, because essentially the PA model says, okay, you're sort of quasi-practicing medicine, and here's a little document that says what you can do. That model is not incorporated here. It's a little bit different.
I would argue if you're administering drugs and caring for patients, that's the practice of medicine. I think we're talking a definition here that I don't agree with. Should be subject to the same requirements that all other allied health professionals are subject to. I think we're trying to get around, as Dr. Yanadev said, legislating a law with a kind of a end around.
Okay, I have a public speaker's comment from Yvonne Chung. Would you like to come forward, please? I apologize, I didn't see it earlier. It wasn't that I was ignoring you.
You get tired of Yvonne Chen with the California Medical Association. I'd like to make a suggestion. Our concerns about this, I mean, we understand the situation that the midwives are in. However, because this is so tied to supervision and you are going to be holding an interested parties meeting related to the previous proposed regulations, our sense was that the extent to which we define what midwives can and can't do on their own authority is so closely tied to supervision that perhaps they should be considered in the interested parties meeting as well, because I don't think that you're going to be able to resolve this today. So, just respect.
Well, let me just for clarification purposes and without, I would just like to read just so we all get an understanding of what the licensed midwife can do. This is taken directly from statute so that we all can get kind of grounded on what we're talking about. The license to practice midwifery authorizes the holder, under the supervision of a licensed physician surgeon, which I think is, we just kind of talked about that issue in the prior item, to attend cases of normal childbirth and to provide prenatal, intrapartum, and postpartum care, including family planning care for the mother and immediate care of the newborn. So again, as my colleague has pointed out, that's what essentially the scope of practice is right there. Not exactly the same thing as medicine. It's differentiated because it's set out in statute.
Don't put your hands up for him. It's for me, okay? I'm going to call on Carlos Ramirez from the Attorney General's office because he's been waiting patiently to speak.
Good afternoon, Carlos Ramirez, Office of the Attorney General. I sense a certain degree of discomfort with this regulation, and perhaps I would offer the assistance of our office and perhaps drafting either a formal or an informal opinion as to whether this regulation either expands or expands or merely complements the practice of midwifery, and perhaps maybe some of the questions that have been presented by the board members could be addressed in that context. I'm just throwing that out.
Okay, thank you. Okay, so okay, Dr. Stolman.
I appreciate Carlos's comment, and that kind of is my thought, which is if we're saying midwifery is not the practice of medicine, and I respect that, then I would think we do not need physician supervision. And I think we should work towards, it's like that we don't supervise the pharmacist. So why should we supervise the midwife? I think they should have autonomy, and I would push for that.
Okay, what I'm going to suggest is, thank you very much, Mr. Ramirez, for your offer. I'm going to suggest that staff needs to get together with staff, and if they can use your services, I want to thank you very much for offering them. What I'm wondering about is that if I have a motion on the floor. It needs to either be approved or not. The motion specifically is, Mr. Hepler, would you?
The motion would be to set this for, direct staff to set this for a regulatory hearing at the next board meeting.
So if the will of the board is to do so, they'll vote yes, and if the will of the board is not to do that, they'll vote no. Okay?
Could you repeat that? I'm sorry, Barbara.
If the will of the board is to vote for the hearing, which will be at the next board meeting, they should vote yes. And if the will of the board is for that not to happen, they should vote no.
Okay, the maker of the motion would like to hear your opinion. How do you feel more this can be handled?
I am, to be honest with you, I think it's important for people that are trained to do a specific task, regardless of what that task is, to be able to do the task and have the tools that they need to do that task available to them. The need to bring the midwifery committee to a level of responsibility, transparency, accountability has been over and over and over in this board's purview for the last 10 years probably that I know about. It's been very contentious. It's been at times neighbors are talking to neighbors, meaning people sitting at the committees, groups of midwives are talking to other groups of midwives, are talking to other groups of midwives, and nobody agrees with anybody. And so what this board determined that it would do under the leadership of Dr. Richard Fantozzi and Dr. Lori Gregg, an OBGYN here in the Sacramento area, was to force the issue and to bring it into the umbrella for the time under the purview of the medical board. I think that they have made immense strides. This is not a vehicle for me personally, but on the issue of how things should be done as far as process. And I happen to believe in process and accountability and transparency. I think they've done an admirable job. I'm still saying this is for that community to decide what is best for them. If you tell me that you can't give somebody oxygen and you need oxygen to do your job, I have to listen to people that are using oxygen. I have a friend who's 95 years old who, for whatever reason, needs oxygen at night. There's nothing wrong. She tells her houseman to go down and get the oxygen tent and gives her the oxygen. Do I think he's trained? No, he's not. But that's, her doctors allowed that to happen. I'm not suggesting what is right and what's wrong here. I just think that on a go-forward basis, to get this, it's a profession, I assume, correct? Profession? To the point where we expect it to be professional, they need to have the tools of the trade to do their job. So on a go-forward basis, I would support their request.
Just trying to clarify what is the regulatory hearing the same as an interested parties meeting?
No, it's not.
Oh, okay. So the motion is for a regulatory hearing.
Right, to set the matter for a regulatory hearing, which essentially invokes us preparing a notice and a statement of reasons, opening up a comment period for written comments, also having an oral comment period at the next board meeting, in which then the board can hear those, can consider those written comments and the oral comments and decide whether to move forward or not.
It's not an automatic. It's everyone would have the opportunity again to hear the exact same conversation you've heard today, but maybe with more participants, more doctors, more anesthesiologists, more insurance companies.
And it would be on
If
the
you
language.
also have you also all taken a look at what the language is specifically? It's not as, I don't think it's as broad-based as we might think it is.
The
It's on
language
page
is on page
91.
91.
So if you look at page 91, it says, did you read it already, Kurt? Yeah.
License.
Did you read,
You're not.
I heard you read something. I didn't know who read what. Did you read it, Mr. Warden?
No, I did not.
So let's take a minute and hear what it's not like we're not talking about a whole big rocket science out there, but anyway. A licensed midwife shall have the authority limited to the practice of midwifery to obtain and administer drugs, immunizing agents, diagnostic tests and devices, and to order laboratory tests, period. This authority includes, but is not limited to, obtaining and administering intravenous fluids, analgesics, postpartum oxytoxics, whatever that is, ROGAM, whatever that is, and local anesthesia, oxygen, local infiltration, vitamin K, eye prophylaxis, diaphragms, and cervical caps. Note, authority cited, and then you have that. So it's very limited in scope. It's not that they're going to be administering Oxycontin or prescribing Oxycontin or antibiotics. It's very limited in what it is that they can do. This is stuff that they have been trained to use and are currently using. So it's not like it's something that just evolved. Dr. Bishop?
Analgesics, do those include narcotics?
No.
Narcotics are an analgesic.
No, but no, it's limited to what's here. It's not what's not here.
Well, but I think there's
It says
for-
analgesics.
Analgesics is a very
Analgesics-
broad term.
Right.
Oh, I don't know. I think
I
of
interpret that as
analgesics as
including
Tums,
narcotics
personally. I mean, I don't know.
Hmm.
I think it's aspirin. I don't think
Then
it's,
it should say aspirin. Then it should say aspirin or non-narcotic analgesics. I would be accepting of that.
so you would prefer, you would consider it a good addendum to have non-narcotics?
I'm certainly
That's
more
fine.
comfortable
Let's,
with that.
okay, if that's what's going to take,
How about cocaine? Cocaine's an analgesic.
And a local
I mean,
anesthetic as
anesthetic.
well, yeah.
Right, it's an anesthetic, so it's not.
isn't it a triplicate drug or something?
Scheduled drug.
Scheduled drug? I don't know from
What I'm
those,
getting
I
at-
don't take them.
We have physicians, and nurse midwives, I'm sure, are very honorable individuals, but we have very honorable physicians who circumvent the law all the time. And now we would be including another group of people who would have access, if they so choose, to an additional way to circumvent.
Okay, so would you suggest not, the term non-narcotic, because I don't know what, I know what a narcotic
I
is.
would suggest no prescription drugs, is what I would suggest. Because the
No.
law says under the supervision of a physician, which they currently do not have. So
No,
if
see,
approve
you need to
this-
understand that oxygen is a
Oxygen and
prescription.
ROGAM.
Okay?
And that would include ROGAM.
These are, ROGAM is a prescription. What I would,
I
instead
understand
of saying
that.
what you can, it's what you can't. Non-narcotic medication, I understand. No triplicate drugs, no,
Scheduled drugs.
no scheduled drugs. How's that? No scheduled drugs, Dr. Bishop?
That's more acceptable than otherwise.
No scheduled drugs. Can you add that into your legislation, Mr. Warden, Mr. Hepler, please?
Barbara.
Well, we would have to kind of amend the motion.
I'll get the motion to be amended after we agree on everything.
My point is, I think it is so complicated, and I do look at that physician supervision and that and the law which you just read it to me as very important. We're trying to do with collaboration now, so this might be a good place for interested parties to come really work with the staff and come up with something we can accept rather than continuously debate and keep adding not this drug, not this drug, not this drug. You don't want to also tie somebody's hands when they need. At the same time, they need to know the complications of the drug. I mean, there are a lot of issues. Drugs are not that simple. They might be great for 95% of the patients, but you have that 5% when there is a serious problem with it, you got to be able to take care of. So I think it is a good time to really meet with the interested parties. We already agreed this morning that we'll do with the interested parties. Why not?
Okay, so how about if we take this Part B, not like Part D in the insurance business, but Part B, and send it back to the Midwifery Advisory Council for an interested parties meeting at the Midwifery Advisory Council. How's that? They're not meeting till March.
Good.
We have time to get everything out, right?
Right, but why not? I mean, we have a motion on the floor.
Okay, I agree with you.
You might have
All right.
amend it to put it into
Do you want to
the
put it in,
interested
okay.
parties meeting that you're already going to schedule.
So you said
Would they show up at the midwifery meeting? Okay, so the issue is, what do we, Dr. Lowe?
You know, I think that a regulatory hearing is premature because there are too many definitions and issues that are yet undefined. I propose that we have a work group of interested parties who will lay a foundation for the board, present everything, all the definitions, explain to us what the training entails that they go through. And, you know, being trained 10 years ago doesn't make you current to use the drugs now. If you lay the foundation with this work group and present it to us in an organized fashion, then we can more intelligently make a decision about proceeding with a hearing.
When do we meet again?
That's a motion, I'd second it.
Well, wait, we have a
Not a
motion on the
motion,
table.
it's a
Wait. We currently have a motion on the table, so it's up to the maker of the motion to either change the motion, withdraw the motion, change the motion.
Well, we can vote on it. I think it's premature. That's my comment.
It's
It's
you're
premature.
more than entitled to your comment.
Well, we don't have to,
So we go. Okay, so I'm waiting for the maker of the motion to decide.
I think,
While we're
I
taking a
think
deep breath.
maybe I'd like your suggestion, well, maybe I should say, I still have the motion, I'm not changing that yet. I thought we want a discussion so everybody gets into a same place. I do like your suggestion of us taking it back to the midwifery, the one you were just talking about, committee, the one you were saying a while ago, before that motion comes up, before that suggestion come up. Would that be?
I think just from a time perspective, the issue is this. The issue is that it's now February. Midwifery Committee meets in March. We meet in May. The issue is that the members of the board don't sound like they're comfortable with what's going on so far, that they have questions and concerns out of deference to information or lack thereof. So the issue is to take it back to midwifery, hash it out there, and then bring it forward. When are you going to have the other? And had the, so if we did the interested parties meeting for both at the midwifery meeting in March, that way we would be able to come back to the board in May with all the information as Dr. Lowe has recommended.
Well, I like that.
The problem with the midwifery people. Microphone. The problem
problem with the people in midwifery doing it alone without the interested parties is they have.
No,
one
there would,
perspective.
excuse me, Dr. Lowe, there would be interested parties at that meeting. No, it would be a publicly noticed interested parties meeting in conjunction with.
Right, okay, how about we give it back to the midwifery council for a interested party and conjoin, I think you're saying
Right,
is
and combine the two meetings.
combined with the issues to
Or at least
be-
the same day, you know, we can meet, the midwifery can meet in the morning and the interest, or either way, at morning and afternoon. But do it the same location, the same day, everything, and staff will just be very busy.
Okay.
So you're amending the motion?
Can I modify my motion
Okay?
to that?
Okay, and who is the second? Dr.
Well, no, it was
Levine?
Lee.
Second.
Yeah.
Okay, so you accept the change?
Yes.
Okay, so now we're going to have discussion on the motion that's been changed by the board. Discussion on the motion.
I'm just not sure what that implies, that then we're ready to roll on the regulatory hearing?
No,
The next-
no, it has to come back to the board. No.
Okay, good. So what does
Regulatory
the
hearing is
No.
off the table
Right.
right now.
Right, there's no regulatory hearing right now. Okay, so now members of the public on the motion as it is. I don't have any slips, so do I see any hands in the air? So we don't. All those in favor of the motion as it stands, please say aye.
Aye.
Any opposed? Fine. No opposed, no abstentions? I'm sorry. All right, so now we're going to go to C. Not the ocean, but right here, sea to shiny sea, but on number 20C, consideration of the proposal to modify the appointment process to the council. You've heard that there's a motion, there's a proposal by staff to, where is it?
Sorry.
What page?
Page 92.
Kurt, and, Mr. Hepler, Mr. Warden, could you present, please, and tell us the page number you're on? 92, it's, I can see it's
92 to 94 is the report. We currently have 2 vacancies on the Midwifery Advisory Committee due to resignations. Prior to that, the board had advised or authorized the Midwifery Council to check into expanding their membership to add a couple of more public members. With these vacancies, this created a new opportunity for the MAC committee and the board to not expand the membership and instead revise how the current membership was, which would include the MAC committee had decided that they would still like to have a OBGYN on their committee, but they would also like to have a non-board licensee on the committee.
Excuse me, they'd like to have a public member, another public member
Right.
that happened to be a licensee.
No.
No?
What-
A user of the services, a non-licensee. I just want to be clear on what they wanted.
Okay, they want.
I don't remember.
They want one public member who is a OBGYN,
Right?
and they want one public member who is a non-licensee of the
Oh,
board.
okay, sorry, thank you, okay.
Of any type. So, with the resignations of the 2 previous public members who were both physicians, that gives us that opportunity. One of the physicians who resigned, their membership actually expires in July. So we are down to 4 members on the MAC committee at the present time. The MAC council is asking that the board allow them or instruct staff to do the notice for new committee members and for them to choose their appointees and for the board to allow those appointees to participate in the MAC committee on March. And those be appointed at that time for at least at minimum to participate in that MAC meeting and have a say. And then the final decision, it'd either be for the board to delegate their authority for the MAC council to actually appoint those 2 members or to allow the suggested appointees to participate in the meeting and approve them at your May meeting.
Thank you. So do I have a motion to do what Mr. Warden has asked, and that is to allow the MAC to put out a notice for 2 new members, one in OBGYN and the other for public member, non-OBGYN, at their March meeting?
I have a question first.
Yes?
How is it done normally? Do they have governor and legislative
No,
appointees?
no.
Who normally get on?
No.
What's the change, I guess, is what I'm
No,
saying.
the change, what has happened is that this body, the MAC, operates as, by virtue of this authority from the Medical Board of California. They have 2 vacancies. 2 doctors have resigned.
Right.
So they are asking for permission to put out a notice to, of people, interested parties that might, it's not like we're walking down the street and finding someone to do it. It's, people need to want to participate in a volunteer opportunity to sit on the MAC. That's all they're asking. Oh, please clarify.
In the past, when they had a vacancy coming up, they would send out notices, they would select individuals and bring them back to the board. They did not have vacancies on the board. The board would approve it. There's never been an instance where the board has not approved a recommendation from the council. In this particular case, there are 2 vacancies, so there are only 4 members of the council and no physician member. And so they're just asking to be allowed to go ahead through the process of finding 2 individuals to sit, one being a physician, one being a public member, to have them sit at the March meeting before this board confirms them as members. And then the question that has to be resolved is, do you want to delegate that to them, or do you want it to come back in May, but you have authorized those 2 individuals to sit in March?
Dr. Levine.
So can I make a motion?
Please, my pleasure to hear it.
Can I have a question before you?
No, you'll ask the question on the motion after after the motion's made, please.
So I'm going to move that we ask the Midwifery Advisory Council to work with staff to put out a notice to recruit 2 members as described, that they be invited to sit with the committee at their March meeting, and that the board formally approve them in May.
Thank you. Second for that motion?
Second.
Okay, now we'll have discussion on the motion.
Yeah, just questions for the staff. If we go this route, what's the composition of the committee? How many people, how many physicians, how many midwives, and how many public members?
It's in here.
Currently, the
sorry.
composition of the MAC committee is 6 members. Half of the committee needs to be licensed midwives, and the rest are basically public members. Those public members, one of our public members is Ms. Yaroslavsky, and previously we had 2 physicians. The public members can be anybody. The MAC
Anyone that's
Council
interested.
has asked that they would still like to have at least 1 physician on the committee, specifically in OBGYN.
Okay.
So that's what they're asking for right now, is basically to recruit, to see who's more interested in participating, and they would prefer to have 1 physician, hopefully that applies, and is who's an OBGYN, and they're hopeful that a non-licensee of this board applies for the other vacant public position.
Okay, so to answer Dr. Ganadev's question, if we went to 6 members like proceeding here, we would have 3 licensed midwives. We would have 2 public members that are not a licensee of the board, and presumably 1 physician who may be an OBGYN. Is that correct?
Should not be maybe. I think you probably prefer. But let me ask you, the next one is that, do we know the reasons why 2 physicians resigned? Or is it personal reasons rather than anything to do with the
There were
family?
personal reasons. Dr. Ruth Haskins has a very busy practice and 2 or 3 little children, and Dr. Frum was it was not an appropriate match for him.
Okay. I mean, after going through the discussion today, that's why I was just curious what the reasons were.
No, they unfortunately came right on the heels of each other, but it is what it is. Dr. Diego.
Real quick question. So the 2 physician vacancies, they weren't required to be physicians?
No.
Correct.
No, okay. So now I don't read this as presumed. I read it that this is going to be a licensed, right?
OBGYN.
Well,
I mean, the way this reads, right, it will be filled by an obstetrician gynecologist. That's the way I read it.
That's what they're asking.
That's what they want.
We're
But that's
hoping-
what's on the table. That's the motion. It's not like, that's not what
No,
they're
no, but
asking.
that's the reason it's the motion, is that's what the Midwifery Advisory Council has
I just want
requested.
to, I just want to clarify
wasn't
that it's
required.
not presumed or anything. If it passes, that's what we get.
Right.
We get an OBGYN plus
That's what we want.
two.
That's what they,
We
that's
have
what the
to assume
maneuver,
that we get an OBGYN who applies.
that's what they want.
Right, I know that's what
Yeah.
they want, but I don't want to hear presume, assume.
Well, we
That's
we
what we
don't
would
have
go
applications.
for,
out.
right? Right. So it may sit vacant.
Yeah.
Well, they're
Can
vacant
we-
now.
Yeah. Yeah.
There was no physicians at the last MAC meeting, because they had both resigned. One of those physicians' terms actually ends in July. The other one's term actually is another year out. So the MAC committee is asking that the next committee members be one OBGYN and one non-licensee of the board.
So moved.
Perfect.
So you have a motion on the table. You have a second. We have we have a motion. Thank you, Dr. Karen.
Right.
So now we've had discussion from the board members, and now is there any debate from the public? All those in favor of the motion as it's was said, please say aye.
Aye.
Any opposed? Any abstentions? Okay, so that's done. Thank you, Mr. Warden. Thank you, Mr. Hepler. We're now going to move on to item number 21, Ms. Threadgill's motion, but Dr. Lowe, I would like to call on you, please, before we start the,
Yes, I just wanted to make an addendum to my report this morning, and that is that I was hoping that the enforcement leadership at the medical board would have the ability to hold a training session for this expert review course and invite their investigators to that meeting, and also that the investigators be allowed to be invited to the other meetings that we hold throughout the state. Is that possible?
so you're adding that to your, you don't need a motion or anything, correct? You're just adding it as a
Yeah.
point of information, please.
I'd like
Right,
them,
correct?
I want to be sure that they have the authority to do that, that the enforcement leadership at the medical board has
And
the
do
authority
you
to do
feel
that.
that's mission critical for the enforcement program?
I think it would be very important.
Then we will take your direction. Thank you.
Thank you. So we're clear on that. Thank you, Dr. Lowe. Anything else to add? Thank you. Ms. Threadgill, please, welcome. Good afternoon.
Good afternoon.
Almost good evening.
I'll try to.
Well, no, take your time, please. Talk slowly so I pay attention and listen to what you're saying.
Okay. First, turning to agenda item 21A, may I have a motion to approve 15 orders restoring license to clear status following completion of probation, and 5 orders for license surrender during probation or administrative action.
Do I have a motion? A second? Any discussion? Any public discussion? All those in favor of the motion, please say aye.
Aye.
Any opposed? Any abstentions? Thank you. It's done.
The expert utilization report, which can be found at page 95, agenda item 21B, shows that the district offices used 450 experts in 2011 to review 786 cases. The total active list of experts as of January 3rd, 2012 is 1,172. Turning to agenda item 21C on page 100, we are focusing on reducing the time for the following data markers, and if you'll look down the page, the average days from request to receipt of medical records, average days from request to completion of physician interview, and average days from request to receipt of expert opinion. We anticipate improvement as a result of policy changes and legislation implemented to encourage cooperation, as well as the recommendations by Dr. Lowe during our subcommittee meeting that we reduce the amount of time that experts are allowed to review a case up front by telling them that instead of 30 days, we want We're directing experts to review non-voluminous cases within 15 days to hopefully shave more time off of the case aging. I'd like to thank Dr. Lowe for his assistance with the case aging, reducing case aging for the enforcement program also. Before I get into the rest of my report, I'd like to introduce the enforcement staff that are here today. Who have, could I get you to stand up? Victor Sandoval and Melinda Sant. Victor Sandoval is the supervising investigator from our San Jose District Office, and Melinda Sant is an investigator in the San Jose District Office. And I thank you guys for coming today. I'd also like to take a moment to thank my management team, Laura Sweet, who's the deputy chief. If you don't know who she is, could she stand? And Susan Katie. This period, the last 6 months have been extremely busy, and they have, they have shared most of the workload and kept things going and moving, and I could not have done it without them, and I am extremely appreciative. And you will hear this, and you'll realize this when I get into my report, that there has been a lot of activity. This quarter has been extremely busy concentrating on filling investigator and supervising investigator vacancies. As soon as the freeze was lifted, we immediately began conducting interviews and selecting candidates for background. We identified 17 candidates, 9 of whom were from the Department of Justice and in jeopardy of being laid off. Because the DOJ candidates were in such high demand and numerous agencies were competing for these candidates, agencies such as the Department of Insurance, Alcohol and Beverage Control, our staff undertook the speediest backgrounds in medical board history.
Right.
Unfortunately, after the backgrounds were nearly completed and we were merely awaiting authority from the State Personnel Board to hire, 4 of the candidates withdrew from our background process. And yesterday, when I came to the board meeting, I learned that yet a 5th has withdrawn from the process. Some of them withdrew because their jobs were saved at DOJ, and others because the background of other agencies were done as quickly and they decided to go with that job offer. Being that we can't compete with the agent salaries, none of the individuals whose jobs were saved chose to stay with us. Not surprising. So we're back interviewing again. Unfortunately, most of the candidates who are now being identified will require the 16-week academy, whereas the agents did not. The current vacancy rate, this is before I got notice that we lost yet another applicant, for the investigators is 17%. However, when we adjust that figure to reflect the individuals in background, the rate had dropped to 4%, but it's going to be slightly up with the addition of the candidate who fell out of background. So the current vacancy rate for enforcement supervisors is at an all-time high of 25%. We have had difficulty filling 3 of our supervising investigator vacancies, and however, we're optimistic we will have more viable candidates as we are anticipating a new supervising investigator list to become available sometime this month. So we have had significant investigative activity this quarter with unlicensed practice of medicine cases. The San Jose District Office led the investigation of an unlicensed individual who was performing liposuction in his home. Investigators served a search warrant early in the morning, and the subject was apprehended and arrested as he tried to flee out the back door. He's being held on a $750,000 bond. Our Operation Safe Medicine, this was in Northern California. We're trying to handle some of those more egregious unlicensed cases as we can, but it just highlights the need for an Operation Safe Medicine unit in the north. However, the Operation Safe Medicine unit that we have has been extremely busy arresting unlicensed practitioners. During January, and one of our investigators unwittingly walked in on a subject who was performing a hemorrhoidectomy. The subject was arrested and the patient was taken to a local emergency room, and all ended well. But that's just an example of how busy and every day is becoming a surprise to me. We had a productive meeting with the supervising deputy attorney generals and area supervisors, Susan, Katie, and I also, where numerous issues were resolved. We have disseminated the revised vertical enforcement guidelines to staff. And again, I'd like to thank Laura Sweet for her participation in the redesign of this guideline, along with Tom Lazar, Supervising Deputy Attorney General Tom Lazar. They put a lot of hours in on this project, and we're happy to say that the investigators will be held to the standards that have been identified in this manual effective March 1st. We had to give them a chance to read it, so we disseminated. They'll be required to follow it in March. As Dr. Lowe reported, we have worked out a system to reconcile statistics with the Office of the Attorney General at both the district level and the Discipline Coordination Unit level. At the beginning of the year, our records reflected that we were off. We had a count of about 118 cases that needed to be reconciled. And as of this report, we only have 27. We're down to 27 cases being reconciled. And those are the cases that we showed filed, referred to the Attorney General's office pending an accusation for more than 60 days. So we're confident that we'll have that all cleaned up, hopefully by the next board meeting. We've held our own with case aging despite investigator vacancies. Staff has managed to reduce case aging by 31 days since this time last year, and by 71 days since the same time fiscal year 09-10. As the travel restriction eases, Deputy Chief Laura Sweet and I will resume the very successful Age Case Council to develop plans to quickly resolve troublesome cases that have aged. At the last board meeting, I said that I would be tracking the status of how the new law requiring a different way of contracting with experts, how this impacted our enforcement program. I'm pleased to report that due to the yeoman efforts of our expert reviewer analyst, Susan Getzinger, with the assistance of Central Complaint Unit staff, 1,207 contracts were sent out between December 27th and January 23rd. As of Monday, 376 contracts were actually in place, and we are receiving more daily. I'm also pleased to report that the 11th edition of the Model Disciplinary Guidelines were approved by the Office of Administrative Law and became effective on January 11th, 2012. They are now available online, and we have provided you with soft copies, and we have some hard copies available for you if you would like to have them in that format. Susan Katie, again, I don't know how she managed to stick with this project to the end. I think everybody had given up hope. But I really, really do appreciate her efforts and the results. As Jenny Harold from the Pharmacy Board mentioned this morning, the CURES program is undergoing some significant changes as a result of the Department of Justice having staffing cuts. This program, Susan Cady met with the DOJ staff and learned that the responsibility for the CURES program has been transferred to the Bureau of Criminal Identification and Investigative Services within the Department of Justice. But as Jenny reported, all previous staff were eliminated, and at present they have redirected new staff from other units to provide support to CURES. The redirected staff have been successful in eliminating the backlog of applications for access to the system, which usually, those applications usually come from physicians or pharmacists attempting to determine if patients are doctor shopping or following instructions regarding control medications. However, there is a slight backlog with the input of data regarding the prescriptions, getting that in the system. So we'll be, Susan is a point person to follow CURES, and we will be reporting back to you on that. We lost our ability to ad hoc reports, to obtain ad hoc reports from CURES about 6 months ago. So the administrator committed to working with us to reactivate our access to CURES data, and at this point in time, DOJ staff trying to restore the program as much as possible. But more than likely, they will need outside support from us, the Board of Pharmacy, and other interested parties in their efforts to obtain permanent staffing for their program. Staff will begin working with our new research program specialists on data analysis for the upcoming vertical enforcement prosecution report and sunset review. As you heard yesterday, the enforcement committee, we are working very hard on the Laura Suite in designing the new training for experts, and we're eager to launch that. We are also have met with OAH regarding their participation in our expert reviewer training. As well as Dr. Lowe will be meeting with a representative from OAH in order to work on designing a training program that the administrative law judges have expressed interest in receiving from the medical board. And I'd like to conclude my report.
Thank you, Ms. Threadgill. Are there any questions of Ms. Threadgill from the members? Dr. Ganadev?
Yeah, I just have one, Renee, is that you do spend a lot of time training these investigators. What's your retention rate?
I don't have this. I can get that for you. We have had, I've been reporting out vacancy rate at every meeting. We have quite a bit of turnover. And that is due in large part to our inability to pay staff as at the level that would be associated with the complexity of this kind of investigation.
That's a concern because, I mean, the amount of time needed for her division to train these people, and if the retention rate is low, it is not very high, then it really is a significant issue.
It's true. Thank you. Any other comments? Dr. Lowe?
Are the salaries competitive with the investigators at the Department of Justice?
No, that's.
I thought that when Steve Alexander was board president, he made a tremendous effort to try to equalize that. That never did happen?
No, I don't know if you recall the legislation that paired us with HQE had had language in it that said that we should be receiving comparable pay to the investigative agents of the Department of Justice, but that is not something that has happened, no.
The Department of Consumer Affairs commissioned a study, and the study results determined that the pay for the investigators for the medical board, dental board were at the level they should be.
Right, but that might be changing. I mean, Dr. Dago?
I was going to say, do we know why we're unable to retain these people? We're talking about salaries, but maybe that's not it?
We do exit surveys, and one of the big issues is salary.
So if this is something that...
Excuse me, let me qualify
Sorry.
that. Coupled with the complexity of the work. I mean, if you could get a job that pays the same and you don't have to work as hard, sometimes that might interest you.
So this might be something for the Enforcement Committee to take under its wing when it's finished with everything else it's dealing with. That seriously, the issue raised that the cost effectiveness of training versus the maintaining of employees, as well as the inequality of salary pay scale, is seriously an issue, and that is something that I think needs to be addressed, and we should think about that seriously. So any kind of materials that you would like to eventually provide with your Enforcement Committee might be something for them to deal with.
I would say that it's more appropriate for the executive committee to deal with.
My pleasure. I'd be more than happy to put it in the executive committee. We'll so do it. So you'll make sure we have the materials, please. But Renee, I want to thank you and your staff. It's been a very frustrating, long time, both with staffing issues, salary issues, vacancies, and the job it entails. This is a constant statewide job that you guys perform, and you and your staff really are to be commended. I want to thank you on behalf of this board.
Thank you.
So let's have Mr. Ramirez come up. We've heard how well you guys are all getting along now. So we expect it to keep going.
Good afternoon. Like others, I would like to start by thanking Dr. Lowe for his leadership in the Enforcement Committee, and specifically for his leadership in getting the data case reconciliation project started. I think it's a project that's been long time coming, and I'm glad it's on its way now. As previously indicated, on January 23rd, our staff and CMS staff met with the director and her executive staff and presented the 3 reports that had previously been requested from DOJ. Those have been delivered to your staff. Following that meeting, NBC staff requested additional reports from CMS. Though some of those can be readily accumulated and presented. Others may take a little bit more time, but we are going to work on those as fast as we can. With regards to the staffing, we have 2 vacancies in San Diego, 2 retirements as a result of 2 vacancies as a result of retirements, and we have just added 1 more deputy in the Sacramento office to accommodate the work that's being transmitted from that office by your staff. If there are any questions, I'd be glad to answer them.
Any questions from board members? No, I want to thank you, Mr. Ramirez, as well. Please, we're very pleased to see things moving along more parallel than they have been in the past. Moving on the agenda, we're going to move to item number 23. Mr. Simoes, would you please come forward and present on legislation?
Good afternoon. Tim should be passing around some update packets. There was a couple of bills that were introduced and amended since your ledge packets were in the mail. To start off with some good news, our 2012 law books are now in print, so you should all be receiving some in the mail. So this law book will basically have all the changes that were made last year through legislation. Okay, so as Tim passes those out, there's an updated tracker list on there to reflect the new bills that have been added to your packets. So refer to your legislative packets. I've included a legislative calendar in your packets just so you're aware of some of the legislative deadlines and due dates. Like the February 24th is the last day for bills to be introduced, so we'll see an influx of bills near the end of February. So I included that in your ledge packet. And on the top of the stack that Tim is passing out is your tracker sheet. The first, the sponsored bill is in pink, and we're going to review that bill, and then there's some bills in blue that will also be discussed, and the board needs to take positions on the bills in blue. The bills in white and gray are two-year bills. They've already been discussed, and we have support positions on both bills, so we really don't need to discuss them unless anyone on the board wishes to do so. So do any members have questions on the bills in white and gray? If not, we'll move on to start with the bill in pink, AB 1533, Mitchell.
So let me just wonder, all of a sudden, you all know what the bills are that you're supporting, and you don't have any comments or questions, or, I'm glad to hear that.
There's two bills, AB 589 and 783, that we supported last year. They're two-year bills, they're still alive. They're in the second house, so they're still alive. Okay, so should we start with AB 1533? Mitchell? Yeah. This is the bill that we sponsored. It's the one we're co-sponsoring with UCLA, and as you remember, it's the UCLA IMG International Medical Graduate Program. And the bill would proposes to allow program participants to engage in supervised patient care activities, clinical activities, just in this one pilot program for up to 6 weeks. And so this is a bill that we're co-sponsoring with UCLA. I encourage you to look over the language, but it basically allows them to get this clinical training as a pilot part of that program. And of course, all training would occur with supervision provided by licensed physicians. The bill also requests the UC to prepare a report for us in the legislature after the pilot program has been operative for 5 years. It includes specified information and also includes the potential for retention or expansion of the pilot program. And the bill sunsets a pilot program on January 1st, 2019. And so this is just to let you know this bill was introduced. We already have a support position. We're sponsors of the bill. It will likely be heard in Policy Committee in March. Does anyone have any questions?
Any questions?
Okay. Okay, the rest of our, as you probably remember, we have some other sponsor proposals that you approved at the last board meeting. All of our other sponsor proposals have been approved to be included in the Senate Omnibus Bill, which basically means that we met with Senate BMP staff. They approved those proposals. We met with the Republican consultant. They okayed those, so they're going to be included in the Omnibus Bill. I can go over those if you would like, or, okay. So the first one is the non-practice license status, our authority to impose discipline. As you remember, there was a court case that basically said for non-practice license statuses, we don't have the authority to impose discipline. This bill would just make it clear that we do have that authority. It's going to be included in the Omnibus Bill. And that Omnibus Bill will likely be introduced at the end of March. Omnibus bills don't have the same deadlines as other bills. Another piece of news too, I know you guys probably remember Rosie Lynn Pomano. She worked at Senate BMP. She moved to Assembly Health. So just to let you know, the new person that we'll be working with at Senate BMP is GV. His name is GV Ayers, and he's been assigned to the medical board. So just to let you know.
Just backing up, so the kind of discipline, if someone doesn't have a license, typically we discipline the license, so it's fines, is that basically
Well,
it?
what had happened in this case, do you want to talk, Kurt? Or?
Go ahead.
What had happened in this case, it was a retired license status. And so what the court decision basically said is that we didn't really have the authority to impose discipline on non-practice license statuses, was the effect. And what we wanted to do was to sponsor legislation that made it clear that we have the authority to impose discipline over all licensees regardless of license status. So regardless if they're in inactive status, retired status, whatever status they are, they're still license holders of the license that the medical board issued, so we should be able to take action.
So we could revoke a retired license kind of thing, okay.
Okay.
It becomes important because you have a statute of limitations, and if you allow someone to evade discipline by putting their license into a retired status, then you lose the ability to have control over that.
That's the core issue.
Okay, the next one that will be included in the omnibus bill is the renewal notices, and it basically gives us the ability to send those via email if the physician opts in to receive their correspondence via email. We're going to add some language to address an issue raised by the Republican analyst, and it's basically just that we have to confirm the email addresses every year just to make sure we're sending them to the right email address. So the language will include that. And then the last one is the licensed midwives, the retired status. It's establishing a retired status for licensed midwives. So those three will all be included in the omnibus bill. Does anyone have any questions? Okay, with that, let's move on to the 2011-12 legislation. The first bill is actually in your update packet, and that's AB 1548 Carter. This bill is exactly the same as AB 2566 Carter that was vetoed last year, and it's sponsored by the American Society for Dermatologic Surgery and now the California Society for Dermatology and Dermatologic Surgery. Basically, this is a bill that enhances the penalty for corporations violating the prohibition of the corporate practice of medicine, and what the purpose is really to provide incentive for the district attorney's office to prosecute against these violations. We've always supported this bill. This bill mirrors, it's exactly the same as AB 2566 from last year, which we supported. Also included in your update packet is a letter from Assemblymember Carter asking the board to again support this bill and then possibly co-sponsor. Last year we opted not to co-sponsor, just to support the bill. So the staff recommendation is that the board take a support position on this bill, but I would need a motion.
So moved.
So do I have a motion?
So moved.
Second?
Second.
We have discussion on the motion. Have any public discussion on the motion to support? I see someone coming forward. Please have a seat at either table. At the table would be fine, and then when you're done, I need a slip, a speaker slip, please.
Good afternoon. Bryce Doherty here on behalf of the co-sponsors of the bill, the American Society for Dermatologic Surgery Association. This is basically a bill that goes after the corporate entity component of some of the legislation we've built on with Mrs. Carter over the past. We think the medical board, we agree with Schwarzenegger's veto of the prior bill, which is basically the medical board in California has appropriate authority to go after physicians, but I think he was short-sighted in terms of what this bill was to do, which is to raise the penalties to go after the corporate entities that are luring in physicians and putting some patients in harm's way. So we think this bill gives the tools for local district attorneys to go after this unscrupulous corporate behavior. We would certainly love for the medical board. We think it meets your mission and objectives to protect the public. We would love for you to come on as a co-sponsor with the Federal Dermatologic Society and the State Society, but would very much encourage your support as well. So thank you.
Thank you. Do I have anyone else, public speaker from anywhere else? Okay, all those in favor of the motion as presented, please say aye.
Aye.
Any opposed? Any abstentions? Okay, thank you. Continue.
Okay, the next bill that we're going to discuss is SB 352 Huff, and that's in your original packet. And this would prohibit chiropractors from treating allergies, including hypersensitivity to foods, medications, environmental allergens, or venoms, including the use of laser therapy. This bill would also prohibit chiropractors from advertising to provide the above listed services. A little background, and we're going to talk about this later, and I believe it's agenda item 29 about these regulations, but just to give you a little background for the purposes of this analysis. The Board of Chiropractic Examiners has drafted regulations relating to the use of cold and laser therapy. And what it basically says is that chiropractors, the intent of the regulations are to protect consumers by specifying what chiropractors can use these cold lasers for. And so what it would say is that they can only use them for things within the chiropractic scope, only for uses that have been approved by the FDA, and it actually lists in the regulations, it says nothing in this section shall be construed to authorize the use of a laser by a chiropractor outside the chiropractic scope of practice. This includes, but is not limited to, laser ablation, surgical procedures, and the laser treatment of allergies in cases where there is a known risk of anaphylactic reaction. And we're going to talk about this later, but medical board staff actually attended the chiropractor board meeting and asked them to also include cosmetic procedures in that list, because medical board staff is seeing, and others are seeing, a lot of advertisements, and I'm sure if you're on Groupon, you've probably seen them too, for laser lipo, non-surgical facial lifts, things of that nature. And so we thought it would be helpful to also, as we believe that they're not in the chiropractic scope of practice, to go ahead and specifically list that too, to make it easier for the chiropractor board to go after those kind of advertisers and chiropractors that are doing those kind of services. Senator Huff introduced this bill. It's kind of like a backup in case the regs don't go through, and so he has in committee agreed that if the regs go through, he'll drop this bill. what staff is suggesting is that the board support this bill, but take a supportive amended position to add that section that's in their regulations, which says nothing in this section shall be construed, and also to add cosmetic procedures to that. The chiropractic board wasn't very receptive when I went and asked them to do that, so this is kind of another way of getting around it. That being said, the chiropractic board was created by initiative, and so it was brought to the people, which means that there's some argument on whether you could actually just introduce a bill and have the governor sign it. It may have to go back through the initiative process. So, so the staff's recommending that we basically support this bill if amended to specifically list the things that shouldn't be in the chiropractic scope.
So do I have a motion to approve that? There's a second?
Second.
Okay, can I have some comments from the board members? Dr. Ganayev?
Yeah, it's somewhat scary to hear this. I mean, consumer protection just goes through. I mean, these lasers unfortunately have the danger with them is significant, and non-scientific things they advertise, anyone, sometimes even physicians, unfortunately, is just scary because it's not a consumer protection, it's a consumer deceit. It's just, so I think we should take a strong stand on these things which do not work, or these things which are dangerous in the hands of people who are not trained to do them.
Okay.
Thank you. Do I have any other comments from anyone? Any public comments on this? All those in favor of the motion, please say aye.
Aye.
Any opposed? Any abstentions? Thank you. It's done.
Thank you. So the next bill, and this is in your update packet, is SB 924, and this is a bill that was around last year, but it became a 2-year bill before our board meeting. It's kind of been sitting. Recently, it's had some major amendments. So before Walters was the author, now Price and Steinberg have been added as the authors. This is a bill where 783, which we already support, adds PTs, physical therapists, to the list of people that can be hired by a medical corporation. You probably kind of remember this. In the past, medical corporations have always hired PTs. There was a recent Ledge Council opinion that they could no longer do this. We supported 783. So this bill now adds that piece into it. So it adds PTs and some other practitioners to allow to be hired by a medical corporation, which is something probably the board would support because we supported 783. It also, this bill allows patients to directly access PT services without being referred by a physician, provided that the treatment was within the scope of a PT, and there's certain conditions that have to be met. So I'm going to go through those conditions. If the PT has reason to believe the patient has signs or symptoms of a condition that requires treatment beyond the scope of the PT must refer that patient to a physician or the appropriate healthcare entity. And it requires PTs to comply with advertising requirements, requires PTs to notify the patient's physician in writing as long as the patient authorizes them to do so. And this is the important part. It requires, and this is kind of something that's been different from bills in the past, it requires the PT to not continue treating the patient beyond 30 business days or 12 visits, whichever occurs first. So this is their attempt at ensuring that a patient doesn't see a PT for a long time without some kind of physician oversight. So at that point, what the patient would be required to do is to go see that or their physician, to get an examination, and to have the physician sign off on the PT's plan of care. It also requires kind of a notice to consumers kind of thing, but it basically requires the PT to provide this information to the patient orally and in writing, and requires the patient to sign off on this. And so basically stating what the bill requires, that they can't see the PT longer than the 30 business days or 12 visits, whichever occurs first. So like I said, in the past, the board's taken an opposed position on bills that allow for direct patient access to PT services. Board staff feels that expanding the scope of practice of PTs and allowing them to see patients for that amount of time, 30 calendar days equals almost 2 months, basically 12 visits, whichever occurs first. We believe that may compromise patient protection. Staff is suggesting that maybe a more reasonable approach would be to shorten the amount of time that a patient can directly see a PT, like maybe 15 to 30 instead of business days, we'd make that calendar days, or 6 visits, whichever occurs first. Kind of the pros and cons of us taking an opposed versus an opposed unless amended position. This bill has a lot of power behind it right now. Steinberg is one of the authors. Price, who's the chair of Senate BNP, is one of the authors. So Wayne, do you want to get it in a better place, or do you want to oppose? So that's the board's call.
Okay, I'm going to ask for a motion to approve it, to approve the support.
No, oppose unless amended.
Suppose unless amended, but I'm going to ask for a motion before we have the discussion is what I was trying to, I'm sorry. Wait, before, but can we just have the motion before we have the discussion, please?
Okay, I'll do a motion according to the staff's recommendation, which is oppose unless amended. Okay, I'll do that.
Okay, so that for purpose of discussion, I appreciate that. Thank you. And then second, for purposes of discussion.
Second.
Okay, so now we'll have discussion and questions. Dr. Solomonson?
Strategically, where would we stand with a neutral position?
Well, I mean,
what would be the implications of neutral?
I mean, I think a neutral doesn't allow us to make any changes. So if we're neutral, we're neutral. We're totally off of it. If you're happy, I mean, if the board is happy with the 30 business days and 12 visits, whichever occurs first, that's up to the board's decision. Staff is recommending maybe that may be a long time for a patient to directly access PT services without seeing a physician, but I will leave that to the board.
Dr. Levine?
Yeah, there are two issues in here. And I think one is the policy issue, which is under the scope of practice of a physical therapist, they are not, their scope does not include making a diagnosis. So direct access to physical therapy essentially is accessing treatment without the establishment of a diagnosis. And much of the time that's probably harmless. But from a policy perspective, that's exactly what this bill would do. It would say that you can access physical therapy without having a diagnosis established. People already have the ability to go to a trainer or a massage therapist on their own and do that. The difference, of course, is insurance coverage. So what this bill does is essentially says that physical therapy services for the first 30 days will be covered by insurance in the absence of a diagnosis, and that's sort of the policy side. I think Jennifer's absolutely right that the legislature is anxious to get this issue off the table. Senator Steinberg has, I think, said, he doesn't want to separate the two issues, which the Hayashi bill did last year, so that the choice would be oppose unless amended, and the amendment would be to remove the direct access. I don't think that will happen, quite honestly, or alternatively, to limit the period of time which patients would have the guarantee of insurance coverage for physical therapy visits without the establishment of a diagnosis prior to initiating therapy. I think those are the choices.
So my concern is that the way that we are at the table to change anything that we don't like, to reduce the time, is to oppose unless amended.
Correct.
So anyone else have any?
Yeah, and then we need to decide what
right.
amendments we want.
Right. What amendments? Dr. Ganado?
I'm just Jennifer. I'm just curious. Is this a compromise between the interested parties, or is it legislature pushing? I'm just trying to see. There are two main issues, and the fight the last couple of years has been food fight, has been just horrible on one side, and then the patient safety issue on the other side. So how did this come about? That's what I'm just
I actually don't, have the insider track on how this came about. I mean, I do know that obviously there's legislative pressure behind it if you have the Senate Pro Tem and the chair of Senate BMP on it. I doubt that both sides are in agreement about this, but I believe, like Dr. Levine said, that the legislature wants, at hearings that I attended, they wanted both of these issues. They were constantly molding them as one issue, and I don't really believe that they're one issue, but they want them to be taken concurrently, which is probably why they both got put in the same bill. I believe it's probably more of a legislative compromise than it is both sides compromise, but I haven't been in the insider track to get that firsthand, so.
Yeah, that's the way it sounded like. I haven't heard there was any compromise between the entities, I think, but I do like our position, which is oppose unless amended. Our concern is having somebody getting quote-unquote treated appropriately for 30 calendar days without a diagnosis.
No, the point is to be treated with insurance for 30 calendar days. Right now, anybody can go to anybody and get treated without getting paid for it, so it's not, this is the insurance issue.
Okay.
Ms. Chang, please, I'm
No,
sorry.
I just want to know, so I can, if this bill passes, I can go to a physical therapy and go there for 30 days without seeing a doctor and get paid for it?
30 business days or 12 visits, so it's whichever of those occurs first.
Okay.
Now, if we oppose this bill, not unless amended, just oppose it, does that put us in a place where we have no negation, no place,
With
no
input.
voice?
You have no input when you do
Well,
that.
we have no negotiation power. We're opposing it outright, so nothing, basically when you take a post position, it means nothing you can do can make this bill any better. That's the message.
And we see, my viewpoint is actually would like to see a person go to the physical therapy, go to the doctor first before you go to physical therapy. That's the current practice.
You
right?
can go for any kind of treatment currently. The issue is, with this procedure, with this bill, is that you will be able to have your insurance cover you.
Here's, can I, just, the explanation is that it's very hard to get a claim paid without a diagnosis.
Right.
And a physical therapist scope of practice does not include a diagnosing. That is, I think, restricted to physicians, nurse practitioners, and PAs currently, or
So,
is that correct?
So your amendment would be that people have to see the physician first, right?
That's the current, in order for there to be a diagnosis, you have to see the physician first. The challenge we have as a medical board is we support half the bill. And it's been married to an issue that's more complex.
Dr. Diego, did you have your hand up? Okay. Dr. Conradin again?
I just wanted, the background is this, that physicians could hire physical therapists as employees. Then the physical therapy board came and said, well, that falls under the corporate bar. A physician cannot hire physical therapist. Suddenly the board came up with the regulation, you know how regulations becomes laws. And then that's a trump card to get direct access to the patients without seeing the physician. So this is what this bill is about. They're combining both, that is, removing that what physical therapy board said that physicians cannot hire the physical therapist. So this will allow physicians to hire the physical therapist. But along with the thing comes where a patient can be treated for 30 business days without a physician seeing the patient first. So that's why, but still I think my concern here is the safety and the practice of medicine, what this board is supposed to do. I think it's the right position as opposed unless amended.
Okay, so I have public comment from Ryan Spencer. You need a new pen.
Ryan Spencer with the California Medical Association. We've been one of the most interested stakeholders with this bill, and we actually started speaking with the Senator Steinberg when he's opened up negotiations early in January to try to come to some type of compromise. To clarify, and she said it correctly, this is a legislative compromise. It's not necessarily a compromise between the stakeholders. This is an effort to try to move the ball, get past this deadline, and try to see if we can make any more concessions in the future. CMA officially does not have a position on this bill. In deference to the pro tem, we said we go back to our positions, but we do have concerns with the bill just on its face. And one thing I do want to clarify, the physical therapists are specifically prohibited in law from treating a patient without a diagnosis. This bill will allow them to be treated without a diagnosis. It has nothing really to do with insurance, because the insurance companies, it's left up to independent insurance companies to figure if they want to cover their enrollee without a referral, without a diagnosis. And so there's actually, if you read the bill, there's specific language in the bill that says this is not an insurance mandate. So they're trying to keep that separate from this bill. This is just allowing physical therapists to treat something which they really don't know necessarily what they're treated, because we would argue that they don't have the education to perform those treatments. So we're still heavily involved in this bill. Actually, we appreciate the amendments that you're offering, but I can assure you that there will be other suggestions that we'll be offering to the author. Thank you.
Thank you. There's also a portion of physical therapists that are allowed to be hired by appropriate doctors. Did you want to address that part too? I thought you would.
Support that.
There is, and of course, we actually appreciate that aspect of the bill.
I thought you would. I just thought I would
But you know,
make sure you were out on it.
there's an ironic part in that bill as well, because there are some, and honestly, that's one of the reasons we came to the table. We also understand that there is a legislative desire to take a look at direct access, and we're not being obstinate to the idea of direct access unless there's some type of patient protections involved. And keep in mind, current law does require there to be a diagnosis. This actually removes the word diagnosis completely and just says you have to sign off on the plan of care with an examination. That examination, you can assume that examination will end up in a diagnosis, but it's not necessarily required, as it is in current law. And so that's an important part of this bill that we need to get some answers. And our current legal team is taking a look at that to see what the complications are with taking that provision out of the bill. In terms of the employment issue, one of the parts that the physical therapists wanted to be included was also the establishment of physical therapy corporations, which allowed them to employ physicians. So they were opposed to physicians employing physical therapists, but they're now all of a sudden okay with it if they have a physical therapy corporation employing physicians. So that's in the bill as well.
I'm so glad that physical therapists are so well paid they can afford to hire doctors now.
That's right. Thank you.
Okay, so we have a motion on the table. We have had public comment. Is there any other comment from the board or members?
Well, I think I want to define unless amended. See, I really do not, I really would.
I think that's staff's responsibility, to be honest with you. If we do a support, oppose unless amended, it puts us at the table. It gives us the opportunity to have staff engaged. And our recommendation is to oppose unless amended. That's where we are.
Right, yeah.
But you want to define amended, and I'm not so sure.
I want to make sure the,
I think.
Can I do that? Yeah, I'm the maker of the motion.
Yeah, you can do that.
I just want to make sure that we have the doctors look at the patient before the physical.
That's not what that's not what this bill is requesting. So you need to decide if you want to pull your motion. You're the maker of the motion. You have the right to amend your motion, but you're what we're talking about here is the staff's position, which is to oppose unless amended.
But I cannot go through with the motion without somebody telling me what is the key point of the amendment.
So the key point of the amendment would be to shorten the time frame before a patient actually is required to see the physician. So what staff is suggesting with this amendment, to shorten the time frame from 15 to 30 calendar days instead of business days, or 6 visits, whichever occurs first. That would bring us to the table to shorten that time frame. It's hard to oppose unless amend a bill and then take out a major provision. A lot of times it's not necessarily a legitimate amendment to ask for. If that's what our position would be on a policy to oppose, we would just probably take an outright oppose position.
I think that we need to look at the reality of the situation. We need to be at the table. The people that are the authors of this bill need us to be at the table. We need to be at that table. So you need to decide if that's going to fit within your
So when you
motion.
Shorten the time, you're saying we cannot remove the word direct access.
You have to give your staff the opportunity to negotiate what they feel is fair and just, and then come back to us, and then we will have, again, a second bite at the apple.
That's kind of the direct access is the main crux behind this bill, and so it's hard for us to take an oppose unless amended position, but to take out pretty much the whole.
They're not removing my
Okay,
motion.
so thank you very much. So the maker of the motion's removed her motion, so I need to know. Robert's Rules of Order would suggest I need another motion. So I need another motion. So I need a motion to support the staff decision to oppose unless amended this bill. Or an amendment. Ms. Chang, would you want to put an amendment and then have that voted down? I don't think so.
Well, that's okay. You can vote me down.
No, but that's not the object. The object is no.
I will propose a motion to oppose the bill unless amended with the cross of eliminating the concept of direct access. I don't know whether I'll even get a second, but I'm making my motion.
I'll second it, yeah. I think it is an issue we do need to look at, but you might be tying our staff's hands. But I think what we are trying to do is protection of the public, rather than this food fight between many, many different entities. And I do have a concern, actually, if we were going to just cut down the number of times they can see without a diagnosis. I have a serious concern there too, so I do agree with Ms. Chang, so that it is, if the amendment were some other issues, I can understand that, but if we were going towards just the lesser number of times they can go to see the physical therapist, I still have the principal concern that is, what else we're going to do as the protectors of practice of medicine, allowing the non-physicians or non-allied health who are trained to do what they are supposed to do doing this.
So,
What,
Doctor, just so you had something to say?
just a clarification, or what might be the implication if this bill, if we support this motion with the having to have direct access, what might be
The implication by taking out the heart of the bill
yes
is that you might as well just not
oppose it.
You might as well just oppose it. I'm suggesting to you that politically it's not a smart idea to just oppose it.
True. And
And in spite of Dr. Ganadev's statement about protection of the public, I would venture to say that we can't protect ourselves. We can't protect the public from themselves. If the public would like to go today to a physical therapist or go to a massage therapist or go to any kind of a health professional that they want to go to, that is what free will is all about. So that I'm going to suggest that we're trying to micromanage staff here to be able to have an opportunity to be at the table.
No.
That I'm concerned with.
No,
You're saying no, but I'm saying yes.
No. Okay, let me reword it this little bit.
Okay.
Okay.
Thank you.
I'm trying to, and I think, but the statement of undermining the staff's ability is really overkill. I have to tell you that. Why don't we do it this way, just to eliminate the direct access portion, unless we can amend it to provide a greater patient care protection, patient protection. And I'm saying is, unless, yeah.
I'm not sure.
So what does that mean? I mean, I
That
apologize.
means
What does
that
it
you
mean?
have a different solution better than what they're being proposed. I'm actually went down quite a bit at this point.
Jennifer?
Well, I would probably need that different solution because it's hard just to go and say we oppose unless amended for better, to increase patient care. We kind of have to suggest what would increase patient care. I mean, I think we have two options. It's we oppose it outright, that we don't believe that there should be direct access, and that's an option. What you lose with that option is the ability to come to the table because you're basically saying there is no negotiation. And if the bill does get passed and then gets signed, it's going to be in the, however it goes through the legislature without any amendments that we suggest. That's an option for the board. The other option is to take and oppose less amended with specific amendments.
But I'm concerned about us not being at the table. And if it seems to me that being at the table gives us a participatory engagement. And so if we don't like it going forward, we can always come back and say, we don't like this. Can we do that? But to cut us out on the front end at the table is problematic for me.
Thank you. Dr. Levine?
Yeah, and I was going to say something similar. This bill was just introduced a couple weeks ago.
Well, it's just amended, so it's been kind of a 2-year bill, and it's been sitting, and then, so it just kind of made it, like Ryan was suggesting, they kind of moved it to meet the policy deadline,
Right.
so.
So this version
Yeah.
is a relatively new version, and my guess is there's a lot of work that's going to go on. So I agree with Dr. DeRousseau that cutting ourselves out of the conversation in January is a mistake. We always have the option of changing our position.
Absolutely, absolutely. You can always vote it down.
And I will bring it back, obviously, at the next board meeting.
Dr. Kennedy?
That's why I said I have no problem with the oppose unless amended, but what were those, what we were thinking? If we cannot, take for example, if we cannot remove the direct access, and you get 5 visits rather than 15 visits or 12 visits, what I would not like to see is us go support of that bill. What I would like to see is maybe go neutral on that bill rather than see it
No,
just.
there's no
goes-
vote here about support. That's never been on the motion.
It would never, I don't think,
That's not been part of the,
yeah, I think if we did an oppose unless amended and they did take our amendments, I don't think that we would be necessarily in support. I mean, I would bring it back to the board at that time, but we would most likely, I would believe, be neutral or something like that. But we can change it to whatever the board thinks is protects consumers as far as visits and number of calendar days versus business days. We just, staff made a recommendation, but we're open to what we had said is 15 to 30 calendar, which is basically 2 weeks or 1 month calendar days, and then 6 visits, whichever occurs first. But that's open for change.
Dr. Bishop?
I think the crux of the matter really is, does the board feel that there are any circumstances under which we want to allow direct access to physical therapists? Because if let's say they come back and say, okay, we'll change it to 5 visits, and the board says, we just don't like it at all now, it seems like a waste of time to vote on it a second time. So I'm thinking if the board agrees today, at least in principle, that there are some circumstances under which we will allow direct access to physical therapists, we should allow the oppose unless amended. But if there is no circumstances we're going to approve this bill if there's direct access, we should just oppose it completely. That's my feeling. I don't have a strong feeling one way or the other, but I think if the board strongly feels that we should not allow this to go through with any form of direct access, we should not waste time on it a second time.
And those would be the decision you have to make. We either oppose outright, the only risk you lay in that is if it passes anyway, then we didn't really have a seat at the
Parliamentary
table.
procedure question, excuse me.
I'm sorry, I'm just wondering, so where we are, I'm sorry, Mayor, so is that Ms. Chang had modified her motion to suggest that we either take out direct access or provide some sort of alternative greater public protection scheme, and that's kind of where we are. So we never really got Dr. Gonadev to see if he was going to go along with that. So there's a motion.
Well, we have a motion without a second. I'm so sorry.
Do I have a second? No.
No.
After we've had all this discussion, we better have it a second.
Yeah, I'll second.
Okay, so there we go. Thank you.
On the amended motion.
So, and again, I worked in the legislature back there when we were pulling up in Conestoga wagons to go to committees, but it seems logical to me that if the board takes a position of OUA and the A is in fact a shortened time or some set of circumstances by which direct access is okay, once we go in there, the board, in my mind, could never go back to saying direct access can be lopped off because we've already crossed the threshold and said, it's 5 days, 6 days, 10 days, or a note from your mother. We've already crossed that threshold issue.
I mean, I would agree with that. It would be hard to say if you amend it, then we're going to be okay with it, and then come back and say, we don't believe in direct access at all. So that's kind of the policy call. We either oppose outright. It may, get to the governor and it may get signed and it's going to go in whatever form it goes, or we go to the table and make some negotiations to try to put something in there to ensure, but you do have to make that first policy call. And
So let me suggest, as I'm reading this again from the beginning, and I know I'm only reading the very beginning, but the first paragraph suggests that this bill would add licensed physical therapists and a whole bunch of other practitioners to the list of healing arts practitioners who may be shareholders, officers, directors, or professional employees of a medical or podiatry corporation. That's all it does. That's the first paragraph.
And that's the part that we previously supported. So.
And we are in agreement with that being able to happen. Then the second paragraph suggests that this bill would allow a patient direct access to PT services without being referred by a physician, provided that treatment is within the scope of a PT practitioner. It's not like they're going to go do stuff that they're not supposed to do, okay? So if they've been trained to do specific tasks, and that's what they're going to be allowed to do tasks. That once, well, but the diagnosis becomes an issue only, my understanding, is with an insurance problem, no? I was under the impression that anybody can walk into a PT office now and get services because they've got a backache and pay for services.
Wellness, but not for a specific problem.
Wait, a backache is a wellness, or a backache is a problem? In my life, it's a problem. In your life, it might be not, but trust me, in my life, a backache is a problem. So, I mean, I'm not quite sure what we're not agreeing about here.
Why don't we do this? Okay, I'll take back my motion, and I'll make a motion so everybody can vote on this one, which is whether we approve direct access or not, and then establish that fact. If the board feel that direct access is an important issue, and they want it or they don't want it, just vote that one out. And then afterwards, you can make a decision, because it's very clear. If you cross that, you cannot backtrack.
I would respectfully suggest, I think the issue should be encapsulated about what do you want to do on this bill, I think, is kind of where I suggest, because I think, I'm sorry, I said, with all due respect.
Please use your microphone.
Yeah, it's like nobody can hear me. I would respectfully suggest that perhaps the core issue is, what does the board want to do on this particular bill? And I think Ms. Chang's point is well taken, but I think it should be wrapped around, what do we want to do with respect to direct access on SB 924?
Okay, why don't I make a motion? You can vote me down. I'm just waiting I'm wanting to get to a place, okay? I'll just make a motion. We oppose the bill unless amended with the direct access being removed. That's my motion. And I would appreciate a second, and then you can totally vote me down and go forward with it, or you don't have to give me a motion.
Second.
Okay.
Oh, any public comment on the motion as it is? Dr. Simonson?
I know, actually, that motion does make sense, because it says we do support a significant component of the bill, the half that talks about employment. So I think because we were saying, oh, well, if we have that amendment, it's like we're gutting the bill. But no, we're supporting half of the bill. So I think that's quite a reasonable thing, and I would tend to support Ms. Chang's motion.
And then the other, it really says what we're opposing, right? Like what we would want amended, because that's it. So my understanding, this would not be a portion of a bill if they had direct access without seeing a provider, Barbara, right? I mean, otherwise, we wouldn't be discussing this.
That's correct.
But because that's why it's a bill, because obviously they don't have direct access right now.
Correct.
Before voting on the, I guess one thing that I'm missing is understanding what the scope of practice of a physical therapist currently is. And
I think it's massage.
So.
Massaging, is that it?
No.
They can use.
No, and
Could our CMA consultant elaborate, perhaps, or can you elaborate, Jennifer, what the current scope
I have a lot
is?
of physical therapy, I can tell you what they do.
But in terms of scope of practice.
Which is useless.
Yes.
Can you elaborate, perhaps?
Ryan, from your negotiations, what you understand the current scope of practice of a physical therapist?
Well, actually, when I heard the question, I was quickly going to my phone to pull up their B&P code section. I think it's 2570, which actually outlines their scope of practice. I'm not sure if the attorneys have it in front of them.
We do not.
But it actually specifically says that they shall not make a diagnosis of a disease. That's in their scope. So they can't diagnose. But a disease could be a malformation you can have a sore muscle, it's a disease. I mean, you can have a torn ligament, it's a disease. I mean, it's a wide definition. So
You can't diagnose, you can't treat something you don't.
that's correct, and that's the argument we're making all along.
Right.
So there's an inherent contradiction within the language of the bill, which is direct access to a service that they're currently prohibited from providing, that is treatment without a diagnosis.
That's correct. They cannot make a medical diagnosis. They can feel and go, I think it's this, but they can't perform an X-ray. They can't do an MRI. They can't do what's needed to do to really get to the crux of the matter. They can make assumptions.
They can make it feel better.
True.
That's all. It's about touchy-feely.
That's true. And you can, I know, if you, I'm sorry.
I was being serious. It's
No,
about
I understand.
touchy-feely. It's not about invasive. It's not about, diagnostics kind of stuff. It's about ice and heat and.
Can I say one thing, if I don't mind, or if you don't mind? Sorry.
No, Mr. Spencer, as long as I get you a new pen.
I'll take this one.
Good idea. It's free.
There was an example that an orthopedic surgeon used at our last committee hearing. This was on the original SB 924, and it was regarding an individual he treated who was complaining about, I believe it was some back pain. And after one treatment, after one visit, he thought, you know what, there might be something else here. He thought it was just a sore muscle. Well, they did an MRI and found out it was a tumor, and it was cancerous. And so there are some examples that exist out there that you can kind of massage it away, make it feel better for a period of time, but then the cancer
tell me that,
metastasizes.
please.
So that's something that, we take that very seriously, and we understand the politics behind this. We understand that there is, in the real world, there is some view that they do want to look at, find some way to improve access, but it can't be at the expense of the patient's health, and that's something we need to protect.
Yeah, I can say the same thing about my operation. I had a muscle hurt around my left hand. So I went to a physical therapist for quite a while. And not
Without
really
going to a
improved
doctor
it.
first, huh?
No, I didn't, but I was paying for it, so I didn't, eventually I
So they were
went to the
practicing
doctor.
outside their scope.
Yeah.
My point
Eventually-
exactly, though.
Yeah, eventually I went to the doctor, turned out to be, I have a condition with my central nerve. I had to have this operation, put the
I remember.
titanium plates, and I guess some of you have seen me, no, I think only a couple of you have seen me in that position. It was a serious matter. If I didn't went to the doctor eventually, I would have been crippled. And that was a case, I feel a physician's oversight is, diagnose is very important.
Sure, yeah.
So I want to only suggest to you, Ms. Chang, that you made my point exactly. You could have walked into a physical therapist's office, and you had the presence of mind to realize it was more important, and you went to a doctor, and that's what should happen.
Right, yeah.
I'm sorry, but it was still out of the scope of practice of the physical therapist.
To do what?
Treat her, yeah.
To treat her.
The scope of practice actually says you can evaluate and consult. You can see a physical therapist before you see a physician. He can't treat you without diagnosis.
Right.
Okay, so we have a motion on the table. Ms. Chang, thank you very much. All those, and we've had public comment, and we've had comment around the board, around the table. Everyone in favor of the motion, please say aye.
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 Opposed?
Abstain.
Abstain. I'm going to abstain as well.
Okay, good.
So now, Ms. Simoes, would you continue, please?
And that actually concludes my legislative presentation.
Oh, come on, you're just getting us going.
I
Saving the
don't
best
go.
for last.
Unless anyone has questions.
Can I have one for her? I have a question for something else.
Sure.
Julie was talking about the National Data Bank. I somehow has an impression if we want to look into it every 2 years, we may need legislation. Was that correct, or Nanita, or
Querying.
referring into the national?
You would have to put that under items for future agendas.
Okay,
And-
all right, okay, all right.
Okay. So let me find my place. 8. Moving on. Where are we?
Is that it?
Oh, I'm sorry, B, 101B, regulatory action.
23B, the status of, Mr. Shunky, please come forward.
Thank you. I know you're running very late, so I'll make it very
Oh, I
quick.
think we're running pretty okay. I'm not sure. Are we running late? Oh, sorry.
The freeways are crowded already. I come before you to bring you 3 bits of good news. Unfortunately, Mr. Warden and Ms. Threadgill have already spoiled some of my excitement. Number one, the polysomnography program regs have been approved by the Office of Administrative Law and filed with the Secretary of State. The disciplinary guideline regs have been approved and filed with the Secretary of State. And here I'm also going to give a shout out to Susan Cady, who did a tremendous job over the last couple of years of bringing this 3-year project to a close. Without her dedication, you would not have the newest edition of the disciplinary guidelines available to you. So I'm very thankful and appreciative of Ms. Cady's work on that. Lastly, an issue which has been very important to this board and to the administration, the implementation of regs for sponsored free healthcare events. This reg file has been pending at the Department of Finance for almost 2.5 months, and we've been pushing and begging and pleading. And in anticipation of your meeting this week, we were informed yesterday that the reg package finally has been approved. So when we get back to the office next week, we will finish up the file, and I'm hoping within 2 weeks, if not even within a week, that we'll be able to submit this file in its final format to the Office of Administrative Law. I do anticipate a thorough review by them and identification of some issues by them. We're the first board that has been able to move forward with this reg package. This is a new programming concept. It's never been reviewed. So although with the assistance of counsel, we think we've got a pretty good package going forward, I think we'll be the guinea pigs for the Office of Administrative Law in their review. But once our reg package is approved, it will provide better guidance to the other boards, many of which are currently moving forward with their own reg package, and it will be an asset to them for us to have gone through the indoctrination process. Any questions?
Any questions for anyone? Thank you very, very much for that good news. Much appreciated. Moving on to number 24. Ms. Scurry, you're on the agenda, please.
Well, to follow up with what Mr. Schenke said, in 2011, a bill took effect that allowed sponsored healthcare events to use the services of individuals who are licensed in another state, although not licensed in California. It provides a mechanism for registering those sponsoring healthcare entities, as well as vetting the qualifications of the licensees from out of state who would be participating. Given that these events usually include multiple types of healthcare providers, dentists, optometrists, physicians, nurses, etc., the board in its regulations, the ones that haven't made it yet through OAL, but have made it through the rest of the process, excuse me, as part of the regulation, it provides that the board may delegate to the Department of Consumer Affairs the authority to register those healthcare entities, not the providers, just the entities. And the reason for that inclusion in the regulation was that it made more sense to have one centralized place say yes or no to registering an entity, so you don't get contradictory responses from different boards, so that one board doesn't say no and another board says yes.
What's an example of an entity?
There's that big, I don't know the name of the entity. In
Like Care Now, Care
Now. They're usually nonprofit entities that put on the health fairs.
Okay.
More than a health fair, but a screening program.
So it's the sponsor of the event.
They're the sponsor,
Okay.
and they would have to register with someone. And the proposal in the regulations, or the authority in the regulations that you've adopted, is to permit you to delegate that authority to the Department of Consumer Affairs so that there's uniformity and consistency in the registration of those entities. So we have in front of you for your consideration a resolution that would in fact, upon approval of the regulations, or the regulations taking effect, make that delegation to the Department of Consumer Affairs to review and register sponsoring entities.
So may I have a motion to approve this process, to delegate, you understand what it is, right? To delegate authority. Thank you. Dr. Levine, second? Second. Thank you, Dr. Bishop. Discussion on the motion? Any public comment? Oh, Dr. Ganade?
Just curious, who is going to regulate the providers? The other states where they have licenses?
No, we regulate the license here in California. They have to be licensed in California. This is only to regulate the entity that's going to do the health fair.
No, but they have.
You're asking about a broader question, not related to the resolution.
No, actually, so if the regulation is by this DCA, I can understand that, but the providers will be California licensed?
The providers who are not California licenses must go through an approval process with the board, the medical board.
We have the regulations that we mentioned earlier, and those were approved by the board, and there's a whole process that a provider must go through, including fingerprinting, in order to provide services at one of these events.
So we're still involved on the provider side?
Yes, absolutely, absolutely. This is just for the sponsoring entity. And in fact, there is a sort of a feedback loop to the state of licensure, should there be a problem in the regulations.
So any public comment, any other comment? All those in favor of the motion, please say aye.
Aye.
Any opposed? Okay, thank you, Ms. Scurry. Now, Mr. Hepler, would you go on to item number 25, please?
Madam President, I'm not sure the board wants to hear from me, but
Well, I'm sure they don't want to hear from me, so let's,
Here we go. For the benefit of our new members, statutes are passed by the legislature. The board is responsible for regulations. Regulations have a specific purpose in the law. They implement, make specific, or interpret statutes. The statute in question here is AB 1267, which essentially requires the board to place on an active status a physician's medical license, also called a certificate, when he or she is incarcerated following the conviction of a misdemeanor. The issue is, when that physician is no longer incarcerated, what are the mechanisms that he or she could provide notice to the board that, hey, I'm no longer incarcerated, and as required by various other sections of the Business Professions Code, what would the board display during his period of incarceration, his license status? So the proposed language on page 113 attempts to answer those two questions. So the way that the physician, after release from incarceration, would tell us is he or she would provide us with a certified copy of release issued by the local jurisdiction in which he was incarcerated, and licensee would provide that to us by mail or personal service at their option. You can't just call up and say, hey, I'm out. We would like a little bit more, something more, a little bit definitive than that. And whenever we place the physician's display the status on our website, it would say, and for a physician so incarcerated, it would say inactive license, misdemeanor conviction, licensee was convicted of a misdemeanor and is currently incarcerated, no practice is permitted. And much like we talked about midwifery, as far as the procedural thing, what staff is recommending this would be set for regulatory hearing at the next board meeting, meaning that we would prepare a statement of reasons and a notice and have a public comment period, a written public comment period, and also take public comment at that board meeting. And then at the conclusion of that, the board could decide whether to proceed with the regulations. I'd be happy to answer any questions you may have.
This is after conviction and incarceration, not arrest.
Correct. This follows conviction of a misdemeanor, not arrest.
I make the motion.
It follows incarceration, not just arrest and conviction. Incarceration.
Just one clarification. Suppose.
So wait, before you suppose, could I have a motion to approve?
I did.
You did, and I have a second?
Yes.
I apologize, where was I?
Well, no, that's.
I don't know.
Just happened.
Okay, Dr. Dussault,
I was
please continue,
wondering,
I apologize.
Kurt, if, let's say that the person does send the licensee send it by mail or personal services. So and he's successful in getting his license back. Do we go back to the website? And
Yes, the display would then be corrected to reflect his actual status. If you look in the conditions of the bill, it says within 5 days of receiving that notice, we have to sort of place his or her license back to its prior or appropriate status.
Yeah, and I might have missed it. I didn't see it in your the proposed regulation language.
Yes, we would be obligated to correct or refresh the status on the website.
Just the same as any time someone's license status changes for any other reason, and the board receives notification of that change, then it gets changed on the website.
Okay.
I'm
Thank
sorry,
you.
and so then this disappears? It's not
It doesn't stay with you.
discoverable?
I'm
Right.
sorry?
Discoverable, or?
It doesn't stay on the website is the question.
No, it does not stay on the website. No, correct.
Any other questions? Any public comment? All those in favor of the motion, please say aye.
Aye.
Any opposed? Okay, then we're going to move on to
It stays in the public's mind.
29. Going to move to number
We'll have to work with it
29.
a little bit.
Discussion and consideration of the proposed chiropractic regulation related to the use of lasers and comments thereof. Mr. Hepler and Ms. Scurry, would you present on this, please?
Well, fresh off my success on that one, I guess I'll go to the well one more time.
You're wearing a stand. Is that the point?
Actually, this concept was discussed probably sufficiently when Ms. Smoes talked about SB 352. And when she did that, we talked about the fact that the chiropractic board is a board created by initiative, unlike the medical board, which is created by statute. And the chiropractic board has promulgated or attempted to promulgate a regulation regarding the use of lasers. And they did meet with staff of the medical board, and we offered some comments about what they wanted to do. And that comment is on page 152.4, which we wanted to add, if the underlined section, the second paragraph, nothing in this section shall be construed to authorize the use of a laser by a chiropractor outside the scope of practice. This includes, but is not limited to, laser ablation, and then our underlined addition, cosmetic procedures, and their continual language, surgical procedure, and so on. I think I can fairly synthesize Ms. Smo's comments or an experience at the Chiro board where this our suggestion was not well received. And in fact, the Chiro board did ask for a definition of what cosmetic meant. So we answered that question in materials starting at 152.5 of your packet. We looked at the PDR and what we thought cosmetic meant. And so the issue is the board wrote a letter, like I suggested, to the chiropractic board suggesting that our amendment be taken. It was not. The chiropractic board, through the regulatory process, has now opened for true public comment. Just like I spoke of in the last item when they're going to solicit public comment, we will solicit public comment on our regulatory process. They are doing that on this regulation. So the motion would be that the board be allowed, or be authorized to comment formally by letter during the chiropractic process, once again requesting and setting the reasons why we want that amendment to insert the words cosmetic procedures for essentially the prohibited use of laser. And so that, I'll be more than happy to answer any questions you may have.
So, do you want a motion to the effect to,
Yes.
So moved.
Second.
boy, we have a lot of people, maybe we should have had our meeting at their meeting, and we could have really given them what for.
Everybody sick on here.
Okay, so do I have any comments from the public? Ryan Spencer, did I mispronounce your name prior? Did I call you other things? But see, this time I can actually read your name. It's very clear. So I apologize for whatever else I called you prior to. You declined to speak. Let that be noted in the record. Okay, Dr. Bishop.
Fully support this, but I wanted to ask a question of my colleagues and anybody else. I was not familiar with the relationship between laser treatment and anaphylactic reaction. I mean, I see and treat anaphylactic reactions in response to drugs, different medications, different substances. I'm not sure what the relationship is, just for my information.
It can be to cold as well, I think. Cold as well?
But I mean, when you use a laser on the skin, will that release some substance which causes an anaphylactic reaction? I'm not familiar with
No, I believe there's, Ms. Smoes, if I'm not mistaken, wasn't there a case where either the treatment or something triggered a case of anaphylactic shock?
This was brought up because a constituent or someone in Senator Huff's district had seen advertisements where chiropractors were advertising to treat allergies with the use of cold lasers, including like peanut allergies, and that's where the anaphylactic comes in. And so there was a case where someone, and this is according to committee testimony, where someone got this treatment from a chiropractor for a cold laser for their allergy. And then they ate C's candy, and it didn't work. So,
but the candy didn't work?
Okay.
No, the laser treatment did not work.
It just doesn't work, obviously.
It doesn't work, and so what Senator Huff wants to make clear that it's clear that they won't be treating for this reason, and that they won't be advertising that they can treat.
Any allergies because it doesn't work. You're right. Okay.
The only way you can get a reaction probably is like anaphylaxis is if there is a topical thing they apply. They're allergic and they can get anaphylaxis.
My understanding from the last time I was in Sacramento watching television, which is something was to watch that, in fact, that there is some kind of an allergic reaction from cold, from the physical of cold.
There can be a histamine release. It's colder to carry it. That's
Right.
well known.
Yeah, and 1 in 2,000 people can have that.
It's not an anaphylactic reaction, but it's a cold. You get that from cold shower.
Anaphylactic shock, I thought was when you go into a heart attack, but no?
I wasn't aware of that, but.
I don't know, I'm not a doctor. I don't,
You can induce an
asthma attack, right.
Cold laser is actually not cold. It's not, it means that it doesn't burn, it's not a hot laser. So
Okay.
it doesn't
I don't need any laser education. Trust me, it's not going to happen. But thank you. Dr. Diego.
I'm sorry, real quick question. So are they concerned that we underscored cosmetic surgery? No, they're not? I mean, was that an issue for the chiropractic board, right? I mean, obviously, we don't want them practicing cosmetic surgery. Was there a concern, or did they say, sure, no problem, that's not what we were intending to do?
I would have to defer to Ms. Mose about what happened at the meeting. I don't know.
Dr. Diego, you're really she's good today.
At the hearing, they suggested that they already knew that cosmetic procedures weren't in the chiropractic scope. I requested that they specifically add them, like they had added other things like surgical procedures, laser ablation. They then suggested that cosmetic procedures might be too broad of a term and that the regs may be returned by Office of Administrative Law. Because of that, we offered some suggested definitions, and they basically didn't think that was needed and told me to take that back to my board, which is why it's on the agenda.
It's not funny, I'm sure it's very serious, but thank you. Okay, all those in favor of the motion, please say aye. Oh, you wanted to speak?
No, I'm ready to vote.
All those in favor of the motion, please say aye.
Aye.
Any opposed, please say nay. Thank you, it's done. Thank you, Mr. Hepler. Now we're going to go back to number 28. Okay, so it's a little bit after 3. We have a discussion on the consideration of the final draft of the strategic plan. The option is to continue it for the next board meeting, or to continue it and do it now. What do you want? So what am I asking them?
You need to verify that people can stay.
Oh, can everyone stay to participate? What time?
I don't know if we can get a later flight, because, I mean, not to get my current flight, if staff can help me and see when the next flight is.
Why don't we take a little break?
I'd have to ask Tim's help to see if I can book
We
on a
think
later
it may
flight.
pass 5 o'clock.
Oh, no. Not past 5 o'clock, an hour. Do you think an hour, 45 minutes, a half hour? Depends on how much everyone has questions about.
Oh.
Oh, listen.
Yeah, Mike.
This strategic plan, I don't know if I really want to spend least amount of time on an important issue like that.
You need to use your mic, Dr. Ganadev.
If it is strategic plan, I'm sorry, it's something you need to spend a significant amount of time rather than try to push it through. I haven't been involved before, but usually that's what, in any corporation and any board, they spend a significant amount of time on the strategic plan, even.
So let me interrupt you, only to interrupt you, not meaning to interrupt you, but let me interrupt you. We have spent a significant amount of time, so let me hear from Ms. Kirchmeier what kind of time frame she's speaking about, because be assured of the fact that it's taken hours. This is not something we've taken lightly. But you're absolutely right, it's very important and goes to the heart of the organization.
And it's really up to the members at this point. I have gone through with the edits from the subcommittee. It's in your packet. You will notice that they're in red. the edits that have been made.
Wait, what page? Give us a page
I'm
number.
sorry, on page 117, beginning on page 117.
Okay, let's all get to 117 and take a look at it and see what we,
And then it's continuing on through page 151 with edits that have been made by the subcommittee. And the edits that are in here are either minor or ones that when we looked at clarified those certain objectives. In addition, the only other thing we would need to go through, if everybody has reviewed those edits and they're okay with them, is that on page 114, and I'll ask Mr. Einer to hand out, I have the handout so you don't have to keep going back and forth in your packet, you can just turn to page 117. But on page 114, there are 2, 4, 6, 8, there are 8 items that need discussion by the board and decisions that are made on those certain objectives. So unless there are any other edits, that's what this would conclude, and then we could make one final motion at the end to approve the edits that are in the document, as well as any decisions that are made on those 8 objectives. That would be up to the board at this point.
so what is the will of the board?
I felt something as important as this, we shouldn't be crunched for time. I just thinking, just like one little discussion took half an hour, and I thought maybe we should just put it on the first agenda next time and give it ample time to make sure we do it right.
Ms. Kirchmeier?
I do want to say that this draft that is in front of you has been reviewed twice and approved twice by you. The edits that are now in there are basically the final review of the subcommittee and your edits from the last board meeting. So
I think the issue is only the discussion items, which is 1, 2, 3, 4 items. 5, 7 items, whether they should be changed, the priority should be changed. So if everyone is willing to take a half an hour, let's see if we can do it in a half an hour, and if not, I agree
I
with Ms.
think
Chang. We should
that this
put it
is this is nothing new to the majority of the board. I mean, we've been at this for 6 months, I think, almost. I might be exaggerating a month or two, but 4. So I think 30 minutes or so. See how far we get. Yeah, I'll be plenty enough.
Hold you to it.
Okay, let's just try. I understand what your objection is, and I agree with you. So let's try the time, and if it doesn't work, it doesn't work, and we'll stop. Mr. Hepler has a question for Ms. Kirchmeier.
Ms. Kirkmeyer, I just want to understand. So we have the questions on the new agenda item 19. How many questions? Plus, are you suggesting that we have to go through and individually go through each of one of these, what the red is, and get?
They're all okay.
Okay, gotcha. Thank you.
No.
They're just the 8 objectives, I think, is what's before us.
Right. And then the edits that are in red that were submitted in your packet.
Yes.
And those are just minor edits.
Sure.
Those are policy.
Sure.
Okay?
So let's see
So
how
let's
far.
go.
Okay. The first one is on objective 1.1. This objective is scheduled to take about 18 months for completion if you look at it on page 117. The priority of this objective may necessitate that we do this quicker than 18 months. But if so, we have to know that the board has the resources to complete this earlier than identified. So at this point, it would be moving up the time frame on this agenda item. And I'm going to actually take that in conjunction with the next one that states that the objective seems to be a prerequisite. 1.2 on page 118 would be a prerequisite of objective 1.1. They both have to do with the CME structure and maintaining that physicians remain current. And so we would reverse 1.1 and 1.2. Not that the order is all that important, but it may just be better placed in the plan. So we would put 1.2 as 1.1, 1.1 as 1.2, and then if the board necessitated moving the timeframes up from 18 months. If I could get a motion to change that to possibly a year's time, and then that would be to Ms. Whitney and I to go back and look at and make sure that we do have the resources to change.
You may have a motion. Second.
So moved.
Okay.
I absolutely agree with switching the order.
Okay.
Absolutely.
I do think that 1.1 actually has a longer time frame required because some of the stuff in there, for example, tracking the FSMB
Right.
maintenance of licensure, we're not going to have any information.
No, it's it should be a pilot project or
In
something.
a year. So I'm not sure the need to Move up.
Change the time? Okay,
the time.
and that, we would be fine with that.
Okay.
So we
Next
would
one?
just go with changing the order, and that would then be the motion that we would entertain.
So everyone in favor of changing the order, say aye.
Aye.
Opposed? Okay, let's continue the second.
Okay.
1.4 now.
1.4, which is on page 120. This objective states to establish a committee and task force. However, should this be under the purview of the licensing committee or maybe a subcommittee of it? Right now, we've identified that we would establish a new one, and based on the information that we received yesterday, possibly we would just want to include this in the licensing committee. So I would just be amending the first one from a task force to the licensing committee and possibly a subcommittee.
So moved.
Second.
Any public comment? Any comment from the board? All those in favor of the motion, say aye.
Aye.
Okay.
Okay, objective 1.6 and 2.5.
Yes, on page 122, and this is really talking about conducting a literature review and internal study of the performance of physicians, and then 2.5, sorry, let me just get there real quick. 2.5 is to study disciplinary cases to identify trends or issues that may signal dangerous practices. These are both identified as priority C. The question is, should that be moved up to priority B?
I want to speak to that directly. The main focus of this board is enforcement and licensing and the appropriate outcomes as opportunities. I apologize, Dr. Summonson, but I'm...
We support you.
So you're suggesting?
Oh,
that move up
absolutely,
B?
absolutely.
Ready for a motion?
Yeah,
So moved.
Second.
thank you. So that's 1.6 and 2.5 have now been moved up to a level of a B.
B.
I don't think we actually voted, did we?
We voted, everybody voted yes to do it. So the next objective is 2.8.
Maybe,
We had the motion, but we could,
We didn't vote?
we did, but we
All in favor?
Aye.
All opposed? I'm sorry, I really thought we voted.
That's
Okay, so now 2.8, add a new activity. Ms. Kirchmeier?
yes, this would be, the request was to add a new activity to communicate to all interested parties the scope of the medical board's authority and what is outside of the board's authority in order to avoid confusion.
Good.
This would be just adding a bullet point in, and it would be basically just identification on the bill. We could probably pull this from the implementation plan.
Yeah, we can always send out a press release too, it's not too hard.
Yeah.
Okay, so motion on 2.8 to add a new activity to inform, clarify the board's responsibility to regulate outpatient surgery centers. No motion? Yes motion? Oh, Second? Second. Public comment? Any comment from the members? All those in favor?
Aye.
Aye, okay. Number 3.6,
3.6.
add another activity.
Again, on page 137. Yes, this is again adding another one to the first activity where it says evaluate how the current license or the current newsletter is being utilized by licensees, what is useful and what is not. And it would add another activity or more to the first one to explain how the board is going to evaluate how the newsletter is being utilized.
Well, wait, I've got a different, expand the newsletter to border better.
But the first bullet under there. So 3.6 is expand the newsletter, and the first bullet there is evaluate how it is being utilized. So it would just be expanding that to include that we will be using surveys and focus groups, et cetera, in that first bullet there.
I'm not clear on what you're saying.
Yeah, that's amended.
Adding language.
clarifying.
I'm
Just
just
clarifying, yeah.
Adding
amending
language.
and adding
It's
some
fine to add
to.
So evaluate through focus groups, survey instruments, et cetera, how the current newsletter is being utilized by licensees. Is that
Would
Yes.
just
Is that
be
what you're
an edit.
suggesting?
Yes, that's my
Yeah,
suggestion.
that's a good suggestion.
I'll defer. Okay, a motion, please?
motion.
Second.
Any public comment? Any comment from the members? All those in favor?
Aye.
Aye.
Any opposed? Any abstentions? Okay, next one is 5.4.
The next one, 5.4, which is on page 147. This objective is the one that we went through yesterday with all of the committees to identify whether we need them or not. This is actually one that was recommended that we change it from an annual review to every other year. So it would be every 2 years we would evaluate it. And actually, I would like to make another recommendation on here. One item that was pointed out by one of the members is that when we establish a committee, that we also put a sunset date on that committee from here on moving forward. So I'm not sure if we would include that in here, but I think that would be a bullet we could also put in here when we identify committees, that we put a sunset date on them.
I'll ask for a motion, and I'll call on Dr. Ganadev, because you've got your hands up, but a motion first to approve it?
Motion.
Second, yeah.
Okay, Dr. Ganadev?
I just support the recommendation that we should have a sunset anytime we create a committee, rather than,
Microphone.
otherwise.
Use your microphone,
I'm
please. They
sorry.
can't, you're too soft-spoken.
Anytime we create a committee, we should have a sunset for the committee, so that then we can evaluate whether to continue, change, what we need to do. Otherwise, you'll just pile up on the committees and put the staff through, and the committees probably, their function goes away.
Any other discussion? Okay. All those in favor? Any public comment? I'm sorry, any public comment? All those in favor, please say aye.
Aye.
Any opposed? Okay, thank you very much. That passes 6.2.
And then the last one is on 6.2, and this would be looking at the first activity. Should it be changed to identify the role the medical board and its licensees can and should play in promoting public health and addressing the upstream social and environmental causes of illness and disease, and refocusing the healthcare system on prevention of health and prevention and health promotion?
Where did this come from?
No.
Well, let's have a motion, we can talk about it. Can I have a motion to approve this?
Motion.
Second?
Second.
So where did this come from? What was
This
the
came from
point?
the subcommittee. It was
Did?
a recommendation.
I would like you to consider tabling at least this one and approving the entire plan, with the exception of this one, because you did send this item in terms of the Access to Care Committee back to be re-examined, and so I'd lift it out of here and let it fall in later.
Okay.
That,
So,
That's a great idea.
well, that means we withdraw the motion.
Withdraw the motion.
I second.
Second, okay,
Yeah.
all those in favor? Oh, any public comment? Any other comment? Okay, all those in favor?
I think we need a new motion to eliminate
Oh.
6.2.
No, the motion to table.
Oh, you're right. We have to vote on the motion to withdraw.
We have to vote on the motion to, no?
No, motion's withdrawn.
Oh, we don't have to
The
vote.
motion was withdrawn, we don't have a motion. We need-
Okay, may I have a new motion, please? To table 6.2,
Just to take it out.
or to just take it out for now?
So moved.
Okay, second?
Second.
Any public comment? All those in favor, please say aye.
Aye.
Opposed? Okay, thank you.
and we would just like one confirmation that all of you are okay with the edits. Did I see everybody? Yes. No issue with the edits. Okay, thank you.
I think
Okay.
that was shorter than a half hour.
Yes, it was. Okay, now we're going to go for agenda items for the, Ms. Chang. Ms. Chang, you've got some.
Oh, yes. The National Data Bank, and I thought maybe we can look into it and then see what's the requirement and what's the cost, and make sure.
So could you direct staff to get this information and bring it forward for the next meeting to see if feasibility, as was recommended, that we verify the data bank every 2 years?
Yes.
Thank you. We'll hear back from the Woodford Advisory Council and staff regarding the workshop on physician supervision and tests, drugs and devices. We'll hear back from the council regarding the candidates who filled the 2 vacant positions of the council. We'll possibly have 1 regulatory hearing on the scope of practice for physician assistants. We have approved a pain management summit, so we will need to update on the progress we've made to co-host that with the State Board of Pharmacy, and we have tabled the Access to Care Committee and its new shape and format, and the staff is to report back on this issue and research the May meeting. We will have a regulatory hearing on the inactive status for misdemeanor conviction. Is there any other items? If there aren't any currently, if you would just get back to Ms. Whitney.
I have a couple. Okay. Dr. Ganadev has agreed to provide a presentation on the definition and use of hospitalists in medical centers. Staff is examining the need to revise some of the information on the website regarding medical marijuana. Thus, this may be ready for a topic for discussion in May. We hope to have data finalized on the time it takes other states to process physician applications. And if you'll recall, we have the Federation of State Medical Boards coming to make a presentation on their annual meeting that would be held in April. So they will be here for an update.
That was maintenance of licensure. Wasn't that what they were?
That's one of the things that will happen at their annual meeting. It's also their centennial meeting, so they're providing an update on all of the other things that they discussed, including a number of the reports that I happened to mention.
Okay, so I would ask the board members, and if there are any issues that you would like discussed at the May meeting, to please let our executive director know, and I will entertain a motion to adjourn.
So moved.
Thank you very much for your attention. Thanks.
Well, it's very nice working with you. I hope I don't betray your first initial impression of me of being even-minded.